Thank you all for joining us. It's my great pleasure to introduce Dr. Rebecca Baker, who is going to kick off this meeting. Dr. Baker is the director of the NIH HEAL Initiative, which stands for Helping End Addiction Long Term, in the Office of the Director at the NIH. Dr. Baker helped develop the initiative and leads the coordination of NIH HEAL Initiative programmatic activities between the NIH Office of the Director and relevant institutes and centers. She also provides expert advice to and represents the NIH Director on initiative-related activities, including interagency efforts in pain and opioid research and policy. Prior to this position, Dr. Baker served as special assistant to the NIH Director and the Principal Deputy Director, working directly with NIH leadership to analyze complex biomedical research policy issues and assist in the development of new science and policy initiatives. She earned her PhD from University of Pennsylvania and her bachelor's degree from Cornell University. Thank you, Dr. Baker, for joining us.
Thank you, Dr. Longchamp, for the introduction and the opportunity to speak today. And thank you to the many organizers and teams who helped put this together. It's a really exciting new direction for HEAL to take into consideration, and we're pleased to host today's meeting. So next slide, please. Here is what we see that we're up against: the national crisis of opioid misuse, addiction, and overdose. Across the country, Americans continue to die from overdoses related to drugs, especially opioids, over 100 Americans every day. And although many policy and research efforts have been targeted towards this crisis, and we began to see signs of flattening in 2019, I think COVID, just like everything else, is creating new challenges. And so we are unfortunately seeing signs that overdoses may be going back up. So it's NIH's responsibility and mission to bring together all of our stakeholders, all of our researchers, leveraging all of our resources to really come up with scientific solutions to this crisis. Next slide, please. And what we recognize is that we cannot take on the opioid crisis without understanding another crisis, which is the extremely high levels of unmanaged and poorly understood pain in America. So 50 million Americans experience chronic pain. About half of them experience pain every day. And about 20 million experience such high impact chronic pain that they're unable to carry out responsibilities at work, family, other activities that give their lives important meaning. And so what we in HEAL are working to do is really tackle these two urgent and vast crises through biomedical research, recognizing that services and partners across government are also working hard, but in the research community, we have a role to play as well. So next slide, please. And so because of the urgency and magnitude of this crisis, we have a significant research effort underway to match it. That's the HEAL Initiative, Helping to End Addiction Long Term. We were fortunate to receive from the Congress $500 million a year to direct towards research in these areas, and turned that opportunity in the past year or two. HEAL launched in 2018 into 25 different research projects underway already. We worked very hard to bring together a coalition of researchers, not just experienced researchers in pain or substance use disorder, but because pain touches so many parts of the body and so many different disease areas and disciplines, to pull together resources across the NIH and research communities. So we have 20 different of the 27 institutes and centers at the NIH, 20 of them are collaborating on HEAL studies, and I'm sure you saw that reflected in the wide range of participation of different institutes and centers involved in planning today's meeting. We have a trans NIH governance structure, multiple institute and center directors advising the NIH director on how to make decisions about HEAL research. We're also very aware that we can't take these research findings and translate them into meaningful changes for patients without partnerships across government with our federal partners, partnerships with communities, caregivers, patients' families, as well as colleagues in the private sector. So partnerships are a significant component of our effort. And because we have so many research needs and so many disciplines and sectors involved, the array of research involved in HEAL is wide. So we have prevention research, understanding what makes folks vulnerable to developing chronic pain or developing a substance use disorder. We have very basic and translational research working to define novel targets for analgesic medications and accelerate the development of new candidates towards treatments for our patients. We have a significant number of clinical trials, studies both to treat specific pain conditions as well as treating opioid use disorder and reversing overdose. And then we have a significant area of research and implementation science, because for many of these conditions and many of these indications, we have effective interventions that we know work, but the challenge is getting them into the community and getting them taken up and working well in real world settings. And so NCCIH and members of this group have really lent their expertise to HEAL in order to bring about these needed changes in practice. But in addition to all of these, we're also continuing to look for innovative approaches, trying to understand the problem in new ways, recognizing that we've had some successes, and over the years, many experts have worked very hard on these issues. But in order to provide durable solutions, we may need to turn over some more stones and come up with some new innovative approaches to understanding and treating pain and addiction. So next slide, please. Here is how we organize these many research efforts towards two overarching goals. First, enhancing pain management, and second, improving treatments for opioid misuse and addiction. Within these, we have 6 research focus areas, and I know that the leaders of many of these will participate over the course of the next 2 days in this meeting. In the area of pain management, we have both preclinical and clinical research areas. And then in the area of improving treatments for opioid misuse and addiction, we have research on novel medication options, research on infants and children, as well as research on new prevention and treatment strategies, understanding the role of sleep, mental health conditions contributing to the development of opioid use disorder, as well as translating research into practice, working in the specific settings where people come seeking treatment, criminal justice settings, primary care, really translating the findings of the rest of the HEAL research community into practice in these places where patients need them most. So next slide, please. I'll now tell you about a few of these that might be relevant for the coming meeting. In the area of enhanced outcomes for affected newborns, this is a really devastating aspect of the crisis. We have infants born every day dependent on opioids because they were exposed to opioids in utero. And we have a number of studies planned and underway to help address the challenges these infants face. The Eat, Sleep, Console study, part of the Act Now program, is understanding specifically non-pharmacological assessment. But then we also have research underway, both trying to determine the best way to treat using methadone or morphine these infants, as well as studying their long-term effects, both in the short term, but then also through the Healthy Brain and Child Development, or Healthy BCD study, over time using a lot of neuroimaging and other approaches. And I'm pleased to say that the ACT Now study has launched, and it is now recruiting infant participants in 20 states across the country. Next slide, please. We're also, and this has been a theme from HEAL starting at the very beginning, seeking to better understand and provide flexible and user-friendly options for people with substance use disorder, with opioid use disorder already. So we have 3 FDA-approved medications, methadone, buprenorphine, and naltrexone for the treatment of opioid use disorder, but they don't work for everyone, and there are aspects of the addiction cycle, such as craving and withdrawal, that may not be addressed by these medications. So coming up with new candidates, and we have a lot of research and a lot of research progress underway in these areas, building upon a lot of work that the National Institute on Drug Abuse has carried out over the past years and decades. Next slide, please. We have, and then we have a number of other research focus areas and research underway in the addiction space. I'll now move on to pain in the preclinical space, and I know that Dr. Michael Oshinsky, one of the co-chairs of the preclinical and translational pain focus area, will be taking part in the meeting later today, so you'll hear from him directly. But we have underway a really diverse and exciting set of studies to increase the shots on goal we have for new treatments for pain and considering different pain conditions. So that includes discovery and validation of new targets, working on devices, because devices can be effective for treating pain, really working with investigators to quickly move a promising candidate into a treatment through translational efforts, and we have some exciting progress in that area. And then working on the pipeline, coming up with screening platforms and models to advance the development of novel drugs, small molecules, and other treatments. So we have a number of studies, a number of investigators working hard on this, and we also have new funding opportunities coming through. So stay tuned for those. Next slide, please. In the clinical research area, and I know we also have some of the leaders in this area taking part in today's meeting, we have research underway trying to develop biomarkers, specifically test novel candidates. We have research programs focused specifically on some certain pain conditions, such as back pain, where we are working to develop a dynamic model that will predict individual responses to treatment, but then also a number of programs that are kind of agnostic to the specific disease area, although they will test both using comparative effectiveness research as well as pragmatic and implementation studies, approaches to treat specific pain conditions in specific settings. So a lot of research underway in the clinical area that is just getting started and really promising for understanding and treating specific pain conditions and providing the outcomes that patients are seeking for managing their pain. So next slide, please. Then in this, so I just described everything that's underway already. We're planning to make some new awards for HEAL research in some areas that were kind of gaps in our first set of investments. So that really includes understanding how pain and opioid use disorder or opioid dependence can track together and why interventions may be needed for people who experience both, which is very common. Understanding the role of mental health conditions, understanding specific treatment settings or health settings for treatment of pain, and then also understanding and increasing the diversity and equity of the research that we have underway through the HEAL Initiative. So that's basically what we've been up to over the past couple of years and what we have launching now. Next slide, please. We have quite a website where information can be found about specific HEAL programs. We have write-ups of individual studies, but we also have information about important events like this one and opportunities coming down the pike. So I recommend you check out our website. Next slide, please. We also have a significant emphasis, and I hope that today's discussion gets there, on meaningful ways to include patients as partners in our research and really understanding what patients are looking for when they seek treatment for pain and approaches for pain management. We had a terrific workshop about this that you can also find information about, and it's going to be an ongoing effort. So please send us your ideas for how we can do that most meaningfully through the initiative. Next slide, please. We have a number of workshops underway focused on different aspects of the initiative, today's being one of several. So encourage the group to also check out upcoming meetings and opportunities to engage with HEAL. And next slide, please. And of course, funding opportunities. So although we made a large set of investments in 2018, 2019, we're still looking for new ideas, and we're still sending out and publishing funding opportunity announcements. I expect a number of new ones will come out in the coming months, so please continue to follow us and find out what opportunities there may be for your research if you're a researcher. So I'll stop there, and thank you very much to Dr. Longevin and to the organizers, and I look forward to a terrific discussion today.
Well, thank you so much, Dr. Baker. We're very, very grateful for the support of the NIH HEAL Initiative in hosting this workshop, and thank you for starting the day for us. So I will now share my screen. Now, Dr. Baker mentioned that we want to look for some new unturned stones in pain research. And we really hope that this workshop will begin to address one such unturned stone, which is myofascial pain. I also want to thank my colleagues in the 6 different NIH institutes and centers that have contributed to this workshop. National Institute, aside from NCCIH, National Center for Complementary and Integrative Health, National Institute of Biomedical Imaging and Bioengineering, National Institute of Neurological Disorders and Stroke, National Institute of Arthritis and Musculoskeletal Skin Disease, National Institutes of Dental and Craniofacial Research, and the Eunice Kennedy Shriver National Institute of Child Health and Human Development. So you can see very, very broad interest in this topic throughout NIH. And I want to start by giving some perspective on the title of the workshop, including the terms myofascial pain, myofascial tissues, and musculoskeletal pain. Our starting point for this workshop is myofascial pain syndrome, which is currently a clinical diagnosis based on history and physical exam, including the palpation of localized tender nodules in muscles and or associated connective tissues. Now, so far, these abnormalities, which are detected by palpation, have not been documented using objective measurement methods. And so the primary goal of the workshop is to review what methods are currently available or could be developed to quantitatively evaluate myofascial tissues, and could lead to better and basic and clinical research on the pathophysiology and treatment of myofascial pain syndrome. We also hope that the workshop will fill an important gap in musculoskeletal pain research in general for 2 reasons. First, because myofascial tissues have been relatively understudied compared with other musculoskeletal tissues such as bone, cartilage, and intervertebral discs. And second, because a better understanding of myofascial tissues and myofascial pain syndrome may improve our ability to do research on other common musculoskeletal conditions, such as low back pain, for example, or temporomandibular disorder. Now, first, a bit of history. The term myofascial pain syndrome was coined by Dr. Janet Travell in the 1960s. She was the personal physician to President Kennedy, who suffered from severe back pain in addition to other illnesses. And Dr. Travell appears to have been able to help him with this. Later, she teamed up with Dr. David Simmons, who was a physician and also a pre-astronaut. He was one of the first people to fly beyond the atmosphere. He later started a program in physical medicine and rehabilitation at the VA, where he co-authored with Dr. Travell a pair of books containing the first descriptions of myofascial pain syndrome. The syndrome is characterized by the presence of focal, tender, and indurated nodules, or trigger points, that feel firm to palpation compared with surrounding tissues. The syndrome includes an active phase when patients experience spontaneous, local, or radiating pain that limits the range of motion in the affected area. Palpation of the nodules causes tenderness and reproduces the patient's spontaneous pain. Applying strong pressure or needling of the area can result in a twitch response, which can cause immediate but usually temporary pain relief. The syndrome also includes a chronic or latent phase where tender nodules can be found on palpation, but without the spontaneous pain. These diagrams from Travell and Simmons' book illustrate some of the typical locations where trigger points can be found, as well as the areas of local and referred pain. Around the same time, the clinical syndrome of fibromyalgia was being delineated. And this was characterized by a diffuse tenderness to palpation of muscles with frequent comorbidities, including sleep disturbances, depression, and irritable bowel syndrome. There's been an ongoing debate about how much distinction there is between myofascial pain syndrome and fibromyalgia. The main clinical difference between the two appeared to be that the myofascial pain syndrome is found in both males and females approximately equally, and tends to be a focal one with one or a few tender locations, while fibromyalgia affects predominantly females and presents with multiple tender points in multiple areas of the body. And many patients have generalized tenderness anywhere that you can palpate. One interesting possibility is that both syndromes may share some components in both the nervous system and musculoskeletal tissues, with nervous system components being more severe in fibromyalgia and musculoskeletal components being more predominant in myofascial pain syndrome. So far, the central nervous system component of fibromyalgia has received most of the attention. If the two conditions are indeed related, developing better methods to evaluate myofascial tissues may enhance our understanding of not only myofascial pain syndrome, but fibromyalgia as well. It's fair to say that our understanding of myofascial pain syndrome is currently very limited. Prevalence estimates vary widely and have ranged from 30 to 80% of the population, but are entirely based on subjective clinical evaluations. There are no objective biomarkers and little understanding of pathophysiology. Because of this, it is difficult to evaluate the efficacy of available treatments that include physical methods such as applying pressure or stretching, needling with or without injections, ultrasound, transcutaneous nerve stimulation, and anti-inflammatories or analgesics. None of these treatments has been adequately tested in clinical trials. So where do we start? Now, in this workshop, we will start with the clinical observation that there is something in the tissues that can be physically palpated and feels firm when one applies pressure over an affected muscle. So one obvious tissue that could be involved is the muscle itself. But muscles are not isolated from the rest of the body, but rather they are surrounded and invested by layers of connective tissue, including the perimuscular fascia. So it is possible that a tender nodule within perimuscular fascia could be confused with a nodule within the muscle. And of course, because the perimuscular fascia is continuous with the connective tissue that surrounds all the fascicles within the muscle, it is not only possible but actually likely that tender nodules might involve both muscle and connective tissue. Now, one thing is quite clear. It's that the clinical diagnosis of myofascial pain syndrome is distinct from that of an acute soft tissue injury where there's been a substantial, unusual, or excessive force applied to the tissue that results in a tear or sprain with acute inflammation, swelling, pain, and muscle spasm, which is thought to be a reflex to protect the tissue from more tear. Such injuries usually heal within a few days or weeks, depending on the severity of the tissue damage, with gradual resolution of the inflammation and pain. But in some cases, patients go on to develop chronic pain. And there's been a lot of interest in the past few decades in nervous system mechanisms of what we call acute to chronic pain transition. And we have made great progress in understanding important what we call nociplastic mechanisms, including peripheral and central nervous sensitization, reduced descending inhibition, cortical reorganization, and psychological mechanisms such as catastrophizing and fear avoidance. Now, these nociplastic and behavioral mechanisms are relevant to any kind of chronic pain, including myofascial pain. But for this workshop, I want to direct our attention to other mechanisms of pain chronifications that may be particularly relevant to myofascial pain and have received less amount of attention. One very common clinical scenario for a patient with myofascial pain syndrome is someone with a desk job who spends too much time at a computer, on Zoom, sitting with a poor posture, and who has bursts of physical activities, often on the weekend, and gets recurrent pain in the same sort of knots, over and over again, often worse after exercising, but sometimes for no apparent reason. I'm sure that many of you are familiar with this, perhaps yourselves, without necessarily having fibromyalgia. So what could be going on here? Well, we know for sure that a sedentary lifestyle and poor posture can cause certain muscles to become weak and atrophied, either in a shortened or a lengthened position. Under these conditions, what are some possible effects of physical exertion, especially repetitive, that could produce the symptoms of myofascial pain? I will now review 4 different hypotheses that have been proposed in the literature to address this. The first I will call the myogenic hypothesis, and was the initial one put forward by David Simmons, and it proposed a malfunction of the muscle at the level of the muscle end plate. It was hypothesized that leakage of acetylcholine at the end plate resulted in a localized hypercontractile or taut band within a muscle, but data supporting this was very limited. Subsequent hypotheses proposed malfunction at the level of the muscle spindle, again with limited data. The second hypothesis I will term fasciogenic, and proposes that chronic abnormal load distributions within musculoskeletal tissues over time leads to microinjuries, chronic inflammation, scarring, and adhesions within the connective tissues that contribute to the muscle weakness and malfunction. The third, or neurogenic hypothesis, proposes that abnormal tissue loads also can cause chronic inflammation, fibrosis, and scarring around peripheral nerves, causing both sensory and motor dysfunction. This hypothesis dates back to over a century ago when Walter Cannon described hyperreactivity of muscles in response to partial denervation. Another variant of this neurogenic hypothesis is that chronic abnormal tissue loads and repetitive faulty movements can lead to degeneration at the level of the spine with nerve root compression and segmental symptoms. This type of mechanism could also lead to sympathetic dysfunction with segmental vasoconstriction, reduced perfusion, ischemia, and metabolic dysfunction. Finally, another route for amplification of myofascial pain might be behavioral, with pain, distress, and fear avoidance causing further deterioration of movement, posture, and motor control. So I have described 5 hypotheses that have been proposed in the literature, but so far have limited data to support them. In large part, we feel because we do not have good methods to objectively study this condition. So in the first session of this workshop, you will hear more about the current state of the science relevant to these hypotheses, including some animal models that may or may be of relevance to them. Session 1 will also include input from clinicians who diagnose and treat myofascial pain syndrome and who will provide expertise on the clinical presentation from different points of view. The presentations in sessions 2, 3, and 4, and 5 will focus on what's in the gray box, methods for the quantitative evaluation of myofascial tissues. Importantly, the presentations in these sessions will be focusing on measurement methods rather than pain mechanisms, although the discussions are, of course, welcome to bring this up if they wish. Because we are focusing on myofascial tissues, we have not included presentations on brain imaging, for example. We fully recognize that the central nervous system plays an important role in chronic pain, but CNS mechanisms are getting a lot of attention these days. And the goal of this workshop is to fill an important research gap. In session 6, we will zoom back out to put these measurements in the context of musculoskeletal pain pathophysiology. So what kind of measurements will we be talking about? Here we have listed some examples of the measurements that we might hypothesize could be abnormal in myofascial pain syndrome, based on the pathophysiological hypotheses that have been proposed so far. They fall into 4 rough categories. Structural, which includes increased or decreased thickness or volume, disorganized architecture, fibrosis, or Phytae infiltration. Mechanical, such as increased stiffness or reduced tissue mobility. Vascular, immune, or metabolic abnormalities, such as reduced perfusion, ischemia, reduced pH, acute or chronic inflammation, metabolic or mitochondrial dysfunction. And finally, neurophysiological, including EMG abnormalities, sensory or motor nerve dysfunction, or sympathetic dysfunction. The presentation will include some measurements techniques that have already been used to collect some limited data on myofascial pain, but need further development or validation. Other techniques that are currently used in musculoskeletal tissues, but have not yet been applied to myofascial pain. And finally, others that are used in other tissues, such as liver or brain, but could be applied to musculoskeletal tissues. I mentioned earlier that session 6 would discuss the broader context of the relevance of this workshop to musculoskeletal pain research. It's worth reflecting for a moment about the fact that the field of myofascial pain is organized around different types of constructs that often do not translate well into one another and have significant conceptual gaps between them. One way that musculoskeletal pain is organized is around body regions, with low back pain receiving the most attention because it is so common. Some musculoskeletal pain research is organized around tissues like bone, cartilage, and intervertebral discs, or structures like spine and joints. Increasingly, we're talking about pain phenotypes, and these often include pain mechanistic domains, such as psychological, sensory, genetic. And finally, we have diagnoses that have developed empirically around a clinical presentation, often before key scientific knowledge becomes available, like temporomandibular disorder, fibromyalgia, and myofascial pain syndrome. Making sense of these diagnostic categories in relation to pain phenotypes, structures, tissues, and body regions is an evolving task, and as our knowledge of pathophysiological mechanisms expand. And we hope that this workshop will contribute to this. So to recap, in this workshop, we have started with a clinical diagnosis, which is myofascial pain syndrome. We decided to focus on tissues, muscle, and fascia because the clinical presentation suggests palpable abnormalities and that we may not have the tools to quantify yet. We also will be talking about the myofascial unit as a structure that needs to be considered as a whole, especially in imaging. And the measurements that we will be discussing will apply to the mechanistic domains that I mentioned earlier: sensory, motor, autonomic, vascular, mechanical, and I believe we will be hearing also about some genetic considerations as well. Now, psychosocial is not on the menu of presentations, but I am sure it will get mentioned at some point in the discussion. And finally, the measurements we will talk about will have relevance to pain in various parts of the body that tend to be studied in isolation, such as the neck, shoulders, and low back. I would encourage our speakers and discussants to think about the potential generalizability of given types of measurements to different body regions, as well as limitations and challenges that could be region-specific. We will also be asking presenters and panelists to consider whether the measurements that they are discussing might apply to the chronic latent phase of myofascial pain syndrome, or the acute active phase, or both. And finally, I want to say a word about why we have deliberately chosen to focus on non-invasive or minimally invasive types of measurements in this workshop. We recognize, of course, that more invasive methods to look at tissues, such as biopsies, have great value as well, especially for correlating tissue histology, for example, with imaging findings. But for this workshop, we want to focus on measurements that could be used in humans as biomarkers, especially in longitudinal studies where the measurement could be repeated over time to follow natural history, to look at the temporal relationships of tissue level measurements with symptoms, or to measure an individual's response to treatment. Non or minimally invasive techniques that could be used in both humans and animals would be especially useful for translational research and exploration of mechanisms. So I hope that this introduction has given you a framework to think about the material that will be presented. And I cannot wait to hear what this workshop will bring. Thank you.
Thank you, Dr. Langevin. If you want to go ahead and stop sharing your screen, I'm pleased to introduce Drs. Michael Oshinsky and Leslie Durr, who will be our co-chairs for session 1. Our first session is State of Science of Myofascial Pain Syndrome, Clinical Presentation, Pathophysiological Hypotheses, and Challenges. Dr. Oshinsky, please take it away.
Thank you, Catherine, and thank you, Dr. Langevin. On behalf of NINDS, the Institute for Neurological Disorders and Stroke, we're very happy to participate with NCCIH, NIBIB, and all the other institutes at NIH in this very important workshop. In the context of pain, we normally talk about the biopsychosocial model. This is a reductionist model where we say that there are different aspects of a person's experience and their biology that can influence their perception of pain. The focus of this conference, as Dr. Langevin has eloquently laid out for all of us, is that we're focusing here on the biology and specifically on the biology of peripheral tissues. In the first session today, we'll be focusing on the pathophysiological hypotheses associated with the clinical observations and how we can back translate that into models that we can use so that we can use animals to understand in this reductionist way how peripheral tissues can then influence the perception of pain. Now, obviously that influence is going to require the nervous system, either in its peripheral aspects, the spinal cord, and then of course, different areas of the brain. But the focus here was going to be these clinical observations and then how they led to hypotheses and can lead to generating new hypotheses for us to then use back translation of animals to study the physiology and the pathophysiology. That means the disruption of the tissue that has led to the perception of pain. Our first speaker today will be Carla Stecco. She's from the University of Padova. For a full description and her bio, please look in the PDF and on the website. And without further ado, please, Dr. Stecco.
Thank you so much for inviting me and to have a focused attention on myofascial unit. I really are many years that I study the fascia, and I think that can be really a source of pain. If we check this new paper that I published this year, we can see that the superficial fascia is the second most innerved tissue that we have among the soft tissue that we can consider just after the skin. And the deep fascia is the fourth one. Before we have only the ligament capsule. So surely the fascia is very richly innerved. And here we can see the innervation of the thoracolumbar fascia. And in brown, we can see the network of nerves that are all together and that can feel the tension coming from different sides. But surely I like the term myofascial unit and not just fascia, because here we can see as a muscle and fascia interact each other every time. The muscle insert into the fascia and can stretch the fascia and create a specific reinforcement inside the fascia. Here we can see the continuity between the latissimus dorsi and the thoracolumbar fascia, between the gluteus maximus and the thoracolumbar fascia. So we can imagine that any distortion in the muscular contraction can affect the thoracolumbar fascia and all the nerves that are inside the thoracolumbar fascia. But we need to remember that many years ago, Professor Weijing have already demonstrated that only the 70% of the muscular force are transmitted by tendon. The 30% are transmitted by connective tissue around the muscle. And here we can see as the connective tissue is totally embedded with the muscle. And then the epimysium can go inside the muscle, forming the perimysium, and then the perimysium go inside and envelop each bundle to create a total continuity of muscle component and connective tissue component. We need also to remember that the muscle spindle, the Golgi corpuscle, are totally embedded in the connective tissue, or better, the capsule of the muscle spindle, as we can see here or here, is just the perimysium that split around the muscle spindle and create the capsule, but it is totally in continuity. So I totally agree with Professor Mens that affirm that the structural disorder of fascia can surely distort the information sent by the muscle spindle to the central nervous system. And consequently, we can't distinguish a pathology of fascia, of muscle spindle. Often all the three elements interact to create the true pain. But fascia is not only related with the muscle. Fascia go around the joint and often are connected with the fibrous capsule of the different joint, with the ligament of the joint. For example, here we can see the medial region of the knee and the connection between the fascia lata and the joint capsule. But the fascia interact also with the tendon. Here we have the dorsal region of the foot, and we can see as the deep fascia of the dorsum of foot split and create a specific envelope around each tendon of the extensor digitorum muscle, and consequently fascia can feel the tension of each tendon. But fascia can also envelop the vessel. Here we can see as the saphenous vein is totally embedded in the superficial fascia, and the fascia maintain the vessel open, protect it during the movement. But the fascia, the superficial fascia, is also related with the superficial vascular plexus, where we can place the arteriovenous shunt, and the consecutive fascia can have also a role in the thermoregulatory response. Here we can see other aspect of a fascia. The fascia is connected with the nerve, both the superficial fascia and the deep fascia. Here is the superficial peroneal nerve that move and split inside the superficial fascia. And surely a distortion in the superficial fascia can interfere in the normal transmission of the nerve. And here is a paper that we have published about the medial nerve. And we can see, as here we have the medial nerve, the muscle, and as the epimysium of the muscle is totally in continuity with the epinephrium of the nerve, creating a continuity in the physiology, but unfortunately also in the pathology. So tension in the muscle can affect the nerve through the epimysium. But I wanted to show you also some pathological condition of a fascia, because in the last year I focused in the more microscopic molecular aspect of a fascia. We know that fascia is formed by collagen type 1, collagen type 3, hyaluronan, water in different percentage. And here we can see the section of a muscle of a 18 years old man, a young adult, and a 74-old man. And you can see that surely we change the shape of the muscle bundle, but what is clearly evident, how we change also the amount of collagen fiber around each muscle bundle, and above all in the perimysium, where we have the muscle spindle. In the same subject, we have also checked the amount of hyaluronan. And the hyaluronan, that is the element that creates the hydration of a fascia, the gliding of a fascia, change in a totally different way. So we have a decreasing of the hyaluronan content, starting from the young people and go to the elderly people. Also, the fascia have also can also answer to different hormonal stimulation. And here I show you just some example. These are fibroblasts coming from the fascia lata, but we have tested also other type of fibroblasts, always from fascia. And we can see as they answer in a totally different way to sex hormone stimulation, specifically to the estrogen stimulation. And we can see as in the periovulatory phase and in the pregnancy level, that such type of fibroblasts produce much more collagen fiber respect in the postmenopausal level and in the follicular phase. We have also checked the type of collagen fiber, and these collagen fiber are type 3 collagen fiber and not type 1. What is the difference? That the type 1 create a rigid fascia, the type 3 a more elastic fascia. This means that the fascia of a pregnant woman, for example, is more elastic respect a fascia of an old woman. In the same paper, we have also tested the amount of elastic fiber, and is more or less the same behavior. So in the postmenopausal level, the fascia have a very low production of elastic fiber. In the pregnancy woman, probably much more. But I wanted to focus the attention on this paper because we studied the presence of CB1 and the CB2 receptor in the fascia. And 3 years ago, we demonstrated that the receptor for the endocannabinoid system are present both in the superficial and in the deep fascia. This year, we have also tested in such type of fibroblast in culture, if we use an agonist of the CB2 receptor, what happens? And we have seen that the fibroblasts start to produce hyaluronan, and they release as a bubble the hyaluronan in the extracellular matrix. So that could be a new perspective of research, because it means that the endocannabinoid receptor can create a more loose fascia and stimulate the gliding between the fascial layer. So to conclude, we can affirm that the fascia connect the muscle, the nerve, the vessel, the joint, the tendon. So surely we can't speak only about one tissue, but it's much better to consider the myofascial unit. Then we need to remember that the fascia are richly nerved and form the capsule of the muscle spindle, of the Golgi corpuscle. So all that element can create a peripheral sensitization. And finally, the fascia could be modified by estrogen, by endocannabinoid system, probably by pH, and that can suggest that the fascia are a very dynamic tissue that we need to understand more. Thank you for the attention.
Thank you very much, Dr. Stecco. So the next speaker, we're going to save the questions for the panelist session and then afterwards. The next speaker will be Dr. Shea from NIH's Intramural Clinical Center. The title of his talk is Chronic Myofascial Pain, Myogenic Considerations in its Pathogenesis and Clinical Manifestations.
Thank you, everybody. Can you hear me?
Yes.
Wonderful. First, I wish to thank Dr. Langevin, Dr. Oshinsky, and the entire team for inviting me to participate in this excellent workshop. I have nothing to disclose except to say that I'm very...
Dr. Shah, you're very soft.
Oh, okay, I'll speak up.
Please come closer to the microphone. Thank you.
Yes, okay. I have nothing to disclose except that I am very proud to be part of a multidisciplinary and multi-institutional collaborative team led by Dr. Lynn Gerber, who's one of the panelists for this session. In addition, 3 of my co-investigators will be presenting to you over the next 2 days. So what are the challenges and the objective for this lecture? So the definition and etiology of myofascial pain is not fully understood. Furthermore, disagreement persists about the nature of trigger points and how they contribute to myofascial pain. This presentation will attempt to explain our team's view that we seek objective measures and how they contribute to understanding the spectrum of myofascial pain. So according to Shriver and Simons, trigger points are discrete, palpable, hyper-irritable nodules formed by a cluster of contraction knots in a taut band of skeletal muscle. They describe active versus latent. So an active is one that is spontaneously painful. A latent shares the same physical characteristics, except that it is not spontaneously painful. Their underlying assumption was that there is the taut band, which is formed from this persistently contracted sarcomeres, as you can see in this animal model in the dog, which lengthens and stretches the rest of the fiber. And you compare that to the normal striated sarcomeres and neighboring muscle. So what exactly is myofascial pain? It's a pain condition that may be acute or more commonly chronic and involves the muscle and its surrounding connective tissue. For example, the fascia, of course. Pain described as aching, deep, diffuse, and difficult to localize. And it's often referred some distance away from the trigger point, as you can see here in these 2 examples of trigger points in the masseter muscle, which have unique referral patterns. Now, according to Shriver and Simons, the trigger points are central to the diagnosis of the syndrome. However, there is this conundrum, right? Because we often see these palpable trigger points found in asymptomatic individuals. So this, by definition, according to Shriver and Simons, would be latent. Latent trigger points are commonly found in pain patients with active trigger points. So that's where the clinical exam and acumen is key to differentiating them. Some nodules are non-tender to palpation. So the gold standard to date is this is a clinical diagnosis. Be able to palpate a taut band, as you can see with the finger, and then press on that hyper-irritable nodule, and often you will get a local twitch response. But the key on physical exam is the ability to reproduce that myofascial component of pain, as you can see in the lower left-hand corner, when you press on the most active trigger point in that person. So as part of the physical exam, we palpate, and as you can see here, strum the muscle, and you can see the local twitch response. And as I said, we are trying to reproduce their pain. But our team, what we are doing is we are seeking objective measures and reproducible findings. So we use pain pressure threshold, or PPT, as a way of clinically measuring discrete local tenderness and as an outcome measure in treatment trials. Now, one of the most well-known hypotheses is Simon's integrated hypothesis, which rests on 3 pillars, which is one being EMG data showing increased miniature end plate potentials or end plate noise at the trigger point, the concept of the taut band and this increased fiber or tension, and then the critical crux of it was histochemistry, or the release of sensitizing substances. So what our group did was we used these criteria that I described, Travell and Simons, together with digital palpation and a microdialysis technique. We demonstrated and subsequently confirmed that objective biochemical data validate the diagnostic distinction that clinicians make among active trigger points, latent ones, and uninvolved muscle. So what did we find? We found that active trigger points have elevated levels of inflammatory mediators, neuropeptides, catecholamines, and cytokines that are associated with inflammation, sensitization, muscle tenderness, persistent pain, and intercellular signaling. So when you palpate this active trigger point, and this is a case as you can see here, the coterie of substances such as bradykinin, norepinephrine, serotonin, these pro-inflammatory cytokines, they can bind either individually or synergistically to local receptors on the muscle nociceptor, sending increased signals towards the dorsal horn. Just before the dorsal horn, you have the dorsal ganglion, which is releasing neuropeptides like substance P and CGRP. Orthodromically, what do you see? Bombardment of the dorsal horn, increased release of glutamate, substance P, and postsynaptic excitation. However, there is this antidromic release as well. And why do we know that's relevant in active trigger points? Because we see elevated levels of substance P and CGRP. But this neurogenic inflammation is affecting the entire peripheral that nerve. So that will lead not only to tenderness of the myotome and the trigger point, but presumably the dermatome, the sclerotome, the fasciatome, everything innervated by that segment. And one of the other occurrences of this would be expansion of the receptive field. So I think it's important to mention here that we are looking and we are seeing dysfunction not only in the trigger point and the taut band, but in the local neighborhood. And so there is this concept of the dysfunction in the neighborhood. So that's something we can talk about later. So again, like Dr. Langevin mentioned, there is a limbic system dysfunction. So even though this is a regional pain syndrome, we see this on MRI, and it's supported by use of self-reports demonstrating dysfunction in sleep, mood, etc. Okay, so what happens, and again, this is why it's critical to understand the difference between active and latent trigger points. So yes, active trigger points are more tender than latent ones. Active trigger points are more tender than non-trigger point sites in the taut band, which are more tender than normal muscle. And both types of trigger points are more tender than normal muscle. That's not surprising. So one of the first critical studies was done back in '93 by Hubbard and Burkhoff, who found increased background activity, which is not found in normal muscle fibers. And this is termed spontaneous electrical activity. And this occurs without normal motor end plate potentials. This was the first electrical marker for trigger points, suggesting they could be a neuromuscular disorder. Moving just 2 millimeters away from that trigger point zone, there was a change from this high amplitudes, spontaneous electrical discharge, to silence. These small discrete spots in the muscle can be targeted for treatment and investigation. So building upon that work, Simons and Hong showed that there was a 5-fold increase in electrical activity at the motor end plate. This was termed end plate noise, which they demonstrated was equivalent to that spontaneous electrical activity described by Hubbard and Burkhoff. But here's the critical thing to appreciate. This results from an abnormal increase in the spontaneous release of acetylcholine from the motor nerve terminal. So they concluded that increased end plate potential activity and spontaneous release of acetylcholine is associated with the trigger point. So it's important to appreciate that we, based on the work of Gerwin and all, Geoffrey, that we can utilize EMG data and more contemporary understanding of what's happening in the neurophysiology of muscle to expand upon the original hypothesis. So please appreciate that there is both an evoked discharge, an activity which requires nerve activation, and spontaneous. So what happens when you see this increased acetylcholine release? Well, it will stimulate sodium currents, which will travel through the T tubules, and then that will stimulate the sarcoplasmic reticulum to release calcium, right? And that calcium will then cause the binding of the actin-myosin filaments and the cross-bridging. And presumably that cross-bridging is what then leads to the formation of the contraction knot right in that local end plate or end plates. Now, according to Simons, what this would then do was to do what? Compress the local blood vessels. So that would lead to compression and then ischemia, hypoxia. And as you know, you need ATP not just for contraction, but for relaxation. But because you have this compression and loss of local blood flow that theorize, you develop this local energy crisis, this inflammatory soup that Clifford Wolf has described, which would lead to sensitization, etc., release of biochemicals in the local milieu that we have identified. And as we said, these biochemicals can then bind to local nociceptors, causing pain and muscle tenderness. But here's another critical thing to appreciate. Not only do hydronium ions cause sensitization, muscle activation, but they together with CGRP can also inhibit acetylcholinesterase. So what will that do? That will lead to the promotion of further acetylcholine in the synaptic cleft. It will lead to increased acetylcholine receptors. And as you can see, this is another critical event that could be associated with this local hyperactivity, local neuromuscular junction syndrome. That's what's occurring. But remember, there's also elevated levels of norepinephrine. Why is that important? Well, norepinephrine also activates the autonomic nervous system, and there is this autonomic modulation that occurs that is influencing the voltage-gated calcium channel. So then that will also result in increased amount of acetylcholine into the synaptic cleft. All events that can promote that local contracture according to Simons. And finally, let's remember that there could be this alpha adrenergic activity, which could lead to vasocompression, again, due to sympathetic modulation of the local blood vessel. So taken together, these are intriguing nuggets of data and information. Obviously, this is speculative, but this is what clearly warrants further investigation by our colleagues. Thank you very much for your attention.
Thank you, Dr. Shea. We do encourage everyone to put questions in the Q&A section, but again, they'll be addressed at the end of the panel session. Our next speaker is Dr. Serbel from the University of Guelph. The title of his talk is The Role of Neurogenic Mechanisms in the Pathophysiology and Clinical Manifestations of Chronic Myofascial Pain.
Thank you, Michael. It is indeed an honor to be invited to speak to this exciting initiative. And I really want to just kind of take over from where Dr. Shaw left off, really just to reiterate that one of the key gaps in the field that we are all sort of exploring right now is this definition of the pathogenesis of myofascial pain is still not fully understood. And the core disagreement or the core problem right now is that the question still remains whether myofascial pain is a disease or rather a syndrome. And we know that the trigger points, we've heard that trigger points are intimately associated with the clinical manifestation of myofascial pain. But again, as we've heard from Dr. Shaw, the pathogenesis is still not fully understood, and disagreement persists whether it's the primary pathology in myofascial pain or a secondary physical sign. And even up to two-thirds of clinician respondents suggest that the trigger point may not even be essential to the diagnosis of trigger points. So where does this lead us? Essentially, what many of us in our group in particular, George Mason, we recognize that the development of reliable objective biomarkers for myofascial pain necessitates that we elucidate its underlying mechanisms. And this was seen similarly in conditions like diabetes and peptic ulcer, where they were only effectively treated after we recognized the underlying mechanisms. And so Varday in 2006 suggests that the prognosis for chronic pain could be improved with a better understanding or a move towards this concept of mechanism-based diagnosis. So the current prevailing theory is that the integrated hypothesis suggests that the onset of chronic myofascial pain is precipitated by some acute or chronic muscle overload, so an injury to the myotendinous unit. But we clinicians realize that many of these clinical observations do not align with this injury model, and specifically for a couple of reasons. Trigger points are associated with a number of somatic and or visceral conditions in the absence of injury. And in black here, I've highlighted some somatic conditions, but there's a growing body of visceral conditions that are clinically associated with the presentation of myofascial trigger points. Furthermore, the trigger point simply doesn't behave like an injured locus. So pressure, for those of you who applied pressure therapeutically to a trigger point, it doesn't induce a withdrawal reflex. It's not a well-demarcated pain, as would be experienced by a local injury. And patients often characterize this as a good pain, and they want more pressure. So again, this sort of is counterintuitive to this local injury model. It doesn't seem to behave like a local injury to the myotendinous unit. So what are some alternate pathophysiologic mechanisms? Dr. Langevin alluded to the neurogenic, a body of neurogenic research that's emerging to kind of tie in some concepts here. And one of the sort of studies that really eluded me down this path was this idea of visceral cross-sensitization, studied in an animal model by the Ustinova group, where they experimentally induced colitis. And within 3 days, they identified an inflammatory response in the bladder that they attributed to neurogenic inflammatory mechanisms that were triggered by central sensitization. So we kind of carried this line of thinking forward and asked the question, could the myofascial trigger point then be the physiologic expression, similarly, of neurogenic inflammation within the muscle? And does it really matter where the primary pathology resides? Could it be somatic and or visceral? So we proposed this neurogenic hypothesis of chronic myofascial pain that suggested that the trigger point and myofascial pain more broadly is a function of neurogenic inflammatory mechanisms in the muscle that are evoked by distinct primary pathologies residing outside of the muscle, but that fall within the neurosegmental field or that are neurosegmentally linked to the affected muscles. So if we look at this schematic here, if we introduce a pathology in the receptive field of this nociceptor, we can introduce, if it's persistent, we introduce sensitization in the dorsal horn that then triggers a primary afferent depolarization, dorsal root reflexes that release pro-inflammatory neuropeptides into the peripheral tissue, in this case, a muscle. And this is called neurogenic inflammation and potentially creating a focal point of tenderness. Similarly, through interneuronal pathways, we can also activate the motor neuron pool. And it is the coexistence of these two pathways that provide the biological plausibility then of the formation of the myofascial trigger point in the absence of local injury. So using this framework, we can begin to explain some of the clinical observations that are not explained with the injury model, the integrated hypothesis. This framework also can explain the muscle spindle hypothesis as proposed by Partanen in 2010, where he describes the active role of the muscle spindle. And we know that C fibers are densely innervating the capsule of the spindle and the intracapsular lumen. And so again, any neurogenic inflammatory response here would also release pro-inflammatory neuropeptides at the spindle, thereby activating the cycle, where the gamma motor neuron would be activated and then reflexively activate the alpha motor neurons that could potentially create this local contracture that we observe clinically. So using this model, using an animal model, we actually demonstrated the causal relationships between experimentally evoked osteoarthritis in an animal model and neurosegmentally released neuropeptides and pro-inflammatory biomarkers. Similarly, in humans, we've also observed increases in motor unit pool activity in the first dorsal interosseous muscle using an experimental sensitization model. So this is the pre-sensitization tracing. And you can see here, post-sensitization, we see a much greater frequency response during abduction, as well as larger motor units kicking in at much earlier force production, suggestive of a breach in the Henman size principle and dysfunction in the motor unit pool. So again, these data are beginning to emerge to support this neurogenic mechanism. Okay, so then what clinically feasible biomarkers can we use, knowing this, to diagnose and assess the myofascial pain patient? Well, we can look at C-SENS or central sensitization, and neurophysiologically here you can see data from an anesthetized rat showing the differences in the dorsal horn neuron activity post-sensitization. And we can see not only an increased response, but one of the characteristics of C-SENS is an accelerating input response profile. So with each input stimulus here, we get an increase, a gradual increase in the response of the dorsal horn neuron. We also see persistence here, or an aftershock after the peripheral stimulus has been eliminated, which aligns, is analogous to the persistence of pain. So this is manifest in humans through this idea of wind-up or temporal summation. So we can see here in a study back in the 90s, chronic pain patients demonstrated a much greater temporal summation to pain than age-matched controls. And again, this is evidence of a wind-up phenomenon that is mediated through altered central sensitization or altered function within the segment, the affected segment. And so we are looking at biomarkers that are actually targeting this phenomenon, and in particular using an idea called the wind-up ratio, which I'll discuss in a minute. But we use these weighted pinpricks here, which are logarithmically scaled from 8 to 512 millinewtons, developed by Treat and McGarrell. And they provide quantitative data not only for mechanical detection thresholds, but also enable us to assess stimulus response functions with repeated stimuli of known forces. So we can actually target specific segments by identifying the corresponding dermatomes and then applying this wind-up ratio concept, which I'll describe in this slide here. So, and it's described in Rolka 2006, where he talks about the wind-up ratio as the actual perceptual correlate to temporal pain summation. And the way we do this is we apply a baseline stimulus using this 256 millinewton pinprick, and then we apply 10 stimuli at 1 hertz, and then ask the patient to provide us with a numeric pain rating. And effectively, what we do is we take the average pain rating of these 10 over the baseline rating, and that provides us an estimation of this wind-up ratio here, as you can see here, so this amplification. And using this mechanism, we can actually begin to target the temporal summation or the central sensitization that may be mediating these changes in pain and motor function that we observe in our patients. So this is something that we are looking at actively in our lab. And so just going back to Dr. Langevin's slide, this is one area that may address the sensory and motor nerve dysfunction in the assessment of myofascial pain patients. Thank you for your attention.
Thank you, Dr. Serbo. Our next speaker will be Dr. Lasandak from the University of Pittsburgh. The title of his talk is A Clinician's Perspective on Treating Myofascial Pain, Overview and Challenges.
Good morning, everyone. Thank you so much for being here today. It's absolutely a pleasure to be part of this amazing group. I want to be sure everybody out there watching who, from a more imaging standpoint and other other research aspects, understands what a typical day is like for a typical clinician who has to deal with human beings who come in with various aspects of pain and myofascial pain type syndromes. So I deal predominantly with people who have chronic pain issues, also subacute. So we're looking at 3 to 6 months, postpartum situations, and all manner of pre and post surgical issues in general. And the predominant technique that is utilized are various forms of myofascial release. Let's actually talk about what is a release. Well, from the point of view of the patient, it's a subjective inner sensation that feels like a letting go. And that letting go is accompanied by a decrease in tension, improved range of motion, greater physical ease. Those seem to be the three most common, and different people perceive them on different levels. Some might perceive all three, some might perceive one or two, and it is almost always accompanied by a palpatory difference that is perceived as a softening of the affected treatment area. Now, as I mentioned, this is a manual procedure that uses a lot of different techniques involving the hands or the arms. And the other key thing is it's more than ischemic compression from the viewpoint of myself and many other colleagues. There is that compression, but there's also shear and combined with stretch and traction. And very often that stretch is provided by the patient themselves, doing slow micro movements, slow guided movements, because the fascia has, depending on the calculations that you use, an estimated 100 to 250 million sensory and proprioceptive nerve endings. So the more we can stimulate that proprioceptive and sensorial response, plus get the patient comfortable with the idea of slowly and exploratorily moving areas that they're afraid to move, the better results we get. And I also want to call your attention to the picture at the lower right, which is from the Fascial Net Plastination Project. And that, of course, is the fascia lata of the thigh, including the notorious IT band and the gluteus maximus. Now, looking at fascia as a force transmission system, 80% of the muscle force of the gluteus maximus is transmitted into the iliotibial band. So I take a somewhat broader view of what's going on in the whole physiological mechanism, and we'll explore that in a few slides. But since we're on the topic of this compression, shear, and stretch, well, what's happening on the cellular level? Well, this was done by Paul Stanley's group at the University of Arizona, and what they did was they took a healthy, living, active cell culture and subjected it to 8 hours of repetitive motion strain. And that's the picture you see in your upper right that has the letter B after it. There was reduced cell-to-cell contact. There was both a decentralization and cytoplasmic condensation, a precursor to apoptosis. And by the way, the apoptosis rate went up about 30% from what would be normal after 8 hours of repetitive motion. So 3 hours later, they let these cells rest. They went home, they had some dinner, maybe an after dinner drink, we're not sure. But 3 hours later, they reconfigured the substrate to mimic compression, shear, and stretch. And they found that 60 seconds of cellular myofascial release resulted in picture D on the lower right-hand corner of your screen. The condensation was reduced, most of the cell-to-cell connections were restored, and there was also a proliferation of the neutrophil GRO, which is a very, very important innate immune system response. So that's what's going on the cellular level, but most of the people I see come in looking something like this. So I'm approaching this from the structural and the mechanical level. So all three of these people could be coming into me expressing nonspecific low back pain. But if I treat them all the same, because the pain is in the same area, I'm going to miss a lot. So this is where an important postural or pathoanatomical analysis has to take place. And you're seeing it just on the sagittal plane from the left lateral view, but we also look at the front, the opposite side, and of course the posterior view as well, to see where do the parts and pieces not add up, where do things seem tight or restricted or not in optimal alignment as they might be, and how does that relate to their mechanical difficulties and their pain? What's the story? How do we put it together? Now, this is more in a chronic phase where the fascia itself has densified around these areas, and it sort of makes the posture a default mode that can be very difficult to mobilize or get out of in an effective way. Part of what's going on here is that collagen needs constant stimulation in order to maintain a healthy framework. So on the left, you see a healthy collagen network, and after 3 weeks of immobilization, you see a deterioration. It reminds me of kudzu, those amazing prolific weeds that grow like wild in the south. So without good motion, the collagen does not have the right stimulation to grow in a way that supports the movement and then begins to actually be deleterious to the movement. And that collagen, of course, is produced by the fibroblast. Which is mechanosensitive cell that responds to both pressure and vibration. So part of what we think is going on is that we are stimulating the fibroblast network to produce collagen in a different way, and perhaps to secrete collagenase to eat up the collagen in the areas where we're now trying to increase mobility. Now, there's another factor too, and that's hyaluronin. So the hyaluronin is secreted by fasciocytes, which are cells that live predominantly in the epimysium, the sliding layers between the myofascial units, and they respond very strongly to shearing motions. So that's kind of the WD-40 of the myofascial system. And when it's not properly being stimulated, what happens is that hyaluronin tends to densify, and that also can inhibit motion. It can also inhibit the proper output of the sensory and proprioceptive nerves, which are highly abundant both in the superficial fascia, but also in the epimysial sliding layers between the muscles. So where do we start when we're looking at somebody like this who says, can you help me feel better today? Well, fortunately, we've had a lot of researchers who are mapping out the connections beyond just the individual myofascial units, because we need to look at the system in a biotensegrity kind of way, or at least in a top to bottom force transmission kind of way. And these fascia sparing dissections almost always use the blunt end of the scalpel so that we can feather up the connective tissue along with the muscle, even right over the bone, rather than through the bone. So, and these are becoming independently verified by some curious systematic reviews. One of these global change is the one you see on your left, the superficial back line, which is a continuous system of myofascial units that goes from the epicranial fascia down the erector spinae, across the sacrotuberous ligament, into the hamstrings, up the gastrocnemius and soleus, down to the Achilles tendon, around the periosteum of the heel to the plantar fascia. So having these maps, having these ways of looking at the interconnected anatomy beyond the individual segments allows us to make more global treatments that create better outcomes, as we see in this slide. So this is ideally where we want to finish, is the picture where you see the post-12 treatments. Now, this was a woman who came in with a lot of postpartum issues, including bladder issues, a prolapsed bowel. It had a lot of different therapies in PT, but things still weren't quite normal. After 12 treatments, and this was about 4 years later from her initial pregnancy, she was able to resume exercise again, and in a real world measurement that was quite delightful, she was able to blow up balloons for her boy's birthday party because the interabdominal pressure did not allow her to blow up balloons without pain and discomfort in the bowel and in the pelvic area. So that's what we're going for when we start with people on the left, what we're going for on the right. But what happens when people come in looking like that post-12 treatment picture and we don't have obvious markers? Well, again, this is where the clinician's understanding of myofascial anatomy and science comes in handy. And I want to highlight a study just published this year that Antonio Stecco was involved with. He'll be on this afternoon. You can query him about this further. But what this showed using the T1 row MRIs is a densification of the hyaluronin in the area around the elbow on people with elbow pain. So what he and his group were able to do was to treat an image pre and post treatment, the change in the densification, that red area that you see in the top line that the arrow is pointing to, and you can see how it changes in the post line in the line below. One of the other markers that they found was a change. The inflamed area, as imaged in the red above, had a much higher free water content. That free water content changed more into a bound water content post-treatment, and it is theorized that has something to do with the change in palpation felt by the therapist post-treatment. So that's a lot. And there's a lot here to unpack. So one of the things I want to highlight to everybody here is an upcoming conference being organized by Dr. Stanley's group at the University of Arizona and also Andrew Taylor Still University, because we want to try getting all these manual therapies on the same page. And with that said, I just want to thank you all for being here today and my research librarian, because without her, I would be not quite so effective. Thank you, Heidi, and thank you all very much.
Thank you to Dr. Lasendak for those clinical observations. There were some really exciting things there. Our next speaker will be Mary Barb from Temple University in Philadelphia. The title of her talk, Basic Research, Animal Models Relevant to Myofascial Pain. Dr. Barb?
Thank you.
Excellent, thanks.
The first model I'd like to discuss is repeated contusion and eccentric exercise model.
We don't see your slides yet.
Uh,
Click that share screen, the little green button at the bottom.
yes, I did that.
And then pick the window with your slides.
It's not sharing.
When you click the screen share green button, do you have another window that pops up that shows all your individual windows? Your desktop's at the top and then individual windows?
It's not doing something correctly. Just a second.
Okay, sure.
I have to switch computers.
That's fine.
It's let me try again. It seems not to want. You
Oh,
see?
good. Yes, now we can. So just click it into presenter view. Thanks.
The first model I'd like to share is repeated contusion eccentric exercise model by Huang and Zhang et al. In this model, the vastus medialis is repeatedly contuted once a week for 8 weeks, and the animals also undergo a downhill treadmill running for 90 minutes once a week for those 8 weeks, after which they undergo a recovery period for 4, 8, or 12 weeks. What they found are palpable bands that they deem as myofascial trigger points that are associated with increased spontaneous electrical activity during fine wire EMG. As you can see in the control group, there's no EMG activity, but in the experimental groups at 4 weeks post-recovery, there's dense EMG activity suggestive of acute injury and inflammation, as well as then at 8 and 12 weeks, intermediate activity suggestive of resolution of the inflammation and perhaps formation of a chronic myofascial trigger point. They took these EMG signals and divided them up into subtypes, the most interesting being those in red, type 5, that you only see in the experimental groups at 8 and 12 weeks post-recovery. These were doublet fasciculations or fibrillation potentials that are indicative of central hypersensitization or chronic inflammation in the neuromuscular system. When they examined the muscles compared to the controls, the experimental group showed myofiber knots like shown in F by the arrow, rounding, thinning myofibers, and inflammatory cell infiltrates that decreased over time. The second model is by Dr. Sluka, who will present the second session. It's a muscle acidosis model with repeated acid injections into the muscles 5 days apart, which induces a secondary cutaneous allodynia in the 2001 study, but in none of her studies do you see any significant muscle damage. On the left here, you can see 4-Paul mechanical cutaneous threshold changes that show a decrease after pH 4 or 5 injections, but not higher pH injections. And these persist for up to 5 days post-injections. There's only a mild lymphocytic inflammation seen, particularly after the second injection at 7 days post-injection. The secondary allodynia appears to be due to an activation of acting acid-sensing ion channels, shown quite nicely in this study using knockout mice that are knocked out for either the acid-sensing ion channel 3 or 1 versus wild types. In the top panels, you see the wild types where the 2 injections of acid increases a mechanical threshold in each of these groups bilaterally. And it's still present in the animals that are knockout for type 1 acid-sensing ion channels. However, look at the panel B, there's an absence of the mechanical threshold changes in the type 3 knockout, implicating this particular ion channel in this response. One of the underlying reasons for this is an activation of resident macrophages that is inducing the chronic muscle pain and the secondary cutaneous allodynia. This was shown by depletion of resident macrophages in the muscles by a quadrinate liposome injection, which you can see here occurred at 2 days or 1 day after the first acid injection. And then there was the second acid injection at day 5. The Paul-Ridal responses were attenuated by the quadrinate liposomes bilaterally, as were the muscle withdrawal thresholds, indicating that the resident macrophage depletion was attenuating this hypersensitivity. When the second acid injection sort of response is attenuated by blocking macrophage activation with a toll-like receptor antagonist C3/4, you see no effect on the acid induction of hyperalgesia because it was elicited in the first injection first. As you can see here, due to an activation of these resident macrophages. In panel B, the acid injection is increasing their proliferation. And then over here on the right, you can see a large increase of multiple types of pro-inflammatory cytokines, very similar to lipopolysaccharide injections shown in the black. The third model is quite interesting. It's a Fujiwara's model of repetitive reaching and food pellet retrieval for 6 weeks. The 6 weeks of this chronic repetitive unusual movement is leading to a progressive decline in grip strength. You also see a progressive decline in the withdrawal thresholds of muscle hyperalgesia that's after probing with monofilaments. They do not see any inflammatory change, but what they do see is an increase in muscle atrophy, shown in the upper right panel here, of a decrease in muscle weight in the task animals versus control, and a decrease in the individual myofiber cross-sectional areas. They also see this is associated with an increase in autophagy proteins, such as beclin and HEG5 and 12. The fourth and last model I'd like to present is one from my lab. It's a chronic repetitive strain injury model where the animals are pulling a lever bar repeatedly at a higher repetition rate, is 4 reaches a minute, and a high force level, 48 to 55% of the rat's maximum pulling force. This occurs 2 hours a day in 30-minute intervals for 3 days a week. By the third week of this repetitive task, the animals show an increase in behavioral indices suggestive of muscle discomfort, such as forearm guarding, switching limbs, pulling with a couple of digits versus a full grasp. Nerve inflammation is elicited in untreated task animals, as is degraded myelin basic protein. This is associated with an increase in abnormal ongoing activity within the median nerve, shown in A, and examples in B through C. That is quite reminiscent of what we saw in Model 1 with the spontaneous EMG firing in the muscle contusion model. By 6 to 12 weeks of this repetitive task, one sees persistent sensory motor declines, as well as changes in the spinal cord of central sensitization. I'll talk you through the slide. Here in this first one, you can see despite conservative treatments of ibuprofen or move to an easier task of low repetition, low force, there's a persistent decline in the forepaw withdrawal threshold, unless one treats preventively with ibuprofen, shown in green, or early rest, shown in orange. This was all associated with an increase in substance P in the dorsal horns of the untreated or even ibuprofen-treated animals, as well as a neurokinin-1 receptor antagonist in all of the animals compared to task animals compared to the controls. This is because the treatments were not provided until after the onset of the discomfort. So based on the literature that shows there might be some fascial changes, we did look for that, and we see an increase in neurofibrosis around the median nerve here, shown in green, and collagen, as well as a CCN2, a fibrogenic protein. And the median nerve is encompassed here to the point that there's an increase in degraded myelin around the individual axons of the untreated task animals. If the animals are provided a 6-week rest period, the degraded myelin starts to recover, but the collagen does not. However, if the animals are provided an anti-CCN2 antibody drug called FG3019, the degraded myelin in a 6-week treatment period goes back to normal, and the collagen fibrosis deposition is reversed. All of this leading to a reversal of the grip strength declines. Centrally, there are other changes, but I'd like to point out these pictures here to the left, that the muscle and endomysium is undergoing an increase in collagen that is associated here with an increase in substance P in the extracellular matrix, as well as in the muscle itself. This FG3019 drug, shown here in the crosshatch, decreases the collagen type 1, the collagen type 3, and the CCN2 to control levels. But most importantly, there's a change in the spinal cord. Apparently, this fibrosis around the nerves is creating like a compression on the nerve, and the task animals are showing an increase in ATF3, an indicator of neuronal stress, as it moves into the nucleus. The 6 weeks rest recovers the sum. You can see the ATF3 is not only in the cytoplasm, but the drug that's reversing the fibrosis results in a change so that the neurons in the motor horn of the spinal cord looks very similar to the controls. And for all of this is supporting some ideas that was presented first by Dr. Langevin, that there's some structural changes like micro tears and degraded myelin, and scarring and fibrosis and disorganized architecture contributing to this, as well as some metabolic changes such as reduced pH or chronic inflammation and autophagy. And some of the ways that it can be detected is with the electrophysiological changes or sensory motor dysfunction.
Thank you, Dr. Barb. And really thank you to all the speakers for a very exciting session that really showed beautiful integration of data from clinical studies and animal studies to inform different types of physiology that could lead to the clinical symptoms and clinical manifestations of myofascial pain in the patients. I hope you all agree with me that that was a really exciting session. And thank you to all the speakers for staying on time. So at this point in the program, we have a 15-minute break. And following that break, we are going to have a panel session. They'll be chaired by Dr. Leslie Durr. And there'll be a short presentation to react to the talks from each of the panelists, and then we will move into a discussion of the questions, etc. So at this point, we're going to have a 15-minute break and we'll reconvene at 10:45 Eastern Time.
Thank you, Dr. Oshinsky. And a reminder to all of my panelists, please make sure you are muted and your video is off as we move into this break. We'll be needing to just make sure that we've taken care of our housekeeping. Thank you, and we'll be back at 10:45. Dr. Der and Dr. Oshinsky will be moving into the panelist comment portion, which will be led by Dr. Leslie Der from NIAMS. So just 30 seconds from now, and so I would invite my session 1 panelists to bring their video back up. And I have returned the ability for panelists to unmute themselves as needed. So thank you so much. So Dr. Der, do you want to take over with Dr. Oshinsky, please? I think we're just
absolutely.
Go.
Thank you, Catherine. I'm Leslie Der from the National Institutes of Arthritis, Musculoskeletal, and Skin Diseases, and we are administering the Back Pain Consortium Research Program for the HEAL Initiative. And so this workshop is clearly of interest to us. And so I want to thank you all for participating, and really looking forward to the remainder of the talks, as well as how much I enjoyed this morning's presentations. So we are now going to move into a panel. We're going to hear from each of the panelists just some short highlights that they'd like to bring out, and then we will open it up to a broader panel discussion. So our first panelist that we would like to hear from is Lynn Gerber from George Mason University. Lynn?
I am just bringing up my screen share.
Okay.
Is everybody able to see that?
Not yet.
Okay. So let's go back here. And close that. There we are. Okay.
That's great. Perfect.
And one moment, let me put it on presenter. Good.
There you go. Yep.
Thank you so much for the opportunity to be a panelist in this very, very exciting workshop and a wonderful series of presentations this morning. I think the presenters have been very consistent in observing that there's great confusion in the literature about the diagnostic criteria and the kinds of measurements that can best be used for evaluation and treatment outcomes in myofascial pain syndromes. I think the challenge that Dr. Langevin posed to us is to start with the muscle. I'll use Dr. Stecco's concept, the myofascial unit, to begin the journey in developing a biosignature for MPS. No small task to try to objectify pain in a dynamic clinical state whose diagnostic criteria are not universally accepted. So we start with Travell and Rinsler, who coined the term the trigger point in the 50s, and it stuck because it was palpable, observable, and to some degree reproducible. That's questionable. Travell and Simons broadened it to include the more neurological components of sensory, motor, and autonomic findings that were associated with trigger points, but not necessarily causally related. And so we are now faced with identifying objective measures that bring all of these observations together. And we've made progress. First of all, we've identified microanalytes that are associated with inflammation, neuropeptides, and catecholamines. And also, we have identified changes in collagen, which seem to be associated with abnormalities of tissue due to shall we say, postural changes or aging, perish the thought, and quantified sensory testing that Dr. Shriver talked about as a way of objectifying findings associated, but linking these to the patient's self-report and the overall perception of their experience is in fact lacking, and we are challenged to do that. This allostatic model proposes to look at myofascial pain syndrome as a result of the cost to the body of an inciting event. The inciting event may be well behind us, and we can't even identify the primary organ that has been involved, and yet we are pressed to understand why we have persistent pain. So we can look at nociceptive bombardment, we can look for trauma using imaging, we can look at inflammation, looking at biochemicals and self-reports. I think one of the main challenges going forward is to try to quantify and understand better the relationships that enable us to talk about pain, and those need better objectification. So a biosignature that includes internal and external stressors that can help us understand the extent of the problem using objectified individual patient responses are likely important to understand mechanisms of myofascial pain. Thank you.
Thank you, Lynn. Appreciate that. Next up, we have Kendi Hensel from Texas College of Osteopathic Medicine. Kendi?
Good morning. Good morning, and thank you for the opportunity to speak with you, to talk about how I think and how I talk to my students about fascia. I describe fascia as a sheet. I teach first-year osteopathic medical students, and we talk to beginning students about feeling fascia as a sheet. It has continuity to it that can be felt and assessed all over the body. It should feel slick, slippery, and slide easily on the tissues underneath it. It should feel like silk or satin. Inflammation, however, can change that palpatory texture to something that's stickier, more like flannel instead of silk. Like my cat Oliver here in the picture, dysfunctions or restrictions can hold down these fascial layers, preventing them from sliding, and those layers then feel tacked down and sticky and not moving or sliding on each other. When there's a bind in the fascia or a dysfunction pulling on the fascia, like in this picture, I'm pulling on the sheet from the lower left corner, it gives a palpatory directionality to the fascia. Applying tension in one area of the body can help triangulate or localize an area of restriction, leading me as a clinician to what dysfunction or restriction I need to treat or evaluate next. After treatment, the release that was mentioned earlier, the motion of the fascia should then feel unencumbered. It should be moving freely and back to a slippery, slick feel. So as a clinician, what I'm feeling for in evaluating the fascia is both the texture, both the silk or the flannel, as well as the free motion of that continuous sheet of the fascia around the body and where it may be held down by either a somatic or a visceral dysfunction that could be a result of trauma, surgery, postural strain, etc. And that's what I look for when I diagnose. Thank you.
Thank you, Kendi. Okay, next up we have Eric Jacobson from Harvard Medical School. Eric?
Thanks very much. I'm very happy to be part of this conference. I have been a structural integration practitioner for the past 45 years, and I'm going to talk about, if I get the slideshow started, there it goes, I'm going to talk about, can you see my screen?
Yes, we can.
I'm
Thank
going to talk about two clinical phenomena that are typical of structural integration and two hypotheses that might explain their effect on chronic soft tissue pain. The first one is fluid migration through the myofascia. In her landmark book on structural integration, Dr. Rolfe taught that fibrosis and densification reduced the migration of fluid through the fascia, and that this had negative effects on soft tissue health. More recently, Dr. Shea and his associates found higher concentrations of nociceptive amplifiers and pro-inflammatory cytokines in the interstitial fluid at sites of chronic soft tissue pain. I'm very glad he presented that data. Clinically, manual pressure and simultaneous fascial movement reduce the density and increase hydration in the fascia, and reductions in chronic pain are often reported. What could be the mechanism of this? Increased fluid migration might enhance the clearance of nociceptive amplifiers and pro-inflammatory factors. Second theme, stretching of myofascia. Dr. Rolfe also taught that densification and fibrosis of the myofascia reduced elasticity and that this limited the patient's ability to stretch the soft tissues. Clinically, a combination of manual pressure and simultaneous movement of the fascia increased the client's ability to stretch. Reductions in chronic pain are often reported. What could be the mechanism of this effect? Increased stretch might activate anti-inflammatory, anti-nociceptive, and pro-resolvent effects that were found in animal studies. The studies referenced there were done at Dr. Langevin's lab at the University of Vermont School of Medicine. Thank you very much for your attention.
Thank you. All right, moving on, we have Jan Mundo from Mundo Lifework. Jan?
Hello, I'm happy. Hi, I'm happy to be here. There we go. Okay, good morning. Migraine is a neurological disorder that affects 37 million people in the US and is characterized by throbbing, trigeminal pain and associated symptoms like nausea, vomiting, sensitivity to light, sound, or odors, and myofascial pain prevalence between and during episodes. For 50 years, I've practiced and taught a targeted, gentle, precise pressure transcranial touch and focused concentration therapy that I developed for headache and migraine. Following a cycle of sensations, the therapy modulates and resolves the pain and associated symptoms. Tactile attention, or attention focused on the object being touched, and a type of mental imagery called a mental push accelerate the process. So how do touch and focused concentration modulate and resolve acute migraine and associated symptoms? What are the connections and neurocognitive pathways between touch, attention, and migraine pain? This stuff keeps me up at night. Is fascia the mechanosensory transducer between touch, migraine, pain perception, somatosensory cortex activation, and neural circuitry?
It seems Dr. Mundo has frozen.
How to measure to resolution? Oh no. Research. Oh, my connection. Am I here? Am I back?
We can hear you again, Jan. Yep, keep going.
Okay. Research of manual.
Is she frozen or is it me?
Yes,
she's frozen. Jan, maybe stop sharing your slides and that'll increase your bandwidth and you can finish speaking.
Jan, I'm going to go. Yes, there you go.
All right. Did you hear the presentation?
Yeah, we heard most of it. Just finish up. Give it a little.
Okay, I actually did, but for patients, there are no side effects. Somatic roadmap and skill set for replicable, sustained non-drug pain relief and prevention, and it can be self-applied. And research is a way to show real-time study of the mind-body connection. Thank you very much.
And thank you. And sorry for your connection issue. I know how that. Okay, next we have Nikki Munk from Indiana University.
Hi, everyone. I'm really excited to be a part of this. And for fear of my connectivity, I'm not going to share my slide. Just as I am representing the therapeutic massage clinical standpoint from this. And these talks have really helped to reinforce my understanding of what I observe in clinical care through therapeutic massage, and also what my clinical research related to chronic myofascial pain situations seek to address in its effectiveness research studies. The work of therapeutic massage clinicians land themselves right in the thick, if you will, of myofascial pain observation opportunity and the potential to address systematic expressions of potentially mechanistic causes of myofascial pain. In my former therapeutic massage practice, my clinical approach to pain with my clients was very much shaped by the trigger point concepts developed by Drs. Travell and Simons and refined by the therapeutic massage delivery paradigm, which includes addressing tissues through mechanistic means via the hands and potentially tools with ischemic compression, shear, and glide over the tissues. My therapeutic massage practice has shifted into full-time academic research, which continues to reflect and be informed by these clinical experiences. And one of the many challenges, or perhaps better questions of interest I have in my research, is that of the ideal trigger point treatment dose related to pain management and how that intersects with the way the therapeutic massage is practiced and accessed in the real world, which, if you want to go on to the next slide, actually shows the unfortunate reality is that practice isn't necessarily overlapped with education and research and therapeutic massage and probably a lot of applied disciplines. But this understanding of what that ideal dose of trigger point treatment is in the real world, because ideally in my understanding, treatment would involve short and repetitive treatments that don't necessarily reflect how massage therapy is done in the real world. So what to do? And this brings me to how we might be able to engage patients in their own healing process. And that ideally, if we're going to be doing a treatment of a one shot isn't necessarily going to be the most effective. It's going to need to be done over time. And people aren't going to come and see me repeatedly over time, or a therapeutic massage person, clinician. So if we can teach them trigger point tools, self-massage tools, to be able to either give us feedback during the sessions or to be able to do at home between sessions to help support the work that we're doing, that would be great. Of course, that adds a whole nother bucket of worms to the measurement questions, how to do this, how to teach that, how to look at fidelity and the like. So I'm interested in more discussion around those pieces and other real world applications of these approaches. So thanks so much.
Thank you, Nikki. Okay, next, Kathleen Sluka from the University of Iowa. Kathleen?
Thank you, and thank you for inviting me. As a background, I've been studying musculoskeletal pain mechanisms for over 20 years, and both at a basic science level and translating those into clinical. And what I wanted to really ask the question is, do we have the right animal models to really get at the questions that we've heard? We have learned from all of our speakers today about an extensive role of fascia in how widespread it is. That's where the nerves are. We've learned about the neurochemical milieu that surrounds the fascia. We've learned about fibroblasts and collagen and immune cells that may all be playing a role in myofascial pain. Dr. Barb nicely reviewed some of the existing animal models, and these animal models, some of them may be appropriate, some may not be appropriate. And I really want to ask and let us start to think, what would be the key components we would like to see in an animal model in order to really be able to drill down and figure out, are we really studying the right mechanisms? Those key components, some of the things that I took away today from Dr. Stecco, Dr. Shaw, were things like, are there immune cells involved in this? What are the fibroblasts doing? Are there changes in collagen? Are there changes in hyaluronin? Are these things happening, and do we see them? And what role do they play in driving pain behavior? And can we modify them to reduce the pain behavior that we're seeing in our animals? And I think I'll leave it there and leave it open to discussion. Thank you.
Great questions, Kathleen. Thank you very much. Okay, our last panelist that we're going to hear from is Heather Tick from the University of Washington. Heather?
Yes, can you hear me?
Yes, we can.
There we go. Perfect. Thank you very much. For over 30 years, the role of neuropathy, connective tissue, and altered movement patterns have informed my model of care. Thank you very much for this meeting that shines light on what have been dark corners. I want to highlight a few items of particular relevance for improving clinical care, especially for those who fail standard care. In the field of sensitization, there is a little known work by the great Walter Cannon, The Supersensitivity of Denervated Structures. This work outlines research on denervation leading to sensitization of all manner of end organs, including the myofascial system. Seth Sharpless expanded on Cannon's work to show that you also get sensitization with partial denervation and with disuse. The clinical connection here is Chan Gunn, who happened upon Cannon's book serendipitously in 1970 and recognized that the sensory, motor, and autonomic phenomena he saw in myofascial pain patients fit the model of sensitization due to neuropathy. And starting back in the 1970s, Gunn developed a systematic treatment using intramuscular stimulation or dry needling to treat muscles innervated by the anterior and posterior primary rami in the affected myotomes. Myung-Soo Lee led a systematic review of RCTs that followed Gunn's protocol and showed more robust improvement than what is seen in studies that don't follow this neuropathic segmental model. The work of Mary Barb's group, especially the one on the repetitive strain injury model, shows somatosensory reorganization that has tremendous clinical implications, especially for those who fail conventional treatments, because they have what is essentially an unrecognized movement disorder. I saw evidence of this in the 1990s treating repetitive strain injuries in journalists and in musicians. The current demonstrations of the dynamic nature of connective tissue and the role of fascia as a connector explains patterns of dysfunction and healing that are very relevant to clinical care. It is difficult to overestimate the role of connective tissue in understanding function and dysfunction in the human body. My hope is also that in subsequent meetings, we will have time to discuss the many new discoveries regarding mitochondrial dysfunction, because that is another factor that confounds recovery. Thank you.
Thanks very much. And if you want to stop sharing, we will now move into the panel discussion. So this discussion is open for all panelists and speakers at this time, and you should raise your digital hand. And one of either Michael or I will call on you, and then you can unmute and ask your question. So I'm sure everybody's been waiting for this time, so let's begin. Okay, so we have a question from Heather Tick. Heather, you want to unmute yourself?
Sure, thank you. Question is for Dr. Serbel. Does your group have a theory as to what is the fundamental neurogenic lesion that may be the origin of the neuropathic changes?
Yes, thank you, Heather, for that question. That's really a core question of ours. And if we kind of drill down into the sort of the mechanisms of CSENS, and I'm going to call it CSENS because I can't keep saying central sensitization over and over again, but CSENS One of the key determinants of CSENS is a persistent nociceptive input. And so if we look at the profile of clinical conditions that do that, there's only a couple. And one of the ones that we've kind of honed in on, and I have with this animal model, is osteoarthritis. You know, and so we know that age is a risk factor, a strong risk factor for both osteoarthritis and chronic MSK, but nobody's actually drawn that connection. And so our animal models are actually looking at that, and I presented some of that data earlier today. So persistent nociceptive input, it could also be an underlying tumor or some sort of metabolic disease that is sort of ongoing and persistent as well, but it needs to be persistent. So osteoarthritis, I believe, is and this is one of our hypotheses, is one of the key primary pathologies that drives the clinical manifestation of chronic MSK, because we don't see these conditions in children.
Have you considered a primary neurological injury, such as at the nerve root, as it exits the foramen?
Well, we have, as a group, we've had many discussions. And so I think the key difference between myofascial pain, I mean, I think you're referring to neuropathic pain in that situation. And obviously the pain presentation is very different. The clinical presentation is very different. So in the case of a chronic MSK, you're looking at a diffuse, ill-defined condition. Obviously neuropathic, you would have much more defined. It would be burning, lancinating type pains and so on. So I think you're talking about the Chan-Gun early.
Correct, yes.
Yeah, so I think, well, we're looking at more of the functional changes in the nervous system in the absence of pathology. So there's a very distinct difference between the neuropathic and the neurogenic mechanisms. I think we're trying to draw on that. I don't know if Lynn and Jay want to add to that.
Jay or Lynn, please unmute yourself if you'd like.
Yeah, I just would like to sort of reinforce this is Jay. Can you hear me? Yeah, just to reinforce the comments that John made with respect to the persistent nociceptive bombardment. And Heather, I think one of the important things that Mensah's work has shown us is that even sub-threshold potentials occur particularly in chronic muscle lesions. And these can cause sensitization even without pain. So that's why I think trying to distinguish the gun model, which is looking more at the sort of the neuropathic from this neurogenic. Yes, it may be a bit of semantics, but I think if we try to adhere to the IASP terminology and nomenclature, that may help us. Curiously, he's done experiments, as you probably know, where injecting nerve growth factor, can induce sensitization without pain. And what stimulates the release of nerve growth factor, TNF alpha and interleukin 1 beta, two biochemicals that we found elevated in active trigger points. So it's an interesting observation, and it's a great question.
So I would like to add the issue of the relationship between the mechanical changes and the functional measures. In other words, what is it about the myofascial unit that enables us to be able to see abnormal movement? This ties in with what Dr. Barb was talking about earlier. If we can understand how the structural changes, by structure we mean maybe the presence of an active trigger point, or and you'll hear more about this from Dr. Sigdar, the imaging changes that look at the actual textural abnormalities of muscle. They are switched to an inhomogeneity that is measurable. If that could be linked to these biochemicals and hyaluronan, and then relate that to the mechanical abnormality that we see, namely range of motion or the repetitive strength decrement, I think we really will be getting to the structure function connection that we're very interested in the more mechanical model rather than the neuropathic model.
If I can add to that as well, I think we are very interested in this idea of the changes at the membrane level as well in the absence of overt pathology, i.e. neuropathic changes. So things like amplification due to increased activity of the NMDA receptor, for example. That's a key transition. I think somebody spoke to the concept of the transition from acute to chronic pain. I think that really, in my mind, from my work, the demarcating point is that transition from the AMPA to the NMDA receptor, which then can upregulate a number of different cascades and sensitization. And so that's the step that needs to happen that precedes the neurogenic inflammatory response. So I think that's really what we're looking at. And I think that is the mechanism that really describes a lot of work done with these viscerosomatic reflexes that Dr. Shaw and Gerber have published on in the past.
So Dr. Serbel, going back to Dr. Tick's question, is that being driven potentially by deinnervation in the case of the neuropathic condition, or do you see this as a separate mechanism that's due to inflammation or overactivity in the nerve and not deinnervation?
Yeah, deinnervation, I think, can create a facilitated segment. So that's through other mechanisms. But I think deinnervation, depending on the mechanism, if there's damage to the nerve, it's a very different clinical presentation as to what we see with chronic MSK. So I think, yeah, there's a number of different, and somebody spoke to the phenotypes, the heterogeneous phenotypes to musculoskeletal pain. I think, yeah, there's a number of them. We're focusing on the myofascial component. And I think, again, what needs to happen in this mechanism, there has to be a primary pathologic source that is persistent. So this is why a muscle tear, for example, will not lead to long-term sensitization because it's self-limiting. We rest the muscle, it's highly vascular, it heals quickly, and so on. But a disc, chronic disc, DJD, DDD, I mean, they're with us forever.
And that leads to changes, as Lynn Gerber was referring to, in that myofascial unit.
Absolutely.
Got it.
And that's a really key point here. Mm-hmm. We don't know the temporal relationship between, let's say, a vascular injury or a traumatic injury that then puts the muscle at risk for a change in motor pattern. Once that sets itself up, then you see collagen, shall we say, production or metaplasia. We're not sure about that yet. And we begin to see the long-term effects of change in motor performance, which then sets up the engram at the central level. It may be related, Dr. Jacobson was speaking about fluid flow. It may be related to that as well. Muscle, we know, acts as a good pump. I've gone on too long, I'm sorry.
Excellent points, Dr. Gerber, thank you.
I saw that Leland had their hand up initially. Is there something you want to contribute to this conversation as well?
Yeah, actually, I had a question for two of the panelists who talked about basically teaching clients or patients self-therapeutic methods. And in my line of work, that's something that I kind of run into, particularly when working with whether it's athletes or tactical operators, like people who are in SWAT or special operations and stuff like that, where I spend a lot of time educating them. And I just wanted to get your feedback on if you've seen any disconnect between current clinical practices in terms of, like, there seems to be a notion that, therapeutic sessions should be lumped to 30 or 60-minute sessions. And is that limiting in terms of actually promoting healing, so to speak? And what type of changes that may need to be in order to actually taking the research work into the clinic in an effective way so that it does contribute to long-term beneficial outcomes. I hope that question made sense.
Yeah, there's a lot to unpack there. This is Nikki Monk. So I think one of the things that you're speaking to is really sort of the framework within which, at least my field, massage is practiced, that isn't necessarily conducive in most environments to a shorter, smaller session. And that has to do, I think, more with the way that the field is framed at this time, and the way that it's tends to be accessed from a service standpoint versus a therapeutic treatment standpoint. So there's all manner of things that tie into that. But I want to go, and I think maybe I heard an underlying piece with this is with your question, and that is, how do you effectively teach and then engage folks? Was that part of your question into doing their self-care?
Correct, yes. Like I have my methods, but I just wanted to get your insight on what you found to be effective.
Sure. Well, my research, I've only done a little bit of research into this. I've done now 4 different studies that are teaching folks how to do this work, and then they go and do it for themselves. And I find that folks are very enthusiastic to begin with. And then over time, it sort of starts to fall away, whether that's doing their own self-care treatment or self-care treatment within a partner delivered type massage model. And so our next step is looking at some of the behavioral pieces and behavioral motivation pieces that need to be also included in that educating section for self-care to get folks to continue to engage in those pieces and put stock into that.
Thanks. So Thomas Myers has his hand up. Thomas?
Yeah, hi, thanks. And I greatly appreciate the panel for a lot of interesting things to think about. Now, primarily as a clinician, first a physical therapist and now a total joint replacement surgeon, and I don't care who speaks to it and who's most qualified, but is this uniquely an American phenomenon? And like, do we have any insight as to, so we tend to lead the world in obesity, school shootings, political polarization, you name it. And so we probably lead the world in myofascial pain syndrome. And how much of that can we actually expect to modulate and that kind of stuff? So I just want to speak a little bit to society's expectations and patient expectations about, how that may influence all this. And then the second thing is, again, chasing pain can frequently be a very challenging thing with patients. And so I'm interested in function as much as pain. And are there any, from the clinical realm of things, what do we have as far as functional scores like an SF36 or a WOMAC or a Knee Society or PROMIS? Like, are there any validated scoring systems that we have that will tell us that whatever interventions we choose are actually working? How do we know that we're making clinical impact here? Or it's good to define all the other stuff we're talking about, but at the end of the day, we want to make sure that we're changing clinical outcomes. Thanks.
I'm a little confused about the question that this is an American phenomenon. I don't believe it is. In several of the countries, they might call it myalgia instead of a myofascial pain. That's typically used in like Denmark, Netherlands, things like that. But it is not an American phenomenon. A lot of the research is coming from Australia, Japan, name many others as well.
Is the incidence as high there as it is here?
Yes.
Yeah.
Very high. I'd like to comment on the outcome measures. Our group, Dr. Sigdar, Dr. Shah, and I, we're fortunate to be able to do an intervention study looking at soft tissue, myofascial trigger point twitch response study. It's a mouthful. Basically, we looked at people who had no signs of myofascial pain and people who had both clinical findings, and we were able to score them on a number of self-reports and physical exams. Our battery of evaluations was quite extensive, and I do not think it's useful for a doc in a box, but here are the key domains. Number 1, range of motion, that improves. Symmetry, especially of movement, in the upper trapezius is a very sensitive metric for looking at response to treatment and to severity of pain. What we also did was, because we're physiatrists and we are interested in function, we very much focused on the other metrics of function: sleep, quality of life. And yes, we use very standard metrics to demonstrate that myofascial pain syndrome is not a regional problem. It's a more general problem, has significant impact on function and daily activity, all of which we demonstrated improved with the treatment, namely dry needling, and the reduction in pain and the conversion of active to latent trigger points. Happy to share those data with you. And we did 8-week follow-ups and noticed persistent improvement. So yes, there are standardized metrics. Yes, it has functional implication. And yes, we believe that there is an effective, we haven't proved effectiveness yet, but an effective treatment for reduction in symptoms and improvement in function.
Great, thanks guys.
I could just comment on that.
No.
From the structural integration point of view, of course, people come with injuries, but what we really see more often is widespread inability to stretch rigid fascia and fascia that's very dry and not hydrated. And that's why we are interested, as David Lasondek was portraying, in treating the whole body and getting the whole biomechanics better. What we are lacking is quantitative measures of whole body biomechanical fitness, head to toe. That would be wonderful if we could develop that.
Dr. Myers, I'd just like to comment on what you might be observing. America also leads the world, the developed world, in ill health. So out of 17 countries, we rank last in terms of well-being and longevity. And we also are one of the only, or the only developed country that has no universal health care. And so while the incidence may not be higher than in other countries, the prevalence may be, because we may have persisting disease from people who do not have access to care. And we also have many factors. There is an IOM study that looked at American health in perspective of the rest of the world. And it's called Poorer Health, Shorter Lives. And it gives many reasons why that may be. The access to food, pro-inflammatory lifestyle, people needing to work 3 or 4 jobs in order to put food on the table. So the basic determinants of health in our country for a large swath of people is not very conducive to healing.
Thanks. So Alan, you've had your hand up for a while. Would you like to unmute yourself?
Yeah, the question I had is maybe for a later session, but there was a lot of focus on the neurochemical changes occurring in the setting of myofascial pain, or in models, or even in humans, which is fine. One might expect that there would be an NSAID responsiveness, and in fact, in Helene's talk, that was one of the items on the list of management. But I'd come back to the issue of fibromyalgia, which of course, as we know, used to be called used to be called fibrositis, because they thought there was an itis component, and that was ruled out. And yet, in our pre-meeting discussions, it was very clear to me from everyone that fibromyalgia and myofascial pain are really co-occurring. And the question is, does that mean that fibromyalgia does indeed have an inflammatory component, or that these are just comorbid conditions that are independent of an inflammatory component?
Can I respond to that, Alan? So there is, it's not an inflammation like we think when we think about a big inflammation, but there are changes in the immune system systemically, and there may be changes locally within the muscle as well. So maybe a widespread, more inflammatory immune system maybe sensitizing some of the peripheral factors and the nociceptors as well as the central nervous system to produce that. So there is kind of an inflammation. It's not what we think about when you injure your leg or you inflame a muscle with carrageenan in a rat. But it is certainly, there does seem to be some inflammatory changes, some changes within the immune system, putting it in a more pro-inflammatory and less anti-inflammatory state. So I think, yes, that's true. And maybe some of the co-occurrence is that there may be some focal changes. They're co-occurrence, but they are separate entities. Like a lot of things are co-occurring with fibromyalgia. There's a lot of comorbidities with it.
Thanks, Kathleen. Eric Jacobson, would you like to unmute yourself?
Oh, I already gave my comment. I just to elaborate on it. There's a lot of talk about transition from acute to chronic pain. Of course, we see that in structural integration, but what we see very often is there's a lot of inability to stretch, very tight fascia. It's very fibrotic, it's underhydrated, and it distorts the biomechanics so much that people are actually predisposed to injury and to repeated injury. This is another reason that we're interested in treating the fascia through the whole body, as David Lasonbeck had in these beautiful diagrams, and trying to get the whole biomechanics better to reduce the liability to repeated injury.
Thanks. And David, I see you have your hand up. Would you like to unmute yourself?
There we go. Hi, thank you so much. I wanted to actually go back and comment on Lialam's question about teaching self-care. I just wanted to add a few anecdotal things from my own practice. I do find that duration matters. For convenience sake, for just the sheer monetary sake of what people have to pay out of pocket, I have tried at various points in my career to adopt a half-hour model, and by and large, I have found it to be ineffective. And I'm not entirely sure why. One thing I can definitely point to, at least in those crucial initial visits, you can spend the first 20 minutes just in the interview process with the patient, and that only gives you 10 minutes for treatment. And more importantly, and I notice this right now because my clinic is open at this time, people are coming in much more highly stressed than they normally would be. I have no idea why. But I think we can all relate to that. And it may take a good 20 minutes to get them to down-regulate enough to be able to receive the work in the manner intended. And there's some preliminary fMRI studies out there now that seem to indicate it can take time to really talk, if you will, to the insular cortex in an effective manner when you're dealing with touch and tactile-based therapies. And to that degree of tactility, some of the more interesting objective things coming out of the studies on foam rolling and self-myofascial release, as it tends to be termed, is that softer is better. And we still have that no pain, no gain idea here in the culture, which is really outmoded. So I have people who don't understand why they're not getting any better from rolling because they're doing too much of it and they're doing it too aggressively. Whereas a softer material, you can ease yourself into, you can't negotiate with a golf ball very well, but you can negotiate with something softer than that. So that's one of the big things that I engender in when I am working with self-care. So I hope those little pearls were helpful.
So
Thank you, David.
If I may just comment real quick, and those are excellent points. The half hour not being very effective. In my experience, I've found that 90 minutes is kind of like the minimum threshold for the person to start. Actually, what I've found actually what you run into is a person who is not familiar with this can't assimilate the information sufficiently to apply it. Or they just, basically you have to spend some time to really truly educate them so that they actually absorb some of the information. And with some of my more long-term clients, believe it or not, my first session is 3 hours long. And what I've found is actually, yeah, I know it sounds crazy, but efficacy has been.
Hey, if it works for you.
Yeah, like I basically make it work because I have the flexibility, but that's where I find that there's actually a really long lasting efficacy for the benefit of the client. But anyway, I'll just leave it at that.
Okay, Mary?
I just wanted to address something that was said earlier, that muscle is really quite plastic and heals. It actually doesn't. There are a lot of studies that show that muscle does not heal entirely to a restorative original basis, that you have lingering changes in fibrotic tissue that can be problematic to biomechanical use, and lingering changes in neural innervation and the vasculature. So we shouldn't think of muscle as entirely neoplastic and grow back just the way it was. There are problems that even with 12 months of rest, and several studies have shown it does not recover back to normal.
Can I just ask a clarifying question, Mary?
Yes.
So when you say muscle, you're talking really about the whole muscle fascia environment, because the muscle itself and the muscle fibers, you're really talking about the fascia surrounding the muscle.
I'm talking, yes, you're right. I'm talking about epimysium, endomysium, perimysium, the connective tissue that can build up around the muscle spindles and the neuromuscular junctions, etc. Not
Right.
myofibers. Thank you.
Myofibers themselves are actually do heal quite well, I think.
Yes, it's
Right.
the fibrotic or the adjacent tissues that still remained with some lingering changes.
So I actually think this is kind of an important point, because we talk about muscle pain, and most of what we're talking about is probably coming from tissues other than muscle. It's probably coming from the fascia, the fibroblasts, the immune cells that are all sitting in the fascia itself.
Or tendon, because
or the tendon, or
tendon
right.
slip changes in the muscle.
Sure.
Yes. Yes.
Okay.
We are in agreement.
From a clinical perspective, one who's treated repetitive strain injuries for a long, long time, I would agree with you. That's why people with RSI don't get better just from rest. They need treatment in addition to that. And so they need the kinds of treatment that we've heard the panelists talk about today to stretch, to restore circulation, and to improve the hydration of tissues.
Great. Jan?
Hi, yes, I'd like to go back to the self-care question, and just say that for how I teach people, clients, patients, it's really a step-by-step process and starts with the mind-body connection. It's like teaching someone how to fish, right? So building the skills of them being able to notice when they have a thought and they're thinking something, what happens in their body. And little by little, and then how to touch. Not just that you do an exercise, but actually how to have your hands so that they're soft enough so that you can make contact and actually move the tissue, like all the things that I do on them to help their move and quell their headaches and migraines. I teach that step by step. And so then that gives them much more motivation. A lot of the process starts with hope and really being able to boost them in such a way and coach them in such a way that they feel that they are empowered and that they can, and that helps clients. And we had a small study in 2078 migraine patients who really short course, 2 hours a week for 4 or 6 weeks, depending on the institution. And there was a 41% reduction in the number of migraines and 52% reduction number of abortive medication. But what I thought was really interesting was that 97, even though some people were still having migraines, that there was a 97% of them felt that they had more control and they were better educated about their migraines. So just that their attitude changed, I feel, helped with the self-care, even though they were having some pain.
Thank you, Jan. Nikki?
Thank you. I have one additional comment around the self-care, and then I have a question for Dr. Lazondek. First, I hope that it did not come across that I was suggesting that therapeutic massage should be deconstructed to little segments of 15 or 10 minutes, and that's the way therapeutic massage should be delivered. That isn't necessarily that's not my stance. But I think that the therapeutic massage encounter, as I think highlighted by Dr. Lozondak's comment, is likely addressing myofascial pain from many different directions and not just from the singular trigger point piece. So the whole therapeutic encounter is very important in the management and care and all of that. And it's more about cultivating a partnership with the patient and with the clients to be able to do some of those shorter, repetitive, mechanistic pieces where they're actually addressing the trigger points in between times, and then they come in for the therapeutic encounter to continue that work and to sustain that work. So that's one piece I just wanted to follow up on. And then my question to Dr. Lozondak is, you talked about the palpable release, which absolutely I've experienced and we talk a lot about in therapeutic massage realm, but is there, from a measurable standpoint, is there some sort of technique or observation process that's been validated that can point to what this release is for clinicians to be able to take into practice?
Okay, I need a little clarification here. Are you speaking, Nikki, to there are individual techniques and then there's a course of treatment from the beginning and end to the session. So are you referring to the specific techniques or the general approach?
I'm talking about an approach to a validated assessment, like a measure of that release. So we're talking, a lot of the presentations we're talking about mechanisms that could be measured.
That's one of the things, yes, that's one of the things that, yeah, that's one of the things I'm hoping that we could get out of this. Is a way to better measure and validate the positive outcomes of those releases. So the more we can measure and validate, the more we can then in the business world, in the spreadsheet medicine world, validate what we're doing, and we can open up what we do to a broader socioeconomic population, which I would really love to see. From an observational standpoint, and this happens all the time when things go well, is if you have an asymmetry, if you have these pathoanatomical deviations, as I outlined in my slides, and you have a specific intervention to correct it, the patient gets up off the table, which is important. There's routine, test drives, as I like to call them. Get up, try that, experience what's different midstream in the middle of the treatment. And you actually see, oh, that leg is a little straighter. You put your thumbs on the ASISs and you say, oh, that ASIS is, maybe half an inch or an inch higher than it was when we started. We could measure that with goniometers. We could also use, little dots in cameras and software and measuring techniques. More powerfully for the patient is you have a mirror and you point out the deviation, and then they get up off the table and they see in the mirror, they feel it in their body, but they also see in the mirror, hey, that actually does look different now. And it's strange, but that visual reinforcement sometimes actually helps to further reinforce the inner proprioceptive and interoceptive sensation that something is better. And then you show them, okay, here's how to keep moving this area, and here's what to watch for in your awareness, so that when they leave the office, you've given them more mobility. If they exercise that mobility, they're more likely to sustain that change. Did that answer the question you were going for?
Partially, thank you.
It's a big topic. It's a big, chewy discussion.
So we have 3 minutes before we open this up more broadly. So I'd like to move on to John.
Yes, thank you. I just wanted to circle back. I think there's a common theme here, or amongst many of these comments, the difference between musculoskeletal pain and myofascial pain. And in effect, musculoskeletal pain, and we've had this discussion with our group many times, and I'd like to hear maybe some of the comments from the group, but musculoskeletal pain would be, in our sort of view, is a structural injury to the myotendinous unit, either macro or microscopic. And it's a well-defined clinical presentation, right? It's well localized, sharp stabbing, And and if you neurophysiologically, if you apply pressure to that area, it induces a withdrawal reflex. But I alluded to in my talk that myofascial pain presents very differently. And so it doesn't seem to fall under the umbrella of this, quote, musculoskeletal pain, where it's ill-defined, first of all, it's deep, dull, achy, and it doesn't induce a withdrawal reflex when you apply pressure. In fact, patients want more pressure. So I think that is kind of, that's something that's been sort of percolating amongst some of these comments. And I think that's, as a group, I'd like to kind of hear some of the ideas from the various corners, see what people think about that. Could there be a common mechanism there, or are they very different?
Does anyone want to respond?
Yeah, from a structural integration point of view, you cannot have what you're calling musculoskeletal pain without serious disruption of the tensions and fibrosis in the fascia. And that's part of what makes the joint pain chronic from our point of view.
Mm-hmm.
But myofascial pain could easily be the release of the calcium, like with leaky sarcoplasmic reticulum. So there are micro tears that just release the calcium, and the calcium's not reuptaken correctly. And that would create some of the deep pain, not like a sharp pain. And that could be long-term, irritation until the sarcoplasmic reticulum heals, let's say. I don't know how long that takes.
Dr. Barb, that sounds like it could be referring to the differentiations in types of C fibers that could be activated. Now, with the with all the new molecular markers they have for looking at different types of C fibers, maybe there's one type of C fiber as opposed to another being activated, let's say in what we're calling, or what Dr. Sorbella said, that musculoskeletal pain as opposed to myofascial pain. It's a possibility that could be tested in animal models.
Good point.
A chemical or a sympathetic type C fiber, because there are crossovers.
Carla, was that something you want to respond to?
Can I just focus one point? I have quantified the sympathetic fiber in fascia respect to C fiber fiber, and we have 90% of C fiber and 10% of sympathetic fiber. So that is just to have an idea. Then we have a different density of fiber, C fiber, in the different type of fascia. So we can't speak just about fascia in general, but the aponeurotic fascia, as the thoracolumbar fascia, has a totally different, much more amount of C fiber respect to a gluteal fascia, respect to an epimysium or perimysium or endomysium. So we need to be very precise when we speak about the role of fascia, what fascia we are considering. Is the superficial fascia, the deep fascia, the epimysial fascia? They have a totally different connective fiber. Some are more collagen type 1, collagen type 3, elastic fiber, different type of innervation. And only if we start to be precise, we can understand the role of fascia in pain.
So Dr. Stecco, have you looked at different types of C fibers, such as those that are responsive to histamine as opposed to those that are responsive to, let's say, TRPM8 or the TRPV1 as opposed to TRPA1? Have you looked at use the molecular markers there?
No, unfortunately, I have just quantified the type, the amount of C fiber.
So with 90% of them being C fibers, there might be really a whole, bunch of one type as opposed to the other, and it might actually change which ones are being activated by the different physiology.
We also know that if the fascia is chronically inflamed, the amount of C fiber increased, and the spinal projection is enlarged and take more spinal level. So all that aspect has to be integrated in the different discussion, I think.
Thank you, Dr. Stecco. Thank you, Dr. Oshinsky and Dr. Dare. I'm actually going to move us now into the open Q&A portion. So feel free for my panelists who have hands up if they want to lower their hands, because the next time you raise a hand, it might be because you want to help answer a question from our members of the larger audience. You'll note that in the Zoom chat, we've been aggregating questions for your consideration. And so I want to start with a question that's been posed from a member that's come in from our webinar queue inbox. So this is likely from one of our video cast watchers. They're saying, for the panelists, where are we at this point with establishing an agreed upon clinical criteria for diagnosis of a quote unquote myofascial pain syndrome? Dr. Oshinsky or Dr. Dare, who would you like to kick it off with that question?
I think maybe we could start with one of the clinicians in the bunch. Maybe Dr. Sondak. Do you want to address that?
Thank you.
Thank you. I was honestly, I was hoping someone else was going to jump in on that one. So I want to thank you for putting me on the hot seat. I think this is something that we're all striving towards. I think this is something that this conference itself is pushing the ball further downfield to try to come up with a specific yet encompassing definition that becomes a legitimate, diagnosis code or an ICD-10 code. And these kinds of dialogues, like we just spent the last 45 minutes, are essential because we can get very reductivist in our models, or we can get too big and broad in our models. And we need to come to a place somewhere in the middle and keep in mind that always what the end goal is how do we make this more real to the medical world at large in helping the patients that we serve. So my answer is I'm very hopeful we will get there. And this is just another step in that direction.
I'm going to try another clinician, another hot seat here. Dr. Gerber, would you like to try to address that?
I was hoping to duck and cover, but our group.
That's why I chose you. You get the best answer that way.
Thank you. Our group headed up by Dr. Shaw and one of our IRTA fellows, V. Fan, who has engaged in a medical career starting this year virtually, published a paper after years of searching for consensus through literature that had been published from 1990 on, taking the approach that we identified keywords that were likely to be in either the abstract, or then if they weren't, they were out, but if they were, we went into the paper itself to determine almost a, shall we say, a democratic approach to terminology and phrases that would help identify myofascial pain syndrome. This is what we found. We found that the use of the Trevelyan-Simons criteria was used in about 80% of publications. And by the way, our European colleagues used it much more frequently than our American colleagues. Number two, there were the common constructs of trigger point, pain, abnormal muscle function, either range of motion or functional activity, which were very commonly used. The things that we were hoping to be able to identify, regional pain syndrome, etc., separating this from MSK, we've spent a lot of time talking about neuropathic pain versus not. That really was not helpful in terms of published literature. I'm happy to share the reference with you. It's been published. And here is something very fascinating, and I'd really like Dr. Sluka to be thinking about this. We have seen enormous changes in where these studies have been published. Initially in clinical journals, no surprise, I'm a rheumatologist and a physiatrist. A lot of the rheumatology world is interested in this kind of problem, which then evolved into the more physiatric and physical therapeutic literature. Then we saw an explosion of pain. So the pain literature, which has really kind of ebbed a bit. And now physical therapy, and to the point of, I believe his name was Lelam, asked us, how do we do treatment evaluations? How do we determine outcome measures? So we've seen a natural history to actually the study of myofascial pain syndrome, and it has not yet landed, in our view, on a succinct definition of the syndrome. There are key phrases that are very frequently used, and we did make some recommendations. I'll leave that to your reading of the paper to learn what they were.
Dr. Oshinsky, we've got numerous questions. So if you don't mind me moving on to the next question at this point.
Oh, go for it. And Leslie, you can take over here if you want to select who the answer is.
So actually, Dr. Rebecca Baker, we had a question specifically for her. So Rebecca rejoined us to respond to this question. Rebecca, are you available for this question? Have you tried looking at, the question is, have you tried looking at reasons behind people, looking for the reasons behind which people which use medication but do not develop addiction versus those that do? So this is really going back to the larger HEAL presentation that Rebecca gave at the start of our workshop today. And how much effort is being made to measure resilience before prescribing drugs? So Rebecca, do you want to take that one? Please feel free to unmute.
Thanks. So it's obviously a really important issue. Our approach to posing the question, who's at risk for developing opioid misuse after receiving an opioid prescription, has mostly been to take kind of a literature-based approach as opposed to supporting a new large cohort study, in part just because of the time that we have. I think that there is research out there about who, certain categories of people, for instance, someone with a co-occurring mental health condition or other factors of the type of pain that they have might make them more vulnerable to misusing prescription opioids. But it's certainly a question that cuts across a lot of our research. And I would also say it's not just that we want to step in and interfere with that circumstance, or recognizing that someone might be at risk and then not providing opioids, but rather would like to have a lot of options for people and patients so that opioids and a few other specific medications weren't the only things that we were doing. And that would really, I think, reduce risk across the board. So not just kind of teasing out the specific groups who are going to be at moderately increased risks, but allowing the community to take advantage of a number of multimodal and complementary approaches to reduce overall reliance on opioids.
Thank you, Rebecca. Just as a follow-up to that, there have been some very large studies, such as one done by the DoD, where there was more than 100,000 patients that were prospectively tracked after they were given opioids. And we found that there were about 5% of them that then led on to not just in the case of overprescribing, but did lead to what would be characterized as an opioid misuse disorder. So it's not a large percentage of the population, but when there's a large number of opioid prescriptions written, in the case of like 2016 or 2017, there were 220 million prescriptions written, it turns into being a lot of people if we're talking about 5%. Now, the exact genetic markers, that is a focus of research, and there is ongoing research in the HEAL initiative and also in other institutes at NIH, such as NIDA, that is answering this question. And if we didn't have an answer to that question, it would be wonderful to have a blood test or skin test or even a genetic test that you could do to figure out which patients will be susceptible. But at this point, we are not at that stage.
Well, thank you. Thank you, Rebecca, and thank you, Dr. Oshinsky, for answering that. I really appreciate you returning, Dr. Baker. The second question we have coming in from folks who've been watching or are on Zoom is being directed to Dr. Shah, actually. And it's asking, any research that has shown in those asymptomatic patients with trigger points, have correlations been made with the presence or absence of any of these inflammatory mediators and cytokines? So Dr. Shah, if you'd like to unmute and address.
Yes, yeah. Thank you very much for the question. Can you hear me, Catherine? Okay, so in our original studies that Dr. Gerber and I did with our group in 2005 and 2008, so initially we had people with chronic cervical pain who had a active trigger point in their upper trapezius, and that was the cause, presumably, based on the clinical exam of their pain. When we looked at, and so actives had more elevated levels compared to latents and normal. So, but then when we looked at, in our second study, we said, what if we looked at a distal unaffected muscle in the similar three groups? In this case, it was the medial gastrocnemius muscle, in which there was no palpable trigger point. And we found in that group that the people who had active trigger points in their upper trapezius, so they had a myofascial pain syndrome in their trapezius area, also had elevated levels compared to the other two groups in their medial gastrocnemius. So what does this tell us? Well, perhaps there is some underlying systemic condition, perhaps, that maybe predisposes them to developing myofascial pain, or is the fact that they now have a syndrome or chronic myofascial pain now predisposing them to more systemic changes? It sort of begged the question, we should look at plasma markers, other things like that. So I hope I answered the question.
Thank you, Dr. Shah. And we'll try to get in one more quick question here before we need to move to our noon lunch break. One of the questions we have is, can myofascial pain syndrome lead to cell necrosis? Also, what signaling is responsible for the cell apoptosis when the cells are subjected to shear stress and rapid movements? Who would like to take that one? Who do you think, Dr. Oshinsky? I see Dr. Barb.
Yes, that's Dr. Barb. That's what I was going to say. Yeah, Dr. Barb raised her hand.
Mary,
Go ahead,
please.
Yes, there has been cell necrosis. Part of it is an autophagy system. The cell was delineated by the body as having some problems. It could be a metabolic problem. It doesn't have to be a frank tear, but a metabolic issue. So the ubiquitination process is turned on and that cell undergoes a necrosis. So yes, there are studies for that. The Huang and Zhang's group have shown in the model that I presented that some of that necrosis can occur, but there are other models that show that as well within other tissues additionally. The other question was what? There was like the necrosis and there was a part two.
And then it was, what about signaling is responsible for the cell apoptosis when the cells are subjected to shear stress and rapid movements?
In bone, it's hard, I know everybody go bone, but the osteocytes have bones have very long processes that undergo a lot of shear flow, and it can be very similar to fibroblastic sort of shear flow, stretch and strain. It's the Wnt signaling pathway that can then drive some of this, and then sclerostin, and the sclerostin turns on, and it's creates like a phagocytic drive, and cells will come and eat the cell that's up-regulated at sclerostin. And obviously they're not feeling pain because these are osteocytes, but they're turned on by the mechanical stress, and all the shear flow can upregulate the sclerostin, and then that will make an osteoclast come by and eat them. It's presumably the same process in other tissues.
That's great. Dr. Oshinsky and Dr. Dare, should we take one more question before we move to lunch, or should we stick to our schedule as close as we can and go ahead?
I think we've done such a great job sticking to the clock here, and I think everyone's going to appreciate that. I mean, we might as well reward everybody by doing one more question.
Okay, wonderful. So we're going to do one question here. I'm just going to grab this last one that came in, or the fifth one here, that says, I read about a study using rats that showed with a sustained stretch, the rats were able to slow the spread of breast cancer cells and even reduce them in number. Has this study been replicated? What do we know about the connection between myofascial release work and cancer cells? I think this might be with Dr. Langevin's department.
Yep. This was the work that started at Brigham and Women's Hospital when my lab was there, and that we're continuing to work on this now in my lab at NIDCR. We published the original study using a P53-P10 breast cancer model, and we're currently replicating it in a different model, that is actually can be induced spontaneously occurring tumors to see whether stretching can be preventive. So yeah, that was the work in my lab. And we looked at some immune markers associated with that response of the decrease in the volume of the cancer lesions, but we're continuing to try to figure out what is the mechanism of the beneficial effect of stretching.
Wonderful. Thank you, Dr. Langevin. I just, Dr. Hensel, I see, did you wish to?
If I could just throw a little bit on, from an osteopathic perspective, that relationship actually makes a lot of sense. It's something that we talk about frequently in osteopathic, with an osteopathic approach, that since the lymphatic channels travel through the fascia, that if that fascia has that fibrotic, tense feeling, it could restrict lymphatic flow. And thereby stretching or massage or osteopathic manipulation, anything that opens up the fascia, can improve that lymphatic drainage and optimize the reaction of the immune system. Lisa Hodge has shown lymphatic pump techniques affecting both breast cancer cells, strep pneumonia cells, and affecting a large change in the immune response of the body. So from our perspective, that makes a lot of sense.
Thank you, Dr. Hensel. I think with that, it's 5 minutes after 12. We're going to move to lunch. And I just want to let our wonderful viewers know and our Zoom attendees that we received over 40 some questions. So with 15 minutes, it was going to be impossible to hit them all, but we will do our best to find a way to address some of these as we can, aggregate them, or find themes. We'll do our best as the meeting progresses. And if not, then I'll talk with my collaborators on whether we might be able to do some post-meeting outreach to address some questions independently. But with that, I ask all of our panelists to please go ahead and mute and turn off your video. And we're going to go ahead for our lunch break, and I will see everybody back here at 1 p.m. sharp for the start of our afternoon session. Thank you so much for the wonderful start to this meeting. Now invite members of session 2 who would like to re-engage their videos to do so. And I'm also going to return the muting and unmuting rights back to our folks.
So it's 1 o'clock. Shall we start?
Certainly. So let's begin. It's 1 p.m. and I'd like to welcome everybody back to session 2 of our meeting today on the myofascial pain syndrome. Session 2 is current structural imaging approaches with potential application to myofascial pain syndrome. This session is being chaired by Dr. Guoying Liu from NIBIB and Dr. Marav Sabri from NCCIH. Dr. Liu, please take it away.
Thank you so much, Catherine. So welcome to session 2. I am Guoying Liu from NIBIB, and co-chairing this session with me is Dr. Marav Sabri from NCCIH. So now we have learned from the opening session that there are a lot of very interesting questions, and a lot of things about myofascial pain are not very well understood. So we need tools to help us understanding, diagnosing, and treating this condition. So we have needs here, and we also have opportunities here. So in the context of biomarkers, having non-invasive imaging techniques that can then be used to develop specific biomarkers for quantitative assessment of myofascial tissue can be very valuable. So it would then enable repeated measurements and longitudinal studies to help shed light on how to help us shed light on how to manage our patients. So in this session, we will hear about imaging techniques perhaps are more mature along the technical development continuum that are perhaps closest to being used for quantitative evaluation of myofascial pain syndrome. Thus, this is a session that would function as a link between session 1 and the rest of the workshop. So now I would like to share my screen, upload this. So can you see this uploaded? Can you see the slide now?
Yes, we can see your
All
slide.
right. Yeah, so the topics that we have chosen for this session are primarily structural imaging techniques. So that would cover if you look at this beautiful framework and common theme slides that developed developed by Dr. Langevin, you will see that this session is about primarily structural imaging that cover this upper left section on this diagram. And we will also touch a bit on the vascular aspect of myofascial tissue, and you will hear about angiogram as well as blood flow and perfusion. So at the end of our discussions and towards the end of the workshop, one of our charges is to expand and refine this framework. So that would help us tremendously in order to pointing some action plans and future directions. So I would like to have a brief overview of how this session is organized. We are very excited to have 4 speakers and 4 discussants, all leaders in their respective fields. So I'm very happy to have you all. And I will introduce the speakers one by one while they upload and share their slides. And we will hold questions until the time for panel discussion and open Q&A. So after the 4 talks, we will move on to the 40 minutes panel discussion. My colleague, Dr. Sabri, will introduce the panelists. And after the panel discussion, we will move on to the general and open Q&A. So now some general logistic reminder. So for Zoom webinar panelists, which include the speakers and discussants, please mute yourself unless you are speaking. Please have your video on during your session. And please raise your digital blue hand through the Zoom feature and wait until you are called. So for our Zoom webinar attendees, you may post a question into this Q&A box at any time during the session. You may raise your digital blue hand to ask your question live during the Q&A portion of the session. So for the video reviewers, you may post a question using the NIH videocast feedback form that have been provided to you at any time. So also one reminder to everybody, please, if you want to download the program book, the link is listed here on the lower right of this slide. So now, let's move on to the talk. So it's my pleasure to introduce Dr. Gary Gold from Stanford. So Dr. Gold is going to tell us about the current MRI approaches with potential for myofascial pain syndrome. Dr. Gold, please take away.
Thank you, Dr. Liu and Dr. Sabri. I'm really happy to be here. This is a very important topic for musculoskeletal disease, in particular in my practice in musculoskeletal radiology at Stanford. Starting with this diagram, which nicely captures all of the varied levels and structure in myofascial pain syndrome, I'm going to be primarily focusing in my talk on structural findings in myofascial pain or in neuromuscular connective tissue that can be seen using MRI. The typical resolution of the MRI scans in this case would be millimeter or sub-millimeter, but not certainly at the micron level, at least not yet. MR has been advancing very rapidly over the past several years. And what we are seeing now are the ability to acquire rapid volumetric imaging of joints and tissues throughout the body with different types of contrast as shown here, and also quantitative measurements, in this case of T2 relaxation time in the soft tissues around the knee joint here. And this is done with a scan time of only 5 minutes in a human subject. And we can do this literally anywhere in the body in humans. We can also scan, in this case, both legs at the same time and get anatomic information and quantitative information from these rapid scanning methods. And there are many different methods under development. Deep learning reconstruction has really impacted the field of MRI, which allows us to take a relatively noisy image shown here and reconstruct it with a different technique using deep learning to get a much better picture of the bone marrow edema and damage around the knee joint here. So this enables us to go faster or go at higher resolution in our imaging methods. Another approach for using deep learning reconstruction is to improve the inherent resolution in the images by using a method called super resolution, which reconstructs lower resolution images shown here on the right with a neural network to improve the image quality shown in the center, labeled Deep Resolve. Here's another example of a spontaneous median neuropathy in the arm. We're looking in detail here at the median nerve. On the image on the left, the resolution and the signal to noise is not sufficient to show the structure accurately, but using a deep learning reconstruction on the right, we get a much better picture of what's happening in this nerve structurally and anatomically. So if we apply these methodologies to the various tissues, what can we learn about structural and other measures of muscle using MRI? Well, one relatively simple approach using deep learning or machine learning is to do automated segmentation of the muscles, in this case, in the thigh, and comparing this to manual segmentation, we get high levels of accuracy of volumetric measures of the muscle. We can do this over the entire lower extremity as shown here, and we can divide the signal between water and fat, which allows us to get a fat-only image on the right, which shows us areas of fatty infiltration in the muscle, and a water-only image on the left, which shows us areas of regular muscle tissue. Now, using MRI for many years, we've been able to measure the proton density fat fraction in the muscle. In this case here, shown in patients with Duchenne muscular dystrophy and another type of muscular dystrophy, the white areas within the muscle seen here indicate fatty infiltration. If you look at the repeatability of these types of methods, you can see that these are very repeatable in terms of measuring the volume and the proton density fat fraction, both in the short and long term in these patients. We can also use diffusion tensor imaging in MRI to estimate muscle fiber length by creating these maps of tractography with the patient either in dorsiflexion or plantar flexion shown here. We can also measure quantitatively the radial diffusivity within the muscle using DTI, which would give us a quantitative measure of diffusion of water molecules through the muscle tissue, which may be altered in conditions like myofascial pain syndrome. I mentioned earlier we can do rapid quantitation of T2 relaxation times. Here's an example where we've provoked this volunteer with exercise in their calf. This area of green here is increased T2 after exercise, which slowly goes back to an almost normal level after about 15 minutes. Similarly, we can also measure both the T2 and the T1 row relaxation times within the muscle. And in this case, we can characterize those as long or short components, which may give us insight to tissue at a microstructural level. And this here demonstrates that we indeed see changes using this quantitative technique in T1 row in the muscle after a stroke compared with the control patient up above. So the T1 row in these various muscles of the arm is increased after stroke, which indicates microstructural change. In this example, where we're looking for a trigger point, we did fat-water separation, these investigators did, and T2 maps of the upper extremities and identified this area of increased T2, which represents a trigger point in this case. We can also measure principal strain directions in the muscle by using a technique called DENSE, and Sylvia Blemker may talk about this later in the conference here. It allows us to actually get a functional measure of strain in the muscle under load. Finally, we can use techniques like chemical exchange saturation transfer to estimate the creatine modulation in the muscle after exercise, or similar methods with different types of spectroscopy to look at muscle energetics. In connective tissue, again, looking primarily at the structural features here, using a relatively old method, which is now becoming a widely available product on the scanners called ultra short echo time MRI. We can get information from tissues which normally appear black on MR images, in this case, the tendons and the connective tissues like the quadriceps tendon and the patella tendon shown here. The information from these connective tissues can be quantitated using relaxation times coupled with the UTE acquisition, in this case showing a T2 star relaxation of the patella tendon harvest site and the ACL graft in a patient after ACL reconstruction. These quantitative measures can be done in all collagen connective tissues, such as shown here in the lower extremity, using UTE imaging and connective tissue imaging in aging. This is a young volunteer on the top row and a more elderly volunteer on the bottom row here, showing the intramyocellular connective tissue in red and the intramyocellular adipose tissue in green. And here we can indeed do automated segmentation of these connective tissues within the calf to quantitate them further. The fascia itself can be seen when it is inflamed, such as in this case in fasciitis, with T2 weighted images and contrast enhanced images. And we can also measure the macromolecular proton fraction here in tendons in various subjects using a UTE T2 star type of technique. So in conclusion, recent improvements in spatial resolution and contrast and speed in musculoskeletal MRI make this a powerful tool to evaluate myofascial pain in humans in vivo. We can quantitatively assess fat and water volumes and other measures such as relaxation times. We can also measure diffusivity in the muscle and quantify characteristics of the connective tissue. Thank you.
Thank you very much, Dr. Gold, for that very interesting overview. So next, we will have Dr. Bruce Damon from from Vanderbilt University, who will tell us about quantitative MRI methods with a potential application to myofascial pain syndrome. Dr. Damon.
Well, thank you very much. Can everyone hear me okay and see my slides?
Yes,
Great, we can. Thank you. Thank you to everyone for being here, and thank you especially to the organizers for giving me the chance to speak. I'll say first that I have no conflicts of interest to disclose. So we've seen this slide and seen that myofascial pain syndrome includes really a broad spectrum in its phenotype. And what we've begun to see and will continue to see is that imaging and other non-invasive methods are capable of characterizing most aspects of this pathology. My goal today is to talk about some MRI methods that are able to quantify vascular structure and function and the tissue level consequences of impaired vascular function. And I'll start at the macro scale, talking about magnetic resonance angiography. So our goal here is going to be to characterize the structure of arteries and veins and the flow through them. There are both contrast and non-contrast based methods for looking at vascular structure, and we can use phase contrast angiography to measure blood velocity and from that blood flow. So here's an example of an arterial angiogram. It's not a muscle example. I'm sorry about that, but it's a very nice example, though, showing a dissection in the celiac artery and the mesenteric arteries down here. So that's a structural image. In terms of measuring blood velocity and blood flow, I think the state of the art right now is what's referred to as 4D flow. So that's 3 spatial dimensions and then measuring blood velocity over time. And you can see up here in this dissection in the celiac artery, for instance, a laminar flow in the true lumen of the vessel, and then this helical flow in the false lumen of the vessel. So moving from that level down to the tissue level, our interest is going to be in measuring perfusion, the tissue mass normalized rate of blood flow. We have a couple of methods in our toolkit for doing that. One of those is called dynamic contrast enhanced MRI. And what we'll be able to use this for, hopefully, is to measure the spatial distribution of inflammation to some degree, and also changes in the vascular perfusion permeability coefficient. The basic procedure is to rapidly acquire images repeatedly as a function of time, and then during that time series, inject a contrast agent. There'll be a signal intensity change that we measure and then analyze to hopefully yield those parameter estimates. This is some of our experience with this method. This is in a local model of inflammation in a mouse, and you can see the inflammation here in the histology. And then this is what a dynamic contrast signal time series looks like. The agent is injected here, and then we see signal enhancement both in the control healthy side and in the inflamed side. I think in our case, the level of inflammation was so great that we violated the assumptions of the model and we couldn't obtain those quantitative parameter estimates, unfortunately. But we do see this persistent signal enhancement related to inflammation. And a number of years ago, Pierre Carlier's group made a similar observation, in this case, in the golden retriever dog model of Duchenne muscular dystrophy, this persistent signal elevation following injection of the contrast agent. Another approach for measuring perfusion is called arterial spin labeling. This does not use a contrast agent. Rather, the inflowing blood is used as an endogenous source of perfusion-related contrast. And so it doesn't use a contrast agent, which is nice. And also the data can be acquired more quickly. So we can make a perfusion measurement, along a time scale of 10 to 15 seconds, which allows repeated perfusion measurements during dynamic events. So as an example of this, these are changes in the ASL signal following a bout of exercise, first in healthy people, and then also in patients who have chronic exertional compartment syndrome, where there's this increase in intramuscular fluid pressure. And because of that increase in fluid pressure, we see the perfusion is decreased following exercise compared to the healthy controls. And we see similar findings in this case in the MDX model of Duchenne muscular dystrophy. This is an ischemia reperfusion experiment, and during that reperfusion phase, we see higher perfusion in the wild type mice than we do in the MDX mice. Certainly decreases in tissue perfusion would be expected to produce a relative ischemia in a tissue. And the main way that we have to look at ischemia with MRI is using a blood oxygenation level dependent contrast, or BOLD contrast. So our goal is to look at that, the presence of reduced oxyhemoglobin saturation. And the basic idea here is that the MRI signal decays more quickly in the presence of deoxyhemoglobin than in the presence of oxyhemoglobin. And there are several different approaches for quantitating that tissue oxygenation. There's some theoretical models. We've used these calibrated approaches in which we take an arterial cuff and inflate it, produce ischemia in the tissue. This is what we see here in this decrease in oxyhemoglobin saturation. Make some MRI measurements of the rate of signal decay. We can see that under conditions of constant blood volume, the rate of signal decay is very well correlated with the deoxyhemoglobin percentage. And so well so, in fact, that we can use this as a calibration curve, apply it to the condition of exercise, and come up with pretty good quantitative estimates of the oxyhemoglobin saturation that agree fairly well with the near-infrared spectroscopy measurements. Of course, perfusion, oxygen extraction, and the oxidative metabolic rate are linked to each other through the Fick equation. And there are also dynamic events that change rapidly during things such as exercise. And so I think you can appreciate how it would be nice to be able to make all these measurements at more or less the same time. There are a number of different ways people have used to do this. I'll show you one example. This is some work from Felix Worley's group at Penn. And his student, Erin England, developed a sequence that allowed her to measure perfusion, the venous oxygen saturation, and the T2 star, which in this case is indicative of a bold effect, at more or less the same time at slightly different locations within the tissue, but very close to each other. And then here's some data from an ischemia reperfusion experiment again. So the perfusion is low, of course, in the resting condition. It goes down to 0 during ischemia. And then when she releases that cuff, we see this big increase in the perfusion that eventually comes back down to baseline. Looking down here, this is the T2 star, relative changes in the T2 star, and we see this decreasing during ischemia, indicating ischemia, and then this overshoot in recovery following release of the cuff. This is the venous oxygen saturation. This is probably artifactual and related to shifts in the distribution of the blood volume during the ischemia. But afterwards, we see, a low initial venous oxygen saturation, and then release of the cuff and overshoot in recovery. The colored lines here represent data from patients with peripheral artery disease. And as the color darkens, we're going from mild to severe cases of that disease. And so we're seeing a gradation of these responses that relates to the severity of disease. Shifting now to a different component of the vascular system, that is the lymphatic system. Of course, the function of the lymphatic system include the transport of fats absorbed from the gut to the central circulation, and the return of water and its solutes from the tissues to the central circulation. Standard approach for doing this is to use diffusion weighted imaging to highlight the lymph nodes. Some colleagues of mine at Vanderbilt are using a long echo time sequence to be able to visualize the lymphatic vessels themselves. They can go in and make some quantitative measurements of their dimensions and so forth. And then in women recovering from breast cancer treatment who may have some lymphatic blockage in the axillary region, we see these, the blocked lymph vessels very well highlighted in the images here. And then following a manual therapy to drain that lymph fluid, they see, a reduction in the size of the vessels. So here showing responsiveness to therapy. Because part of the job of the lymphatic system is to return water and its solutes from the periphery back to the central circulation, we might expect that in disorders of the lymphatic system such as this, there would be elevated tissue sodium. And we can use sodium MRI to do that. Sodium MRI does use specialized hardware and pulse sequences. It's certainly an advanced technique because sodium is at a relatively lower concentration in the body than water. The images tend to be noisier and have lower spatial resolution, but certainly they provide some unique information. And we can see that here. These are some data from a lipedema patient. And what we're looking at down here is, well, first of all, a water image and then a sodium image taken from, an axial slice through the leg. This is a quantitative map obtained through calibration of these standards down here, and we're looking at the distribution of sodium in the tissue. Quantifying this, we see higher levels of sodium in the skin and in the muscle in these patients. And consistent with the role of the lymphatic system in transporting fat, higher fat to water ratios in those patients as well. And so just a couple of points in summary. We'll see throughout the workshop that there are really exceptional opportunities for quantitative imaging of structural, mechanical, and functional variables. What I've tried to highlight here is things related to the vascular system, blood flow, tissue oxygenation, tissue sodium, and so forth. The examples I've shown you have been from other conditions. So far, the application of these techniques to myofascial pain syndrome, however, has been limited. So with that, I'll thank current members of the lab, former members of the lab who worked on the projects that I showed you, collaborators, people who shared data, and finally the NIH for paying the bills.
Thank you so much, Dr. Damon, for that great overview on vascular function and structure using MRI. So our next speaker is Dr. Sandeep Biswal from Stanford University. He is going to tell us about the use of molecular imaging and MRI neurography in the identification of peripheral pain generation or generators. Dr. Biswal. Are you muted, Dr. Biswal?
There you go.
Great. Sure. Great. Thank you. I'm excited to talk to you about switching gears a little bit. This is maybe perhaps molecular structural imaging that I'll talk about first, and then followed by techniques we use for MR neurography to identify peripheral pain generators. So looking more at pain as a kind of outcome or biomarker, if you will. These are my disclosures. And I'm first going to tell you kind of my struggles as a radiologist of diagnosing pain generators, and then give you examples that we're trying to use in PET MRI and neurography to identify those who are suffering from pain. So this is what I deal with pretty much every day. This is data from the Framingham knee study. And one of the interesting things that they found is after doing serial MRs on thousands of patients, one of the things they wanted to understand was what is causing knee pain. And meniscal tears are thought to be an important pain generator of the knee, as is osteoarthritis. But one of the questions they asked is, if you're 50 and above and you have knee pain, what are your chances of having a meniscal tear, which is kind of shown here as an example. It turned out to be 63% in this population they studied. They also asked, if you had no knee pain and you're 50 and above, what are your chances of having a meniscal tear? And it turns out to be 61%. But this is what I do every day as a radiologist, diagnosing these tears. And this is a bit unsettling that I can't tell you if that meniscal tear is painful or not. So, and surgeons are making a decision based on whether or not there is a presence of a meniscal tear and whether they subsequently do a meniscectomy. With regards to what I'm talking about, I'm going to be talking about MR neurography in the second part of this presentation. And we're looking at these kind of structural phenomenons which we can use to detect changes in peripheral nerves in terms of their volume, edema, as well as potentially scarring or fibrosis. And then we simultaneously look at muscle. So we look at muscle atrophy and fatty infiltration. If we add PET MR to it, we have the opportunity to look at a variety of other markers of disease, and that I've kind of highlighted here. I'm not going to go through examples in each one of these, but just to convey that you can develop a pretty multi-parametric study in PET MR by looking at things simultaneously. In terms of PET itself, we have the opportunity to look at glucose metabolism. We've heard a nice talk already on the hemodynamic response that you can do simultaneously with MR. I'm going to be talking about sigma-1 receptor shortly, as well as a brief slide on activated macrophages and MR neurography. So let's say some examples of molecular imaging of pain. Just bear with me with this very basic side of the nociceptive response, but after you put your hand over a fire, you generate an action potential, which eventually travels through your brain, which perceives as pain. And then there are a variety of significant cellular, biochemical, molecular, physiologic changes that occur not only at the pain sensing end, but also in the dorsal root ganglion and the dorsal horn and in the brain. And I'm more interested in the peripheral manifestations of pain. And as we've already shared today by a number of speakers, there's a complex milieu of different tissues, including muscle, fascia, synovium, blood vessels, immune system cells, and variety of peptides that can be exploited in terms of molecular imaging. So if you develop a tracer to any of these or multiple of these kind of targets, you have the potential to pull out or tease out some of the molecular or even cellular changes that occur with myofascial pain syndrome. And in PET-MR, one of the nice things is you get to image the entire body in one sitting. So we go from head to toe in one sweep, and then we'll usually dedicate more time to areas that are more symptomatic to pull out more detailed MR information. But the PET image is kind of powerful in the sense that it provides a very sensitive marker of disease, much more so than MR can provide. I'm going to show some examples here of looking at a glucose marker. So we're looking at glucose metabolism or metabolic stress, as well as bone turnover in the form of sodium fluoride PET. Here's an example of a patient with sciatica. Here on the MR image, you see the herniated disc impinging and exiting nerve root. Compared that to the more contralateral normal side where the white arrow is pointing. This is the glucose image, the fluorodeoxyglucose, showing some increased glucose uptake in that vicinity. And if we co-localize it, it seems to occur right where that herniated disc is. This is a more detailed transverse image of that same patient, showing a more normal looking appearance of the descending nerve root here on the left side of the patient. But on the right side, we see the herniated disc kind of outlined by these arrowheads, which is being impinged, which is impinging the descending nerve root. And here's the glucose image, and those, when we superimpose those together, you can actually see that the metabolism is increased not only in the impinged nerve root, but also in the herniated disc. Again, suggesting there's some pathology, hypermetabolic pathology in both. What was also interesting is this patient complained of leg pain, which is a classic presentation of sciatica. So you usually have low back pain as well as leg pain. And in the MR image, we don't see any abnormality shown here. But on the PET image, we're seeing early changes of what we think is some muscle atrophy or denervation change as a result of the impinged nerve. So getting a very early look at very early muscle changes in this patient. This is work by Gary Gold and Felix Kogan, who are looking at a different tracer in osteoarthritis. So they're looking at sodium fluoride, which is a marker of bone turnover. And what's really exciting here is this is a person with knee pain, but really didn't have any changes on MR, but we're actually seeing on fluoride PET that there are early subchondral changes, which you can map here that right underneath the cartilage. And I think they're really excited to show that these areas with increased fluoride ion uptake on PET may predate early cartilage loss. So maybe an early marker of osteoarthritis. Here's an image that they've combined both FDG, a glucose marker again, with the sodium fluoride, showing there's increased metabolism in an area of an anterior cruciate ligament tear. But in these patients who sustain that injury, they start, unfortunately, getting accelerated osteoarthritis. So you're now seeing early kind of subchondral uptake of that fluoride ion PET, again, suggesting that this patient is at risk for getting osteoarthritis, even though we don't see any overt examples of osteoarthritis yet. Some of the other things that we're discovering by doing whole body imaging is other interesting phenomenon. So here I'm just showing an anatomic image of the cervical lymph node chain. And this is a patient with complex regional pain syndrome, showing here some, innocuous looking lymph nodes in their spine on MR, but on FDG, for some reason, these lymph nodes are taking up the glucose. And so these are hypermetabolic lymph nodes. The clinical significance is not entirely clear, but we're kind of excited that it suggests that in these patients with complex regional pain syndrome, there may be an immune component. Other things we're noticing with whole body imaging with PET, this is an anatomical image of sympathetic chain activity. So here's a patient again with complex regional pain syndrome, a different patient. The MR is not very informative with regards to their sympathetic chain, but here we have these small foci of uptake in the vicinity of the sympathetic chain, which may suggest, again, the sympathetic system is revved up in this patient with complex regional pain syndrome. So in this case, the referring physician was considering using a sympatholytic drug such as clonidine on top of the analgesics that they were taking as a way of combating their CRPS. Moving on to a different tracer, this is the sigma-1 receptor radioligand. The sigma-1 receptor itself is a chaperone protein. Here's a little cartoon to show you what it does. It normally resides in a resting state in the endoplasmic reticulum, but following an injury, it gets upregulated in terms of expression levels, and then its role is to carry these ion channel proteins up to the plasma membrane, where they start acting as ion channels and kind of involved in the hypernociceptive or inflammatory processes. It itself is a receptor, so if you block it, you can actually retard the transmission of these ion channels. And so itself is being investigated as an analgesic in pain states. So our group was able to develop a radiofluorinated small molecule for this receptor. Here's a case example of a patient suffering from many years of knee pain. If I were to read this MRI, I would have called it negative, and multiple radiologists have read this patient's MRIs and called them negative. Subsequently, enrolling into this trial, they were able to see that this tracer was taken up inside the symptomatic knee. Here's a zoomed up image showing quite a bit of uptake in the intracondylar notch of the symptomatic knee. Compare that to the contralateral asymptomatic knee. And then we talked to the surgeon who agreed to explore this intracondylar notch and found a very inflamed intracondylar notch. Subsequently removed that inflamed focus, and the patient's pain went from 8 out of 10 down to a 2, 30 days after the procedure, and then 18 months was completely better and had completely stopped all their pain medications. It turned out to be this highly inflamed synovial lipoma that was sitting within the intracondylar notch. Here's an example of a patient with fibromyalgia. I realize that's different than myofascial pain syndrome, but here's a patient complaining of a number of areas of symptoms. And what's kind of fascinating to us is the MR, and this is a T2 weighted sequence, which was read as negative, but if you superimpose the PET, we're seeing these focal areas that coincided to the patient's symptoms. So we have this molecular marker, if you will, showing that in areas that the MR is being read as negative are actually kind of positive on PET with this tracer. Here are some areas of neck pain in that same patient, which were picked up by PET, but the MR was interpreted as being normal. Interestingly, this patient also had abdominal discomfort and GI distress, and some of the bowel loops, which normally don't have any uptake of this tracer, were taking up the tracer in this case. This is a different patient. Also, what we're noticing is some uptake in the lymph nodes in the patient with complex regional pain syndrome. This image on your right is just an asymptomatic volunteer shown for comparison purposes. There are others using tracers specific for activated macrophages. Here's the group in MGH, Mark Loggia's group, showing one of these tracers, a TSPO PET tracer, looking at activated macrophages. And here they're showing it focally identifying a nerve that's pinched in a patient with radicular pain. On the MR image, it's hard to say whether or not there was some abnormality of the nerve, but the PET kind of highlights the fact that there are activated macrophages around that nerve root. Moving on to MR neurography, what we're trying to do here is to look at kind of structural changes in the nerve itself. This is just a little schematic to show you that there's an epineurium around the entire nerve bundle. We also have perineurium around each fascicle, and then each fascicle is composed of thousands of axons as shown here. And in terms of MR, we're looking for increased T2 signal, as well as a change in volume of these fascicles or the entire nerve. an altered course, and then we'll look for secondary muscle changes. I provided some slides here, which I'm not going to go through detail, but you can look at them at your leisure if you're interested. But these are just kind of tips on how to do it. We do prefer 3 Tesla imaging, and we also do some sort of 3D imaging in the form of these sequences listed here, which are most vendors now provide, that can be done with these 3D nerve selective imaging. These type of imaging can be performed on 1.5 Tesla scanners, as well as 3 Tesla scanners that have shown some details and references here, which you can look at your leisure. Here's just an example of a normal nerve on MR neurography. And what we're looking at here is the tibial nerve. I know it looks like it's hard to see, but that's the point. It's hard to see because it blends in with the muscle. If we were to move on to an example of mild neuritis, we'll see this is the sciatic nerve here, and you can see that the individual fascicles are a little bit brighter than muscle. So on normal, they're iso-intense to muscle, but in mild neuropathy, you will start seeing that the signal is increased there. So if I were to move further down, you can kind of, if you follow it, you can see that maybe there's some individual fascicles that are brighter than the muscle shown here. So we would consider this a mild neuropathy or mild neuritis, since the signal is a little bit brighter than muscle on fluid sensitive sequences. This is just a static image, again, showing here's a normal looking sciatic nerve, iso-intense to muscle, versus mildly or mild to moderate neuropathic nerve with the fascicles being bright. I'm just going to skip over this. Here's another static image. So we can get pretty good detail as far down into the foot. This is just above the ankle, but what we're looking at here is inflamed superficial peroneal nerves and deep peroneal nerves. And this is a normal looking tibial nerve, just for as an internal reference. Here's some references for you in case you're interested in this technique. So in summary, PETAMAR is a whole body quantitative multiparametric tool. You can employ a lot of the exciting tools that my co-speakers have spoken about. PET sensitivity is a distinct advantage in this because it can highlight pathology not normally seen by MRI. The simultaneity of MR being performed is advantageous because it can locate things with excellent spatial and contrast resolution. And as I mentioned, you can employ some of the novel MR techniques discussed in this session. MR neurography can provide information on neuropathic nerves and whether or not there's some mechanical impingement, and then as well as atrophy of the muscles. And thank you for your attention.
Thank you so much, Dr. Biswell, for telling us about molecular imaging and also introducing multimodality imaging to our session. So our last speaker for our session is Dr. Siddhartha Sigda from George Mason University. He will introduce ultrasound imaging to us, and the title of his talk is From Qualitative to Quantitative Musculoskeletal Imaging for the Evaluation of Myofascial Tissues, Opportunities and Limitations. Dr. Sigda, please take it away.
Thank you very much for inviting me to this exciting session. So I'm going to talk about the use of ultrasound imaging to look at the myofascial unit. Primarily, I'm going to discuss its use in looking at structural imaging, but also discuss a little bit about the use of color Doppler and spectral Doppler to look at vascular imaging aspects. So ultrasound, as we know, is very attractive for musculoskeletal imaging because it's widely available. It has high resolution. We are able to resolve individual fascicles using clinical imaging scanners. We can also look at ultrasound is also very sensitive to changes in soft tissue properties. So if you think about ultrasound, what we typically see are essentially the connective tissue interfaces. So those are the primary scattering interfaces in ultrasound. So if you look at a whole muscle, you can see this architecture of the fascicle bundles surrounding by perimysium. And if you drill down a little bit more deeper, you can see individual fascicles. The individual fibers cannot be resolved, but they do produce this sort of interference pattern, which we call speckle. So the speckle produces this sort of texture in the image that can be resolved. So we tend to talk about two properties of ultrasound images. One is the brightness, the overall brightness of the image, which we call echogenicity, and this sort of interference pattern, which we call echotexture or speckle. And the echogenicity and echotexture depends upon the size and distributions of the fibers and the fascicles. It depends upon the composition of the tissue, fatty infiltration, fibrosis, and so forth, as well as presence of fluid in the tissue. It is very sensitive to the orientation of the fibers. So it's sensitive to the orientation of the ultrasound transducer with respect to the fiber angle. So overall, this is these two measures can tell us something about the microstructure and the organization of the tissues. So clinically, ultrasound has been used to look at anatomical and sort of architectural dimensions. So it has excellent reproducibility for measuring size of the muscle, the cross-sectional area, thickness of fascia, and so forth. These are some other images from the literature showing other types of pathologies that can be picked up with ultrasound. So for example, muscle ruptures and the surrounding hematoma is very well appreciated using ultrasound. The scarring that follows the rupture, as well as the healing process, can be documented using ultrasound, and this has a very high level of evidence in the literature. We can also look at fluid pockets. So for example, on the top right, you see a ligament rupture and the surrounding fluid pocket in the ankle. So these are the types of clinical images that are routinely used. The composition of the tissue in terms of the fibrosis as well as fatty infiltration can also be documented. This has primarily been used in looking at various types of neuromuscular disorders, such as muscular dystrophy, spasticity, and muscle and cerebral palsy, as well as various types of myopathies. So the common observation is that normal muscle has this sort of overall predominantly dark appearance with this nice architecture of the fascicle boundaries and the connective tissue. As the muscle becomes more and more pathological, you lose this sort of fine architectural definition, and the overall muscle appears to be brighter and also more attenuative. In other words, the ultrasound does not penetrate as much. So the echoes from bony interfaces deep inside the tissue tends to get significantly reduced. So these are qualitative observations of the different types of pathologies that are being documented. We can also utilize sort of the physics of ultrasound scattering to try to quantify this a little bit better. So one of the observations is that if you have a random distribution of scatterers within the ultrasound beam, they tend to produce a very characteristic sort of distribution of brightnesses. This is, can be characterized by using something called the Rayleigh distribution, which is a single parameter that describes the histogram of brightnesses that you can observe. So for example, if you're looking at a very high resolution within a fascicle, the distribution of brightnesses will follow a Rayleigh distribution. As you go to a slightly larger region of interest, you have a mixture of coherent and incoherent scatterers. So for example, the perimysium and other connective tissues surrounding the fascicle bundles, they produce brighter echoes, and you need to have these kind of heavier tail distributions that has more than 2 parameters to describe them. And if you increase the sample volume a little bit larger and you have this hierarchical muscle architecture, we have shown that you can use a mixture of distributions that can very accurately describe the histogram. So this presents an opportunity to try to quantify and generate these kind of parametric images of tissue composition within muscle. And in one study, we looked at children with cerebral palsy whose muscles are known to be have increased fibrous tissue, fatty infiltration in them. And we can see that using these kind of distributions, we can quantify these kind of parametric maps and show a clear separation between the healthy muscles and the muscles of children with cerebral palsy. So this is one way to try to quantify it. Now, turning to myofascial pain, ultrasound has been used quite a bit to look at muscles with individuals with myofascial pain syndrome. And there are really three types of findings that have been documented. So our group, as well as others, have documented that these palpable myofascial trigger points appear to correspond to these hypoechoic regions within the muscle, in the belly of the muscle. And this has now been documented by several groups. Another common finding is that the fascia appears to be thickened. So Dr. Steckel's group and others have documented that in myofascial neck pain, the perimuscular fascia appears to be thickened. A third finding that has been documented is that within the muscle belly, there appears to be these hyperechoic bands. So again, different from the hypoechoic regions that we documented in the belly of the muscle. So these hyperechoic bands have been thought to be associated with taut bands, although the relationship needs to be further explored. One challenge in all of this is that there is a very broad range of findings, and the appearance of the muscle appears to be relatively complex, if you look at a large population of subjects. So the three types of findings that we have documented. One is that normal muscle appears to be have uniform echogenicity and uniform echotexture. In individuals with active trigger points, we have sometimes documented these focal hypoechoic lesions, but sometimes there are more than one lesion. So sometimes the entire muscle is affected and there are multiple lesions. And these findings now have been documented by other groups as well. So this presents a challenge in quantification. So if you just look at the area of these hypoechoic regions, the reproducibility decreases quite a bit. So the interclass correlation coefficient for inter and intra-rater reliability measures are relatively weak, so ranging from 0.5 to 0.7. Another way to try to get a better quantification is to use some kind of derived texture measure. So in our group, we have used entropy as a way of quantifying the texture. And this allows us to document sort of the heterogeneity of the entire muscle. So we have documented this in 3 dimensions. So for example, on the bottom right, you can see an entropy filtered image of the muscle in an individual with multiple active trigger points. And you can see these sort of hypoechoic regions sort of pervasive throughout the muscle and sort of interconnected with each other. And we document that if you look at the mean area in individuals with active trigger points, they seem to be significantly higher compared to normal pain-free controls. One challenge, of course, is that the ultrasound images are highly sensitive to the orientation of the ultrasound transducer with respect to the muscle fibers. So even if you tilt the ultrasound transducer a little bit, the appearance of the muscle changes. And this is both an opportunity and a limitation. So one opportunity that we see is that if we actually devise a method of carefully controlling the orientation of the transducer with respect to the muscle fiber, in these active myofascial trigger points, we see that there is the appearance is very sensitive to the orientation. So even if the transducer is rotated by 10 degrees, the appearance of these hypoechoic lesions seems to change. So this tends to suggest to us that this is not a solid lesion in the muscle, but rather some subtle changes in the architectural and the fiber orientation, as well as the sort of the connective tissue architecture, as opposed to a pocket of fluid or a solid lesion. So that's one important observation. The second thing that we have studied is blood flow. And using color Doppler, we can document the presence of blood vessels in muscles. And so what we have observed is that in co-located with these active trigger points, there appears to be these large caliber blood vessels that are often observed. And you can see here 4 examples of individuals with active trigger points. And these blood vessels are actually not expected to be in these locations based on what we know about the anatomy of the vasculature in the upper trapezius. So these appear to be neovascularized, neovascularization that appears to be co-located with this, with the trigger points. And this is consistent with what we have seen in the literature. There's been documentation of this sort of hyperoxic rim surrounded by a hypoxic core within the trigger point. If you look at the waveforms of blood flow, looking at the variation of blood velocity with the cardiac cycle, in normal muscle, we see predominantly blood flow during systole and almost no flow during diastole. But in these large blood vessels near these trigger points, we observe an elevated systolic blood velocity and a retrograde diastolic velocity, which is paradoxical, which is not something that we expected to see. So this suggests that there is an altered vascular compartment in these muscles that is very sensitive to even small changes in overpressure, either by the pressure from the ultrasound transducer or by pressure generated within the muscle because of contraction. So this is another interesting finding. So what I've described today is the standard methods using conventional grayscale imaging as well as color Doppler, but there are other emerging ultrasound modalities that could actually present new opportunities as well. So one modality is contrast enhanced ultrasound, where a contrast agent is injected into the bloodstream, and that allows us to quantify the perfusion. So we can look at these time intensity curves to look for changes in perfusion. Photoacoustic imaging, which combines ultrasound as well as laser light to look at a hybrid optical contrast, is another very promising modality. It can allow us to quantify oxygen saturation in the muscle, as well as quantify blood flow in the muscle. So again, we can look at changes in the oxygen saturation with time and with different types of perturbations. So that's a very promising modality. Some of these clinical scanners now come with the ability to do microvascular flow imaging that is more sensitive than color Doppler. We also are seeing higher frequency ultrasound transducers greater than 20 megahertz that allows us to better quantify the architecture. And in the next session, we're going to talk about ultrasound elastography, which is another promising method for quantifying mechanical properties. So to summarize, ultrasound provides several opportunities to quantify the architecture as well as in terms of the echogenicity and ecotexture. It also provides an opportunity to understand vascular physiology. And there are new emerging modalities that could be very promising. But there are several limitations. So one is that the measures are sensitive to probe positionings, which limits the reproducibility as well as the clinical applicability. So these are things that we need to work on more. The appearance of the muscle tissue in myofascial pains appears to be very complex and heterogeneous. And so it limits the ability to develop simple quantitative metrics. So this requires additional study. So with that, I'll stop and thank you very much for your attention.
Thank you so much for this very thoughtful overview of ultrasound imaging tools, and especially like you highlight not only the great capability of ultrasound, quantitative ultrasound, but also pointing out the limitations and opportunities. So with that, we conclude the talk portion of the session. So now I will pass the baton to my co-chair, Dr. Sabri, who will introduce our four panelists.
Thank you very much, Goin, and thank you to our speakers. We will now start the panelist comments part. We have four panelists. Each will have 2 minutes to share with us their perspective and reflections related to the session. Our first panelist is Dr. Christine Chunk of the University of California, San Diego. Christine, please unmute yourself.
I believe that I'm unmuted. Can you hear me and see my screen?
Yes.
Great. So I wanted to thank the organizers for allowing me to participate in this workshop. I think after having heard some of the leaders in imaging in the musculoskeletal system, it becomes apparent that we've got a sophisticated set of tools in our imaging armamentarium to point at the clinical entity of myofascial pain. But I wanted to just be able to quickly emphasize a point that was made in the clinical section this morning, and that's the distinction again between musculoskeletal pain versus myofascial pain and how those patients present to us. I'm going to back up a little bit and give you a foundation for the pathology that we see more frequently clinically. That's the acute musculoskeletal injury. On the two images on top, you're seeing a non-fat suppressed and fat suppressed acute muscular and myofascial injury. I think the vast majority of clinical radiologists would really focus here on the muscle and tendon, and perhaps not so much on the fascial changes, which we see as high signal intensity here. And very tough to perceive those differences as you look at the non-fat suppressed sequence. As we follow this injury to the chronic stage, we see that there's volume loss in the muscle, fatty infiltration, thickening and nodularity of the fascia. But again, perhaps as we think about this chronic sequela of injury, the fascia is something that we focus on a little bit less. Now, if you look at the myofascial injuries that are more chronic in nature, here obvious as you look on the CT images on the left, a muscle herniation. This is a reconstructed image through the thigh, and you can see that muscle herniation very easily, even better profiled in the axial imaging plane orthogonal to the pathology, where you can identify the fascial covering the muscle herniating through it. That's an obvious injury. More likely, when we have the history of myofascial injury or even muscle herniation, the findings on MR can be very subtle, as shown here. The marker indicating that pathology, as you look at the muscle signal intensity, looks normal. As you look at the fascial covering, the low signal intensity here, discontinuous from the tibia, but not a lot of contrast to alert us to the presence of this abnormality. And so as we consider the context now of myofascial pain, having heard clinical talks this morning, having seen amazing capabilities from the standpoint of tools that we can direct towards myofascial pain, I think there are a few challenges and things that we need to keep in mind moving forward. The standard imaging findings can be very subtle. That's what we're looking at in many cases. As we consider robust non-invasive imaging evaluation of these entities, this entity, our evaluation is going to require, as you saw in the last session, deployment of novel tools. And those range all the way from structural evaluation to biochemical evaluation, even to some mechanical assessments. And I think we really have to stay focused on the idea that our reference standards for these imaging biomarkers that we're going to be developing and applying have to include pain. Sandeep nicely outlined that in his talk. Physical examination, that was really emphasized well this morning, as well as in Dr. Sikdar's talk as well, and structure. So we have to combine those things, keeping our focus again on myofascial and muscle injury and separating really what we're looking at and what we're trying to elucidate. Thanks so much.
Thank you very much, Dr. Chung. In the interest of time, we will move to our next panelist, Dr. Bharti Khurana of Harvard Medical School. Please share your screen if you have slides and unmute yourself.
Thank you. Can everybody hear me?
Yes.
Okay, I don't have any slides. Thank you so much for inviting me to this wonderful session. I'm an emergency and musculoskeletal radiologist, reading radiological studies of patients presenting with acute pain almost every day. I developed interest in myofascial pain syndrome when Dr. Langevin was at the Brigham and Women's Hospital. We reviewed thoracolumbar fascia on CT, MRI, and ultrasound in both symptomatic and asymptomatic patients. We tried to look at the architectural distortion, thickening, nodularity, volume loss, attenuation value, asymmetry and enhancement, whatever we could see on those gross images and correlate with patient's pain. It didn't work always. Sometimes there was pain, but the fascia looked great, and other way around when the fascia was thickened and nodular, but there was no back pain. She's long gone, but I always look at the fascia on all my studies, including routine abdominal CT. As Sandeep mentioned, we certainly need to add functional and mechanical components and biomarkers to structural imaging. My other point was I work very closely with spine surgeons and often like to go to the OR to correlate what I see on images and what they see in the OR. Now, during one of my planned visits on a patient with spine surgery, I was surprised to see how surgeons were cutting the thoracolumbar fascia and never suturing it back. More often than not, they just leave it open. And we had such a great discussion this morning on the importance of fascia, even in its mechanical significance. And I would love to get everybody's thoughts on that. I've seen a similar thing with acute spine trauma in the emergency department. The fascia can get torn, can get split, can even show huge accumulations of fluid and hemorrhage, but not everyone is symptomatic. And injuries isolated to fascia are not considered clinically significant, and often they don't receive any attention from our surgeons. And thirdly, I'm also curious if anyone has tried using thermal imaging in myofascial pain syndrome. I know thermal imaging has evolved over last few years with AI integrations. So that's my, just a suggestion. And actually, I'm curious if anybody is using it. It is definitely not under radiology. So we are not doing at our institution. That's all. Thank you.
Thank you very much, Dr. Khurana. We'll address these questions hopefully in the panel discussion. Our next panelist is Dr. Levon Nazarian. If you could share your screen, if you have slides, and unmute yourself.
Yeah, I don't have any slides. Can you hear me?
I can.
Okay.
Please turn on. Oh, here you are.
There. Okay. So I just wanted to again thank the organizers for inviting me, and I just wanted to amplify one of the points made in the ultrasound lecture previously. I do musculoskeletal ultrasound as my specialty. And I just wanted to highlight the use of contrast agents in musculoskeletal ultrasound. For those of you who are not familiar, ultrasound contrast agents are microbubbles that can be encapsulated either with a saccharide or with a lipid shell. And the microbubbles are approximately the size of a red blood cell. And by injecting them into a peripheral vein, we can enhance blood flow signals within the tissues. So this provides a very powerful modality to look at blood flow within muscles, fascia that we're describing here in two ways, really. One is you could actually look at the change in the ultrasound signal intensity over time. So you can generate time intensity curves and quantify muscular perfusion that way. Or we could turn on the Doppler and actually see how it enhances the Doppler signal. There has been some preliminary work, particularly in fibromyalgia, showing that there's decreased perfusion with ultrasound contrast agents in muscles, particularly after exercise. And so this is certainly an area that's already being explored and has future promise. But then there's also another application that I'd like to bring of ultrasound contrast, and that it's for what I know at this point is the only or at least best way to non-invasively measure pressures in an imaging technique. Turns out that if you combine ultrasound contrast agents with what's called subharmonic imaging, you can actually get pressure estimations that are both reproducible and can be very accurate. And so this could be a way, for example, somebody spoke earlier about exertional compartment syndrome. This is something that you could directly measure pressure in a muscular compartment just by an intravenous injection of contrast and then analyzing the signal that comes back from that muscle when it's interrogated with the ultrasound imaging. So I think that this is, and that combined with the fact that ultrasound contrast is extremely safe and it's just breathed out through the lungs, it has no renal toxicity. I just wanted to amplify that as a very, very important tool that we have at our disposal to do research studies and clinical work as well. So that's really what I wanted to expound on. The other thing that's very important is ultrasound elastography, but of course that will be covered in the next session. So again, thank you very much for the invitation.
Thank you very much, Dr. Nazarian. Our last panelist for this session is Dr. Antonio Stecco. Dr. Stecco, please share your screen and unmute yourself.
Yeah, well, thanks for the invitation. I would like to present something about a new modality to assess myofascial pain, in particular, evaluate the inner part of fascia. Because if we check how fascia is made, we know that fascia is made by dense connective tissue, type 1, type 3, collagen fiber, as well as loose connective tissue, so adipose cell, glycosaminoglycans, and hyaluronic acid. So this multiple layer of dense, loose connective tissue have two major functions. The dense connective tissue have the function to transmit force. We can see an ultrasound magnification, and we see how this yellow line is able to transmit force from the medial part of the elbow, so the epitrochlear, down to the forearm. The loose connective tissue between layer at the opposite is a cushion, a lubricant that allows each single layer to glide independently. So this is fundamental because, as you can see here, we are in the medial region of the elbow. The brachial fascia, this collagen fiber, have to pull in one direction, while the other one have to pull in the opposite direction. So we try to use the T1 row that we have saw in the previous presentation. The T1 row allows to evaluate what kind of water we have. In particular, if the water is bind with specific protein or carbohydrate, in particular with the hyaluronan, we were able to discriminate. Because this study that we saw before, that our group performed, we tried to evaluate the spastic patient in the pathological side and the healthy side. So we see a dramatic increase of unbind water. So it means that the hyaluronan was aggregate. Why is I tell you that? Because then we inject the hyaluronidase, the enzyme that metabolize hyaluronic acid, and we saw a dramatic decrease of this unbind water. So we have much more water that is bind with the hyaluronan. And the difference in red that you can see is just exactly the amount of hyaluronan that was drainage, basically, and substituted with new one that is free and able to bind water. This was exactly correlated with the range of motion and with the symptomatology, the symptom that the patient was complaining. So after this, let's say, successful result, we try to do the same, but not with a drug treatment like hyaluronidase, but we try to do manually because we know worldwide the people are trying manually to approach myofascial pain because it's something that seems not organic, but is functional. So we apply fascial manipulation, again, in an elbow problem, and we try to evaluate with T1 row before and after treatment what exactly was changing. And we can see that the patient with the myofascial pain, so typical elbow pain, I mean, there is a dramatic change of the quality of the loose connective tissue in the deep fascia, no more in the endomysium, perimysium, so like the full thickness of the muscle, like we saw before in spasticity, in muscle stiffness. So in this rigidity in the elbow, this painful elbow, the problem is really localized in the fascia. And we see different slide from the elbow to the wrist, and you see clearly that the area that we treat, the lateral side of the elbow, we have dramatically drop in the amount of aggregate hyaluronan, so unbind water. This was exactly correlated with the symptom of the patient. So as less unbinded water you have, so better lubricant you have, better gliding, better range of motion, less symptom you have. So this was very important for our perspective because it was the first, let's say, preliminary pilot data that explained that with manual therapy, you can change a little bit the biology, in particular the biology inside the deep fascia. So thank you.
Thank you very much, Dr. Steko. I'd like to thank all our panelists for their thoughtful comments. Now we'll open up the session for a panel discussion among panelists and presenters. Please remember to turn on your video and raise your blue digital hand. We have about 15 minutes for this panel discussion because we're running a little bit behind. Dr. Liu will moderate this part.
Thank you, Dr. Sabri. Dr. Liu, do you want to unmute? I see that you already have a hand raised from Dr. Bruce Damon. Do you want Dr. Damon to start?
Yes, please. Go ahead, Dr. Damon.
A question for Dr. Chung. So I was noticing in the image that you were showing of, I think it was the muscle herniation. It looked like that was sort of what indicated that was kind of a signal void between the subcutaneous fat and the muscle, if I was looking in the right part of the image.
Yeah.
And I was just wondering what distinguishes that from like a signal void caused by a chemical shift artifact.
You know, it's a good question, Bruce, and the findings are so very subtle. So in that case, we actually saw that little bit of change in the signal, and it's tough to distinguish what the etiology is. In some cases, when we have the subtle presentations, we don't see anything at all in the fascia. So then we try to have the patient contract the muscle image and then see if there's a contour change. But it's very difficult with standard MR sequences where that fascia is low signal intensity to really assess it well.
Okay.
Dr. Liu,
So, yeah, hold on.
Go ahead.
Next, we have another question from Dr. Fritz.
Yeah, I had a question for Dr. Gold or Damon regarding fat infiltration and the extent to which that's been studied specifically in people with myofascial pain syndrome. I'm not aware that this has really been documented, but that could just be my ignorance of what's in the literature.
I'll answer that, Julie. Thank you for the question. I really was not able to find in my literature search for my talk evidence that it's been systematically studied. I was laying it out there as one possibility that we could use to study this syndrome and perhaps the long-term sequela of it, because fatty infiltration, at least in my mind, is one of the later findings in muscle or muscle disease.
Thank you, Dr. Gold.
I would agree with that.
All right.
In fact, I would say, as I was searching the literature for truly quantitative methods in general in myofascial pain syndrome, I found very little.
Thank you, Bruce. So next we have Dr. Wei Chen, who has a question. Go ahead, Wen.
Yeah, thank you. First of all, I just wanted to remind everybody who already posted a question in the chat, could you please, you should raise your hand so you can ask those questions directly, because we're not answering the questions in the chat. I actually do have one question. I'm very struck by the potentials of the PET imaging, and I'm wondering what will be the potentially good tracers for PET imaging for myofascial pain conditions and myofascial tissues. I'm directed to all the speakers and panelists, so whoever would like to answer.
I was wondering, Dr. Biswell, would you go ahead and answering that? I mean, give it a try, since you're the one who talked about PET.
Yeah, no, I think that's a great question. I was trying to do some literature searching to see what are some popular molecular targets. There was some spoken about, calcitonin gene-related peptide. So the receptor for that might be an attractive one. There is actually a PET tracer for that out in the research world. So that might be something exciting to go after. There's also a substance P receptor PET tracer, but unfortunately, the drugs for substance P haven't been as an analgesic as people were hoping once a long time ago. So I'm not sure that's a great tracer for pain per se, but it may be a good tracer for some sort of inflammation that's substance P driven. Other tracers you could think of would be, if you think there's tremendous macrophage recruitment, then some of the TSPO tracers or new ones coming online would be a good one to go after. But I'd have to do a little more reading myofascial pain syndrome. Sigma-1 receptor might be also another attractive way. So if NIH wants to give me some money to do that research, I'd love to do it. So.
Thank you, Sandeep. So we have a question from Dr. Kathleen Sluka. Please go ahead.
Yeah, hi. Although I was kind of answered, I thought I would bring this up. So I was fascinated by the ability to pick up macrophage activation. And my thoughts were that in a lot of animal research, we've shown very subtle changes in macrophage phenotype. We've shown subtle changes in maybe small increases in macrophages in some of the musculoskeletal models. And I'm wondering how good the resolution of this technique, the PET in particular, I believe, is to pick up those kinds of subtle changes where you might get maybe double the normal population instead of hundreds of times the normal population like you would with an acute inflammation.
So that's a very good question. And I will open up to the entire panel. So who would like to take this question first?
I can take it.
About resolution. Go ahead.
So resolution of PET isn't great. We're talking about 2 to 3 millimeters cubed, but where it really excels is its sensitivity. So you could potentially pick up twice as much macrophages as background, provided that your tracer is able to be removed from the background if it's not bound. So if you can clean your background, you can definitely pick that signal to noise up. In the PET world, we kind of ask for 50%, but if you have at least 100%, I think we're good to image that. But again, it really depends on your choice of tracer and whether or not it can be easily removed from non-specific binding in the area. So.
All right, thank you so much. We will now move on to our next question from Dr. Mary Bob. Dr. Bob, please.
Okay.
Oh, would you like to
follow up about that? Same thing. So we talk about activation of macrophages as if they're a single phenotype and they're only doing one thing. But macrophages come in multiple phenotypes, and some are protective and some are, say, pro-inflammatory or pro-nociceptive. And I'm wondering if there's the capacity to differentiate between types.
Yes.
And this is true for all immune cells, really, right?
Yeah. So I think there's a lot of, omics work going into understanding the different types of macrophages. So it'd be important to do these kind of panels and then try to figure out and pull out what is the most, relevant biomarker of an activated macrophage that you're interested in. So that would be the first step, at a very basic level, trying to figure out what that phenotype looks like, and then developing a tracer around it.
Great, thank you.
All right, so Dr. Mary Bob, please go ahead.
I had 2 points. One of them was Catherine Schluka's question just now. There was some work begun a few years ago, UPenn with Beth Winkelstein and a radiation bioengineer, to put a lead particle on an antibody that would bind to a macrophage. At that time, I think they were just picking like a CD68 or CD11B. I don't know what happened to that. I would be interested because then it would be visible in many different imaging systems. But my main point was to Sandeep Biswal's statement about the substance P neurokinin 1 receptor antagonist. Yes, I think they have been disappointing for pain relief, but there has been quite a number of studies that have examined neurokinin 1 receptor antagonists for reducing the role of substance P in collagen production in a variety of conditions. So I think we've got looking at the wrong direction for substance P's function. It should maybe not pain, maybe it's in a neurogenic collagen production instead.
Yeah, I totally agree with that. Yeah.
All right. So we have a question from Dr. Longivan. Ellen, please go ahead, comment or question.
Yes, hi. I have a follow-up on the initial question that was asked about fatty infiltration for either Dr. Gold or Dr. Damon. I guess it's mostly Dr. Gold, because in your presentation, you had showed some really nice data. I guess it was proton density fat fraction, where you really looked at, got a very nice separation between the fat and the connective tissue. It's just that, I mean, that's great. It's just that in a lot of the kind of more conventional, older MR specialty techniques, there's not as good a distinction, right, between fat and collagen or connective tissue. And I think the idea that the end stage of muscle sort of pathology would end up being more fatty infiltration. If you ask a surgeon, who does surgery on, and then they say when you cut through those muscles, it feels like gristle, you know, cutting through them, that it's more fibrotic. And I was wondering how, when you do these, develop these new techniques to look at fat, do you validate them with like biopsies, or how do you determine that it's in fact fat that you're looking at?
That's a great question. So in MRI, fat and water resonate at different frequencies. So by separating the fat and water in the images by the frequency we get, we know which is fat and we know which is water. And that's been experimentally proven in many different models. Now, I absolutely agree with you. In conventional MRIs, such as a T1 weighted sequence or a ultra short echo time sequence without fat suppression, the connective tissue and the fat can look similar. So you have to take care in the application of the method to be able to separate the fat from the connective tissue, but by choosing the echo time and paying attention to the chemical shift caused by fat, those should be relatively easily separable on almost all scanners. Now, not all scanners have fat water separation or ultra short echo time imaging, but many of the modern systems do.
So it's really a matter of paying attention, as you're saying.
Yeah.
Thank you.
So any other questions?
We have some questions in the chat. I wondered if Dr. Heather Tick could tell us her question.
Mine have been answered privately in the chat. Thank you.
Okay.
So
Wendy, would you like to?
Go ahead. All right.
Wen Chen, would you like to ask your question?
Oh, sure. I already asked the question. So my question was whether the HA would be a potentially good PET imaging ligand. This is to Dr. Biswell.
Thank you for your question. I'm a little nervous that HA is kind of ubiquitous and everywhere. So a PET ligand for it might just stick everywhere. So the background will be high, and that might be tough to interpret in the setting of disease. So even if you had a pathologic situation where you had increased or decreased amounts of HA relative to background, it would be tough to discriminate that if the background's already high to begin with. So that's just a general principle. We always like tracers that shouldn't stick around and be completely removed from the area to decrease any background noise. So.
Any other questions?
I see Dr. Basbaum. I see Dr. Basbaum has a hand raised.
Yes, go ahead, Dr. Basbaum.
I'm curious about the reference to the sigma-1 receptor. When you image it, what I'm trying to figure out is what exactly you mentioned the idea of the mechanism that it'll bring channels to the surface. Is the implication that those channels are enhanced under certain conditions and that bind and you pick up more because there's more receptor? What exactly are you finding?
So the basic science of it is that it brings the channels up to the surface membrane and it enhances all the signal transduction that is needed for pain nociceptive processing.
I get that part, but what are you picking up when you're imaging the sigma-1 receptor? Is its expression increased under conditions in which? Oh, so that's okay. So the idea would be an antagonist to that receptor would be theoretically effective in counteracting the problem?
Yes, which we've actually shown in a rat model of spared nerve injury. So if you antagonize the receptor, you actually decrease pain responses in rats.
Because there's an old, obviously, I'm sure you're familiar, there's a very old literature on sigma receptors and pain going way back with the Zukins. But I always thought that was more of a CNS mechanism. I didn't realize that that there's evidence for peripheral mechanism.
Yeah, so in the spare nerve injury model, you actually upregulate in the neuroma itself. So we've shown that immunohistochemically. And then there's actually a clinical trial now going on for paclitaxel-induced neuropathy and pain related to that. And pain has actually decreased.
Right, thank you.
Yeah.
Great.
Mm-hmm.
Well, I think the bell that we just heard actually signals the end of our panel discussion. And Dr. Liu and Dr. Sabri, thank you so much. Dr. Liu, we have 5 questions that have come in that we've posted here for members of the audience. So I'm going to begin with the first one, and then I defer to you on who you think should take this. The first question is, we have discussed many examples that exercise challenge is frequently observed as key in revealing muscle disorders and monitored with imaging. How common is exercise challenge as part of the clinical workup of MPS today? That's our question. Dr. Liu, who do you think should take this one?
You know, this seemed to be a question for the previous session to me. But I will open up to everyone and probably point towards the direction of muscle energetics and related to exercise. So who would like to take on this question?
Goying, I could take it on as a
Thank you.
clinical radiologist. I think it's exceedingly rare that we use an exercise provocation coupled with an imaging study in clinical practice. We definitely do it in the research setting because we feel like the provocation due to exercise may show us a change, but realistically, from a scheduling and a workflow perspective, it's very difficult to put an exercise challenge into our routine clinical workflow.
Right, I would want to add in research study though, they are studies using imaging measuring before and after exercise.
Absolutely.
Spectroscopy, for example. Right. So go ahead, Catherine.
Sure.
Second question.
I see Dr. Damon has a hand raised. Dr. Damon, did you wish to weigh in on that in some way?
Actually, just with another question, I guess. So I guess, you know, with a background in muscle physiology, it seems really intuitive to me that we'd want to assess muscle as it functions, you know, just as cardiologists do with the heart, and just as physical therapists do. So just at a high level, Gary, what do you think would be required to do that? I mean, I guess we'd have to show that there's clinical value to it for one thing, but
Yeah.
You know, what would be required?
It's a good question, Bruce. And you know, you think about like stress, cardiac echoes, treadmills, stress MRI, and obviously it's used there in cardiology. I think the key, as you stated, is we need to demonstrate clinical value. Typically, right now, if we have an acute muscle injury, for example, we can see that on MRI, but it doesn't change the management of the injury right now. So we don't often do MRI even for acute muscle injury, let alone a stress type of test. I do think as we progress, as we understand more and get more sensitive, and especially for syndromes like myofascial pain syndrome, I think that will be a paradigm that we want to introduce to detect some of these subtler findings.
Thank you.
I see Dr. Sikdar. I think you might want to weigh in. I do want to be respectful of time. So did you have a thought about the response to this question?
Just very quickly, just to say that, you know, ultrasound may be particularly attractive here because of the workflow issues. And so if we can quantify using ultrasound a little bit better, perhaps that could be incorporated into the work.
Okay, great. Dr. Chung, did you have a quick thought here?
Yeah, I just had a quick comment about the exercise provocation. So I think if we think about the clinical application and locations of some of these myofascial pain syndromes, trapezius, for instance, overuse in upper extremity, they may not necessarily lend themselves to an exercise provocation. Some may not. So I think the clinical piece of that would be very important.
Yes. Dr. Sluka, any quick comment that you'd like to make before I move on to a next question? I see your hand was raised.
Yeah, yes, sorry, I had to unmute. So yes, I was thinking that it may not take full exercise provocation to see these changes. You see increases in pain within a very short time period for things such as simple as a 5-time sit to stand, which takes 10 seconds to do or less. And you can see, significant increases of 2-3 points on a visual analog scale in people with musculoskeletal pain of various different types of conditions. And I wonder if we could be thinking about more, are there changes in that response during just a movement task, which I think is a very different pain signal than resting pain. And so I was just throwing that out there for people to think about.
So I might reorder my questions here if my Q&A moderators can give me the floor to do that.
Yes, go ahead, Catherine.
Oh, thank you. We do have a question number 4 in here that states previous studies have shown that imaging does not necessarily concur with the presence of pain symptoms and vice versa, particularly in low back pain. Are there similar findings regarding myofascial pain syndrome, or is this condition, or if this condition always implies anatomical structural alterations, and how does this influence the management? I thought that might be an interesting follow-on to what you were just saying, Dr. Sluka. So what can we say about imaging and its concurrent, not necessarily concurring with presence of pain symptoms and vice versa? Do we have thoughts? Taking that question? Dr.
If I can say something, yeah. Obviously there is no clear correlation. So myofascial pain is so common. We are struggling with radiologists, with all our colleagues, to try to objectify specific symptom that can be extremely severe, but does not have correlation with imaging. So the severity of the symptom, unfortunately, are not correlated with imaging. This is something is well described in literature. So unfortunately, what we are seeing that is often a functional, an alteration of the function of the structure more than a morphological alteration, make it more difficult for clinicians to define what is wrong, and for radiologists to objectify and get data about what exactly is the origin of the problem. So unfortunately, we can say that not at all. And this new technology that we saw today maybe can be really the future, because they are looking for the function of the tissue. So I'm really hopeful that in the future we can have a better instrument.
That's a very good perspective. Yeah, I think this is why we're all looking forward to the rest of the workshops, the sessions that would introduce functional measurement and physiological measurement, biomechanical measurement, as well as metabolic measurement. So do we have, Catherine, and do we have more questions?
Yes, we have some more questions. We have a question here that's coming from our audience. I find this interesting. The person asks, how expensive are these technologies? Are they truly applicable clinically, or are they really just research tools? Who would like to tackle that one, Dr. Liu? Who do you think should take this one?
Well, I think all of the panel can take on, and I think ultrasound probably would be the obvious choice in terms of cost, right? So who would like to take on this question? MRI, PET?
I'll give it a shot, Goying. In order of expense, PET MRI would be the most expensive, followed by MRI, followed by ultrasound. That's a generalization, because if you can do a very rapid protocol with MRI, for example, you can afford to lower the cost because the time you spend in the scanner is correlated with the expense of the exam, or at least it should be in most healthcare systems. But definitely, if you're looking at this for a quick screening type of approach, ultrasound would be the way to go. I think MRI would provide incredible detail if there's a chance that the imaging would change the management of the patient. If it won't change the management, typically we don't do it with MR.
I agree. So any perspective from the panel, the rest of the panel members?
Yeah, I might give a perspective. So in our work where PET is extremely sensitive and potentially specific to pain generators, we are seeing examples, I mean, in a case-by-case basis where patients have been seen by doctors for years, and then until they get to our scan, they have finally got some sort of resolution to their pain after looking at the PET MR images. So the cost of that, what that patient went through, is tremendous, and can't really even put a price on it. So in a subset of our cases, we are really expediting diagnosis and cure. So, I think it is a cost-effective way to go about it. And some of my referring physicians who work in the pain clinic are now saying this should be almost a one-stop, visit for a patient in terms of, when they get first seen by a pain doc, they should come to my scan, and we should try to take a look on a whole body perspective, looking at where the pain generators are. So
I see a few hands, Dr. Liu, people who I think would like to weigh in with perspectives. We'll start with Dr. Sikdar. You had your hand up?
Sure. So I just wanted to say that, ultrasound, of course, is very widely used in musculoskeletal imaging precisely because it is less expensive and it allows for dynamic imaging. And so the challenge with ultrasound is the operator dependence, and to be able to get the kind of specificity that you get with PET or MRI is somewhat limited with ultrasound. So with some of these new emerging methods, I think we are going to get improved specificity. And in particular, as Antonio pointed out, if we can start measuring function using ultrasound, that's where I think this could become really powerful. So I think using the current state of the art, I think there's still a ways to go, but in the very near future, I'm optimistic that ultrasound could fill that void.
Dr. Nazarian, did you have a thought?
Yes, just to add to that. So one of the advantages of ultrasound, besides being lower cost, is that we don't have as much of a problem of trying to decide what it is that hurts on a patient, because we can do ultrasound guided palpation. And so let's say an area that we think may be a slightly thickened area of fascia, we can correlate that exactly with where the patient's tender. And then plus we can do a contralateral immediate scan of the other side to correlate not only let's say the thickness of the fascia with also with the presence of tenderness on the other side. So it does give you that added advantage of being able to sort of correlate physical exam findings directly with imaging findings. And then plus one thing that we haven't discussed yet at this session is the fact that you can then go ahead and do an intervention. For example, to do a hydrodissection of a thick fascial plane, which when you combine with a local anesthetic injection, of course, gives you not only a potential therapeutic, but a potential diagnostic, because if they get better from the local anesthetic, you've conclusively proven that the finding that you see on the imaging is in fact the cause of their pain. So that's another powerful aspect of ultrasound, is the ability to correlate it with an intervention, either diagnostic and or therapeutic.
So Catherine, I feel like we have had quite a lot of discussion around the comparison of different modalities and costs. Clearly, there is a need to reduce the cost and use images complementarily. So I would like to take one more question from the audience.
Sure. Another question from the audience. This one I think is much more general, but the person is asking, it seems that there are many very common myofascial trigger points. Has anyone looked at why this might be? So this is a more general question.
So who would like to take on?
Who would like to take this one?
All right, Dr. Tick.
Hi, there is some early research from the 1970s looking at the correlation between motor points and trigger points, and there was quite a bit of overlap there. But that wouldn't account for all of them. But that might explain why some of them are very commonly seen across patients in the same locations.
Thank you.
And I think we might have time if you want to. There was a final question that was actually directed to Dr. Stecco. There exists a hypothesis that there is no unbound water in the body except urine. All water is bound water in fascia. What is the composition of your quote unquote unbound water? Just hyaluronic? How is this called water? So Dr. Stecco, we'll leave with
right. So we discussed with our colleagues radiologists about this. Basically, we didn't have any clue about how water was bound with what inside the fascia. So we know that can be protoglycan, glycosaminoglycan generally, it could be hyaluronan, but it could be other protein over there. So if I can just quickly pull up the imaging that I presented before, okay, this imaging doesn't give you any idea about what exactly is there. For this reason, we use hyaluronidase, so the enzyme that metabolizes hyaluronic acid. So the difference between the imaging pre and imaging post has to be related to hyaluronan. And as we know, hyaluronan is able to bind up to 100 times weight water. But we have a great literature that explain that the hyaluronan can self-aggregate. And so in this case, we have like a matrix with like a big hole, like you can see. Inside this hole, basically the water is not like a primary binded, but can be secondary binder or unbound, as they say. So there is a quite good literature, but it's all in basic science. So in vitro, this is the first data we have in vivo. So it's a work in progress for sure.
Thank you, Dr. Stecco. Dr. Liu, I think that brings us to the conclusion, the 5 questions that we prioritized from the audience members, and we're at 2:52 p.m. So it is actually time for our break. Would you like me to go ahead and take us to break now? Any final thoughts?
Yes, that's right. So I'd like to offer some final thanks to all of our speakers, our panelists, and our audience. Thank you so much, and we will see you during our next session. Thanks.
Yes, so everybody please rejoin us promptly at 3:05 p.m. for session 3. And all of our panelists, please go ahead and mute and turn off your video at this point, and we will go on break. Thank you so much. We'll see you shortly. And to our attendees, just a heads up that we are actually archiving this, and it is being recorded, and it will be shown later, available for you to see later on NIH Videocast. Thank you.
I'm very grateful to the Dr. Langevin and the conference organizers for letting me speak today on imaging the elastic properties of muscle using ultrasound. And what I'd like to do is start off, first of all, with a little background. How did we get here and what are we doing? Well, the field of radiology and medical imaging is about 100 years old, a little over 100 years old. Biomechanics is even older than that. They both had a spectacular development period in the 20th century, but they didn't cross-pollinate. They didn't talk to each other very often. But that changes around 1990 with the dawn of what we call today elastography, or basically measuring and imaging the elastic properties of tissue. So some of the early papers are shown here from University of Rochester, from Tokyo Institute of Technology, and from University of Texas. Now, these two groups used shear waves, basically external vibration sources propagating shear waves through tissues and making measurements of those shear waves with ultrasound. This technique, which is an alternative, uses static compression and looks at strain images in tissues. And we'll take a quick look at what's under the hood of these and how they work today. Shear waves are tremendously useful for elastography, and here's why. Shear waves propagate transverse or sideways to the direction of propagation, okay? And they're relatively slow. So shear waves in soft tissues, maybe 1 meter per second or a little more, basically. Meanwhile, compression waves are much more familiar to you. The sound of my voice comes from compression waves, and ultrasound pulses in imaging systems are compression waves. So these travel thousands of times faster, and the pair of these together make a tremendous combination, because shear wave speed, it turns out, is directly related to the shear modulus, which is related to Young's modulus and stiffness. So if a tissue feels stiff to you with your fingers, very likely it has a high speed of sound, or excuse me, shear wave speed. And the fast, much faster ultrasound imaging pulses can be used to map out the shear wave, measure the speed, and make a beautiful image of the local shear wave speed throughout tissue. That's basically the shear wave ultrasound elastography physics. The alternative technique, though, would be to use slow compression or slow shear, that is very slow movement, while the imaging system is running. All the frames of the images are placed into the computer, which calculates the local displacements, and then you can figure out either what's hard and soft tissue from the local motion or other parameters in more advanced models. So today, elastography has grown enormously over the last 30 years, and there are quite a few techniques available. One way of organizing them all is by looking at the type of applied stimulus, whether you apply slow compression or slow motion or shear to the tissues, or whether you apply, let's say, 50 hertz or 100 hertz harmonic shear waves through tissues, or whether you use transient, very sharp pulses, which propagate shear through tissues. These are sort of broad categories, and we'll take a look at some ones that might be particularly useful for muscle. This is, not to overwhelm you, but this is a time chart going from 1987 to current date, showing each one of these is a unique, published, valid elastography technique. Now, it looks like there are quite a few of them, but actually only a few of these are in widespread use that is embedded in commercial imaging systems. One of them is, an important one is magnetic resonance elastography, pioneered by Dr. Eamon, and that he will be speaking on that shortly. So we're going to focus on a couple of ultrasound techniques here. A fairly widespread use of elastography embedded into an ultrasound system was generated by a French company. They call it the supersonic imaging system. And it uses a very nice set of physics. If you focus ultrasound to a point and give a very sharp, short pulse of ultrasound, you actually impart a radiation force. So if you do that very quickly, it's as if you reached into the middle of tissue where the focus is, flicked your finger, and that launches a shear wave disturbance away from the focal point. Then you switch back into an imaging system and you measure the progress of the shear wave. And the shear wave speed tells you a lot about the stiffness and other parameters of the tissue. In fact, you can do this push pulse sequentially fairly rapidly at increasing depth within the tissue. And that launches a very nice long extended shear wave, which propagates out. It can be imaged by the fast ultrasound imaging system. And again, the measurement of the shear wave speed tells you about stiffness. And there are actually higher order parameters we can measure as well. And this is what it looks like. This is a supersonic B-scan image of a liver, a young liver. And then here is with all of the shear wave measurements have been made. They've been embedded as a color chart. Blue tends to indicate lower stiffness. Red tends to indicate higher stiffness. And this is widely used today in liver, breast, thyroid, and other soft tissues. Now, what about musculoskeletal elastography specifically? Well, it has been growing since the original paper by Sato, which actually considered shear waves propagating through muscles. But things have taken off rapidly since in the years since 2000. So here's an example from a French group, year 2003. This is one of their first prototypes. It puts a sharp transient into the muscle, the bicep here. Then there's an imaging system which measures out the shear wave displacements. And that's shown here. This is depth versus time. Over time, this will propagate out. You measure the shear wave speed, and then you can do this along and across the muscle fiber directions. So here is a graph of anisotropy showing the shear wave speed, measure of stiffness, measure of wave propagation, as a function of angle with respect to the primary orientation of the muscle. So now you can get higher order parameters such as anisotropic measures out of the ultrasound system. This is from Dr. Sikdar, who spoke earlier today. Here's some elastography measurements, applied external vibrations, measured in a muscle with Doppler system here, showing the flow of vibrations, or shear waves, I should say, and an anomaly here at the trigger point. And then here's a similar version with acoustic radiation force pulse, propagating shear waves, blue, red, again, indicating a relative hardness and softness, and the anomaly shown here. This is from a Hong Kong group, well-respected group. Here's a B-scan showing the beautiful fiber orientations. And then when the elastography is turned on, you get a color picture and you get a measurement here, which is quantitative, fairly reproducible, and can be measured over time under different conditions. And then here is a different scan, including a tendon. And when the elastography is turned on, the region around the tendon is red, meaning higher stiffness, the regions below lower stiffness. They have also created a handheld device which makes local measurements applied to the surface of the skin over a muscle. And they claim that there's a very high correlation between the measurements they can get from this device and the measurements they can make with the more complicated imaging system. Here's another example of individual muscle force. Again, the blue versus red or orange indicates relative stiffness in this muscle, contraction making the muscle stiffer. You can do this over time. You can do this under different conditions of the muscle. This is from my colleague Terry Koo, looking at the passive stretching response. So here again, we've got a muscle under increasing amounts of passive stretching, and the transition from blue to more red-orange colors indicates a progressive stiffening of the muscle. So there are different types of elastography available on commercial ultrasound instruments. For about $100,000, you could get a scanner with embedded elastography, and you could make measurements basically using these commercially available scanners. There are research capabilities that can also be purchased for much less, although in many cases you have to do your own programming if you buy the more modular research equipment. But nonetheless, these capabilities are now available at a variety of price points for researchers. So what about the future? Where is this all going? Is it, and basically with reference to Dr. Langevon's conceptual slide here, and we have to be careful because when elastography is introduced and when it's talked about, we usually have in mind basically soft tissue as a bowl of jello. It's large, it's homogeneous, it's isotropic, it's passive. Muscle is, of course, much more complicated than that. It has active innervation, it is a composite, it's inhomogeneous and isotropic. There are many layers. There are important boundary conditions on all sides of the muscle. So it's a much more complicated situation. So basically, my prediction is that the elastography, both the models and the technology, are going to be honing in on these factors at higher and higher spatial resolution so that we can start to really untangle the fine structure of what today is seen as more of a aggregate or composite measure of tissues. And this is what's going to unravel some of the important details of both chronic and acute conditions. So that's a quick overview. And I just wanted to add that if you want to read more about elastography in terms of an overview, there's a review paper on my website. It will be updated shortly to a more modern version, but it does provide a nice overview of the development of elastography. Thank you very much.
Thank you very much, Dr. Parker, for this nice overview of ultrasound elastography. Our next speaker is Dr. Hélène Langevin, NCCH Director. The title of the talk is Measurement of Shear Plane Tissue Mobility Using Ultrasound Elastography Techniques. Dr. Langevin.
Thank you, Mara. Whoops, trying to share my screen here. Great. Can you see that?
Yes, we can.
Yes.
Okay, good. Well, thank you so much, Dr. Parker. That was such a really wonderful overview of elastography. And it's going to be a little bit of, it's going to be an interesting segue into my talk, because Dr. Parker, kind of really focused on elastography to measure tissue stiffness mostly. And I will talk about a different approach to elastography, which is to look at the measurement of shear plane tissue mobility. Now, I want to make sure that everybody is clear that the type of shear or shear strain that I'm talking about is very, very different from the type of shear wave, right, that Dr. Parker was describing that are produced by the ultrasound, stimulus. So I'm going to explain this because shear strain is not a concept that is totally familiar to a lot of people. So I will start by explaining why shear strain measurements are important in the evaluation of myofascial tissues and why we would want to do them. So when forces are aligned with each other, either pushing things together or pulling them apart, they're called tension or compression forces. And the resulting stress, right, is the force divided by the cross-sectional area of the object to which the force is applied. And in contrast, shearing forces, right, are unaligned forces, pushing one part of an object in one direction and another part in the other direction. Now, of course, after all of the discussions that we've had this morning, it should be, clear by now that palpation of tissues, right, is a very important part of the clinical evaluations of patients with myofascial pain. And during palpation, the practitioner applies both compression as well as shear forces, first by pushing down on the tissues and then sliding the tissues laterally. So what is it that clinicians are evaluating both during the compression of the tissue and also during the shearing palpation? Compressing the tissues, right, is a way to evaluate the stiffness, right, of the tissue. how much it takes more force, right, to compress a specific part of the tissue. And one would conclude that this area is stiffer. And this technique has long palpation, right, to evaluate stiffness is a technique that's been a long-standing usage in the evaluation and diagnosis of, say, clinical evaluation of breast cancer, for example. Now, a lot of the techniques that Dr. Parker was describing have this in mind, right, in terms of quantifying how stiff an area of tissue is. Now, applying a shear force during using your hands, right, by first compressing and then sliding with your hands, gives a different kind of information that is also important by allowing the examiner to evaluate shear strain. Now, a lot of people get confused about the difference between stress and strain. Strain is the deformation in a material that occurs as a result of a stress that's applied. So the stiffer the material, the smaller the strain. Now, for shear forces that are moving two layers of material, one past another, the strain is inversely proportional to the distance between the layers. So the closer and the thinner the layers, the greater the strain. So during palpation, right, applying a shearing force allows the examiner to evaluate how much the tissues are able to deform along a shear plane during the examination. If the tissues are sort of stuck together and not moving freely, like there were descriptions of this morning during the clinical presentations, then less shear strain will occur as a result of applying the shear force. Shear strains play a very important part in physiology of the body, especially in myofascial tissues, because they are organized in layers. And the layers of loose and dense connective tissues that surround and separate muscles create multiple interfaces where shear strains naturally occur when the tissues are passively moved due to an external force or actively moved during muscle contractions. Like Dr. Parker was saying, these musculoskeletal tissues are very complex, and therefore a lot of sort of shear plane interfaces are kind of what we're dealing with in terms of the physiology here. And importantly, pathological processes like inflammation, fibrosis, scarring, adhesions, all can produce a reduction in shear strain between adjacent layers of tissue. So that's why we may want to look at that. My research group, way back when I was at University of Vermont some years ago, developed a method to measure shear strain within the thoracolumbar fascia in human subjects with and without chronic low back pain. Now, the thoracolumbar fascia, we've talked a little bit about it already. It's a huge structure in the back, and it's composed of multiple layers of fascia that are actually the aponeuroses of muscles that have different directions of pull, right? The rostrocaudal direction for the latissimus and multifidus muscles, and then medial lateral directions of pull for external and internal oblique and transversus abdominis. So it makes sense that these layers would not all be sort of stuck together, right? And in fact, this is the case. And there are thin layers of loose connective tissue, and you can see them on these ultrasound images that appear, that separate the fascial layers. And if I can point to them with my pointer, I don't know if you can see that, but and the loose layers of connective tissue within the fascia here appear dark. Whoops. While the fascial layers appear bright. Now, shear plane motion between fascial layers is nicely demonstrated using an ultrasound recording during passive motion of the trunk in a human subject lying prone on a motorized table. Now, the recording I'm going to show you is made with the ultrasound transducer oriented longitudinally 2 centimeters from the midline at the level of the L2-3 interspace in the back. So the up and down motion of the table is causing the back to flex back and forth passively. So hopefully my video will play here. And if you concentrate, if you focus on that big white band here, the thoracolumbar fascia, hopefully you can appreciate that not all of the layers are moving at the same rate. And in fact, there are some layers that seem to be moving in the opposite direction to the one immediately above or below it. And that creates a shear strain. right? Now, in contrast to this movie, I'm going to play an example of a patient with chronic low back pain. And I hope you can see that these layers are not sliding past one another quite as much. And it seems like there appears to be less shear strain within the layers of, between the layers of the fascia in this particular case. So how can we measure this? Now in order to measure this, we used a rather old-fashioned method using the sort of conventional method of doing elastography. But I'm going to explain exactly the problem that we're trying to solve here is illustrated here with the yellow and orange objects. And what we want to know is how much does the orange box move relative to the yellow box, right? So how can we use ultrasound data to calculate this? An important thing to point out is that the shear plane movement of the tissue that we will want to measure in the thoracolumbar fascia is parallel to the skin and therefore perpendicular, right, to the ultrasound beam. This is harder to measure than movement that is perpendicular to the skin. And in order to illustrate this, it's useful to look at how this kind of slow compression elastography that Dr. Parker was describing, how can tissue displacement be measured along the direction of the ultrasound beam when the ultrasound probe itself is used to compress the tissues up and down? This was an early application actually of ultrasound elastography that was initially developed to quantify the stiffness of cancer lesions using the probe itself to compress the tissue. Beam mode ultrasound is composed of an array of parallel ultrasound transducers, which produce multiple lines, right, of ultrasound data. And each line is a radio frequency waveform, we call an A line. And it produces multiple, the A line varies over time, right? The radio frequency wave, depending on the echoes that are bouncing back from the tissue. When the tissue is slowly compressed, the waveform will change slightly, as illustrated here. So you see this goes from pre-compression to post-compression. And you can see that in the soft areas of the tissue shown in blue, individual segments of radiofrequency data are moving quite a bit, going from this position here to this position here. But in the stiffer areas of the tissue shown in purple, you see that the waveform is moving, is displacing not quite as much. So by plotting the displacement, one can generate a 2D map that shows the areas of the tissues that move more versus those that move less. But what if you want to measure the movement that is lateral, right, in a lateral direction or perpendicular to the ultrasound beam? This is harder because we have thousands of data points, right, in each radiofrequency vertical line, but only 1 or sometimes 200 points in the lateral direction, depending on the array that is used. And we need to go across, right, the A lines to look at the lateral motion. But this can be done, and if you plot the lateral displacement in the movie that I showed earlier, and you color red to show the cumulative displacement toward the right, and blue to show the cumulative displacement towards the left during 1/2 cycle of the table, moving either down or up, you can see that there's an obvious plane within the thoracolumbar fascia where the maximum shear strain occurs. And that's at the interface between the red and the blue. So if you want to calculate the shear strain across this interface, there's another step. So when you need to calculate the average lateral displacement between two small adjacent windows, as shown here, and then compute the differential displacement between the two windows and divide by the distance between them. This gives an estimate of the shear strain at the tissue interface. And by incrementally moving the windows, it's possible to determine the point where the maximum shear strain occurs. You get a measurement of this. So using this technique, we were able to show a difference between the average shear strain within the thoracolumbar fascia in human subjects who had chronic low back pain for more than 12 months compared with those without low back pain. Now, reduced shear strain at the muscle fascia interface could have resulted from either fibrosis or adhesions that would actually glue the fascias together, right? Or could result from the muscles contracting, right, and not allowing the fascial layers to move. So to address this question, we used this method in a porcine model where we showed that combining a small injury with a movement restriction caused a reduction in the thoracolumbar fascia shear strain even when tested post-mortem. So this suggested that the fascia adhesions can actually create the type of shear strain abnormalities that we were observed in the human subjects with low back pain. Now, it is still possible, of course, that some of the reduced shear strain that we saw in the human subjects with low back pain could have been due to the muscle abnormalities, such as increased muscle tone, right? But so far, this is still an open question. The ultrasound technique can also be used to measure shear strain at the interface between nerves and adjacent tissues in human. But this has only been done in a large nerve, such as the sciatic nerve that's shown here. So far, there's been no study that I'm aware of that has used this method to study myofascial pain syndrome. As we discussed this morning, the detection of abnormal tissue mobility during palpation in myofascial pain syndrome could result from abnormalities of fascia as well as muscle, and probably both. So if there's indeed pathology in the fascia, this could be an important part of the chronic, right, myofascial dysfunction. But pathology of muscle is also intriguing because it could have an acute component, right, as well as a chronic one. Some of the strengths of using ultrasound elastography techniques to measure shear strain in musculoskeletal tissues, the ones that I've showed you, are that it is a relatively simple technique that can be done using standard ultrasound equipment, as long as it can output the radiofrequency data. And an increasing number of companies, ultrasound companies, are providing this. The ultrasound movie gives a nice visual that can be used to interpret the elastography data. And in this method, I showed that calculating shear strain requires post-processing, right, of the ultrasound data, which is an extra step, but we have found it to be more reliable than some commercially available methods for measuring shear strain based on edge detection in the tissues using the B-mode ultrasound images. One important requirement for any type of shear strain measurement is standardizing the mechanical input, which presents different challenges depending on what body region one is imaging. A main drawback for all ultrasound-based method is that the data are two-dimensional, as was previously mentioned, and are influenced by the position and tilt of the probe. So great care must be taken to avoid compressing the tissue during the image acquisition, and also to not slip at the skin interface during the data collection. We found that the shear strain measurements have good test-retest reproducibility when measuring a simple structure and the position of the ultrasound probe position is carefully controlled. Now, we chose the low back for our study partly because of the nice flat plane provided by the thoracolumbar fascia, but measuring shear plane motion in complex tissues that are not parallel to the skin is much more challenging. This is particularly important when performing repeated measurements over time to make sure that they are performed under as similar conditions as possible. So in summary, shear plane tissue mobility is an understudied aspect of musculoskeletal function that may be important in myofascial pain syndrome. Ultrasound elastography techniques can be used to quantify shear strain at tissue interfaces, but have not to date been applied, right, to myofascial pain syndrome. Limitations include the 2D nature of the ultrasound data and operator dependence of image acquisition. And when measuring shear plane motion at complex tissue interfaces, other techniques that yield 3D data may be better suited than ultrasound, including some of the MR methods that will be discussed next.
Thank you very much, Dr. Langevin. We'll move on to our last speaker for today, Dr. Richard Eman from the Mayo Clinic College of Medicine and Science. The title of the talk is MR Elastography, Quantitatively Characterizing the Mechanical Properties of Skeletal Muscle and Myofascial Interfaces.
Thank you very much. Do you hear me okay?
Yes.
Excellent. Okay. So thanks. I really appreciate the opportunity. Thank Dr. Langevin and Dr. Liu and the other organizers for the opportunity to be involved in this, participate in this exciting workshop. Just take a moment to let you glance through my disclosure slide. So my group, inspired by the work of Dr. Parker and other people in the ultrasound field in the early 90s, embarked on a project to develop an MR-based elastography technique that we called MR elastography, which we published in 1995. Basically, the discovery that made this possible was finding a way to image shear waves inside the body, even though they have amplitudes that are on the order of microns. And far below the resolution of what you could see with the resolution of MRI. But it turns out MRI is remarkably versatile, and there is a way to actually image these shear waves. The main use for MR elastography right now in the clinical world is to evaluate liver disease. It works is that we put mechanical waves into the liver, in this particular case, with an external device, and then image those waves using an imaging technique, which was the subject of that science article, which allows us to see these waves as they propagate through tissues in the body. And then following that, applying a mathematical algorithm, which understands how these waves propagate and can calculate mechanical properties. And this has turned out to be the most accurate, non-invasive way to assess liver fibrosis, and it's now widely used. It takes about 15 seconds of imaging time to acquire the data for one of these slices here. Typically 4 are done. There are about 1,500 systems around the world that are equipped for MR elastography. It's now got a standard CPT code 76391, and the medical charge, since there has been an interest in the cost of imaging, Medicare charge for MRE is $350, which surprises some people. That seems quite low. MRE, with this technology, we can certainly calculate stiffness, which is what we often talk about when we talk about elastography. But in fact, with MR elastography, we can do a model-based calculation of something called the storage modulus and something called the loss modulus, the real and imaginary part of the complex shear modulus. Storage modulus has to do with elasticity. Loss modulus has to do with viscosity. And so we can get into that. There are other mechanical biomarkers that we can calculate from this very rich data set, attenuation, volumetric strain, but also we can actually directly calculate shear strain, even though these are very small motions that are being applied. I'll come back to that at the end. So my goal here is to give you an overview of the current state of the use of MRE, the applications that have been explored. This is not a clinical tool in musculoskeletal imaging, but from the research standpoint, what has been explored with MRE and the musculoskeletal system. And at the end, I'd like to finish with a little bit of speculation about how the technology could be applied to evaluate fascia. It turns out that it's remarkably easy to get mechanical shear waves into muscle and to image them with this technique. This was a paper in 1996. And very shortly after that, it became clear on muscle experiments that we could quantitatively assess the mechanical properties of muscle and look at it under load. So we could see, as we increase tension, we could see that the shear modulus would increase in these extracted muscles. And from that, we could actually calculate the distribution of tension within the muscle. Shortly after that, in vivo studies began, and looking at muscles under loading. Here's a muscle with 0 loading, the biceps brachii, and here it is with 4 kilograms of load on the arm, as you see here. And we ended up with being able to characterize the stiffness of muscle under load, which varies with load. And this, of course, became very interesting, was seen as very interesting to people in the world of biomechanics. And so a lot of the work that's been done in using MRE for muscle in the experimental world has been in the area of biomechanics. This is an early study done at Mayo Clinic by our biomechanics team, where they developed an MR-compatible load cell, so you could apply known loads of plantar flexion and dorsiflexion around the ankle to look at the distribution of tension within the muscles of the calf. And so here we see unloaded, and here we see loaded. You can, with dorsiflexion loaded, you can see how the wavelength gets longer, which means that the stiffness is higher. And when they compared the various muscles and various degrees of ankle torque from positive to negative dorsiflexion, we're able to characterize the stiffness of muscle under these different conditions. And you can see how that would be of interest to people in the biomechanics world. And so since that time, this has been further developed. especially by Dr. Sabine Bensamoun in Compiègne, France, who has really shown how it's possible to characterize, for instance, in the thigh, multiple muscles in one examination and look in great detail at the stiffness of muscle versus loading, which is a way of characterizing muscle function. And for instance, this is work that she did in patients with hyperthyroid myopathy, where we know that we're looking at the stiffness of the relaxed vastus medialis before and after treatment for this particular condition, which affects the proximal muscles and particularly the slow fibers. And here in 2 patients prior to treatment, this shows the stiffness of the resting muscle, and here after treatment, a dramatic change, and shows the ability with this quantitative technique to look at longitudinal changes. The work continues on the technology, and this is a recent article showing the ability to do this in a very rapid rate, almost real-time elastography of skeletal muscle. This is coming out of Germany, the Charité group, Dr. Sack and colleagues. Here are the muscles in the anatomic image, and here's with dorsiflexion. They're imaging these muscles and their tension and their mechanical properties at 6 times per second with this technique. Dorsiflexion, again, with tension in the tibialis anterior, and then plantar flexion with tension in the muscles of the posterior leg, including the soleus and the gastrocnemius muscles, as you can see here. Then, let's see. Then, moving on from measuring just elasticity, we can also measure the viscous properties of muscle. And this is some work again from Dr. Bensamoun showing measurements of elasticity in thigh muscles, and here of the imaginary component of the complex shear modulus, which is related to viscosity, which of course is of great interest in this particular subject. This is just another example of another individual who's actually on our panel here from Dr. Neil Roberts from Edinburgh. They looked at the effect of muscle injury caused by brief intense exercise on the mechanical properties, the stiffness of muscle, and then also on the viscous properties. I won't go into what they found, but again, so you can express the viscous properties either with something called as I say, the loss modulus, or you can measure the angle that's created between the real part and the imaginary part of the complex shear modulus, and that's expressed as in different ways, but here as theta. And then another panelist that we have today, Dr. Klatt, did early work looking at the effect of loading on both the magnitude of the elasticity, but also on a measure of viscosity. And you can see how with increasing loading, both of those parameters change. So obviously these are biomarkers that could be very interesting. Well, what about evaluation of myofascial taut bands? We know that there's something there physically. We know that you can see some things with ultrasound as well, and those things. Well, we can also see, there's also evidence that we can see this with MR elastography. This is early work. Here is a normal elastogram of a trapezius. Here is a patient who has a clinically documented taut band, and you can see that there's an area of localized increased stiffness. Another example here. And then in this work that was published several times over the last decade or so, one of the ways of looking at this is looking at the histogram of stiffness values within the tissue. I will say that in general, the areas of increased stiffness do definitely exist and are documented with this, but in that work, the concordance with the physical exam location was only modest. And I would say that that's probably could be addressed with improvements in the technology of the MRE technique. Finally, stiffness of lumbar paraspinal muscles, obviously of great interest. This is some work that came from France, and this is where they used MR elastography to evaluate paraspinal muscles. Here is a coronal image in rest, and here is a coronal image in contraction, particularly focusing in on erectospinae and multifidus muscles, and they found indeed, as you would expect, a change in stiffness of these muscles with contraction, something that then could be used in research related to back pain and muscle. Now, I'd like to finish this really quick overview with some speculation about myofascial interfaces, because I realized after hearing about this that there is real interest in looking at the fascial interfaces. I only wish they were as clearly defined in the images we see, as you see here, but they are important, as we've heard, and inflammation, changes in the matrix and fibrosis can affect these slip interfaces. Well, we've done, I went back and dug out some work to see whether or not we could could suggest some ways in which MRE might be developed to evaluate these. And I'm going to show you 2 ways in which this is true. Here we did a study where we vibrated individually each finger and then looked at the motion that occurred, the vibratory motion that we could detect, even though it's only microns in amplitude in the forearm. And of course, what we're looking at here are the flexor digitorum superficialis and flexor digitorum the deep flexor and also the extensors. And here we're vibrating the index finger, and you can see that there's a part of this muscle, which is defined on this side by a little bit of fascia, but this is all one muscle here. But you can see there's very discrete areas. The superficial and deep flexor muscle are lighting up here with this technique. Here's the middle finger being vibrated, here's the ring finger being vibrated, and here's the little finger being vibrated. And you can see that they're all distinct areas of the same muscle, the deep and superficial flexor. But again, if we wanted to say, okay, well, how independent are these, or how free are the fascial, are the surfaces between these parts of the muscle able to slide past each other? Well, we could look at the ring finger vibration. We can see, we can characterize the amount of motion that's being transferred to the middle finger and here to the little finger. So this would be one way to look at the fascial connections between muscle bellies. But I think we can go one step further. This is the second last slide that I have. And so, this introduces something called shear lines. In the heart here, the beating heart, this black line is the pericardium. The reason it's black is not because it has low protons content, it's because there's motion occurring there, and there's a phenomenon called intravoxel phase dispersion, which causes a loss of signal where there's a high degree of shear. That's a normal thing we can see with MRE when we have very high degree, in MRI, when we have high degrees of shear, but we can actually amplify that remarkably with MRE techniques where we can actually apply vibration. And because we have this very, very high sensitivity to shear motion, we can generate shear lines that would be very difficult to identify otherwise. And the application for this that's being used now in some clinical practice is to look at tumor brain adherence. Here we have a tumor that is where there is no adherence between the tumor and the adjacent cerebellum, and there is this black shear line that proves that. Here, this patient unfortunately has adherence of the tumor to the adjacent brain, which makes the surgery much more difficult. Now, we wanted to make this into a better clinical tool, and we can actually calculate locally the shear strain that's occurring. So instead of relying on a physical effect, we can actually calculate that, and that's now being used and has been published in work where here we have 2 brain tumors. This one is not adherent to the surrounding brain, an important thing for surgery, whereas this one is completely adherent because of the lack of that high degree of shear at the perimeter. So let me wrap this up with this final. So can we see this effect in the musculoskeletal system? Well, here back to the finger vibration experiment. This is where we're vibrating the middle finger here. You can see the deep and the superficial muscle. Well, obviously there must be a lot of shear across here. And in fact, when we have the motion off, this is what the image we get. Again, very, very high sensitivity to shear with this technique. Here's with the motion on. You can see we've had these black shear lines showing that there's in fact slippage of these muscle bundles relative to each other that allow for the motion to occur. There is without, here it is with. And we could, again, we haven't done this because this is old data, but we could calculate and characterize this slip interface here with this technique. So it again points to the possibility that we could use these techniques to not only to look at the viscoelastic properties of myofascial structures, but also at the degree of adhesion at functional myofascial interfaces. So last slide here, as we think about applying, exploring pathology using these techniques, we've seen we can measure muscle tension and stiffness in health and disease, look at viscosity, look at other anatomic regions. And so as I look at this list of requirements that Dr. Langevin has identified, certainly we can look at it, stiffness, reduced strain, reduced shear strain mobility. We can also look at viscous properties here. And then again, we also can assess structural factors such as scarring, fibrosis, and architecture, and probably some of these other things as well with this technique, with further technical development. So with that, thank you very much for your attention. And of course, thank you to NIBIB and the NIH for the funding that's made this possible. Thank you.
Thank you very much, Dr. Eman, for this fascinating talk. I'd like to take a moment to thank all our speakers for the excellent presentation. We now start the panelist comments part of this session. We have 6 panelists, and each has 2 minutes to share with us their perspective and reflections related to this session. Our first panelist is Dr. Shigao Chen from the Mayo Clinic, Rochester.
Thank you. Can you see my screen?
Yes.
So I do have some comments about elastography, but I will save that for panel discussion. Here, I would rather show a few slides that are more relevant to the previous session's talk, because Dr. Sikar talked about the potential value of Doppler microvessel imaging. So I just want to bring the attention to recent technology advancement in microvessel imaging using ultrasound. And this is like the image of a human kidney image in real time. You can see the microvessels in the cortex. And therefore, those might be very useful for trigger point imaging. And here is another technology we're developing. It's called super resolution imaging, where we require the injection of ultrasound contrast. However, we can acquire resolution with maybe 20, 30, 50 micron vessels. And we can also, this is, by the way, this is the chicken embryo gland. And we can also measure the flow speed within the microvessels. So the technology has been validated with optical imaging in the chicken membrane, embryo membrane. And you can see that we can even see the crossover intertwined vessels, microvessels. And this technology has also has deep penetration. This is a in vivo human cortex microvessels. And then we can also see the pulsation of the microvessel blood flow speed over the heart cycle. And this is a diseased kidney. This is a normal kidney. And then you can see that, I'm sorry, you can see that we can measure the flow speed in the microvessels, and then compared to normal kidneys, and it appears that the vessel density is lower, and also it's more tortuous. And I would stop here, and then.
Thank you very much, Dr. Chen. Our next panelist is Dr. Dieter Klutt from the University of Illinois, Chicago. Dr. Klutt, please unmute yourself.
Can you hear me?
I can hear you, but you're sharing the wrong screen. Oh, here you go.
Okay. Well, first of all, thank you to the organizers for inviting me to this exciting workshop. Let me first make a general comment that came into my mind after following the presentations and the discussions today. Pathological changes, right? They have an impact on the mechanical properties in a lot of diseases, or one could almost say in most diseases. And this is the basis of elastography. But you can also see it the other way around, right? Abnormal tissue loads, as for example, they occur when people have desk jobs or so, they can also result in pathology. So you could almost call it medicine to mechanics and back. But what I want to highlight here is the multi-scale nature of elastography in this slide, right? And a bit I reiterate what Dr. Parker mentioned already, that muscle or tissue in general is not simply homogeneous, it's not a simple model. So what does that mean? That means that when, for example, we have ex vivo deformation tests, then the mechanical properties that are determined there, they represent an average over all the components present in the sample. And these components can all have different mechanical properties. I want to indicate here that that also holds for elastography, right? There we get averages within the image voxel defined by the resolution. However, elastography can provide such an indirect view into sub-resolution mechanical properties by rheological modeling of multi-frequency data. So that we measure the elastic properties over multiple frequencies, and then we fit rheological models to the measured data that consist of different components. Okay, here now on this slide, I want to share with you and show that in my opinion, also stress has to be considered when relating the shear wave velocity to the mechanical properties in skeletal muscle, and that is well known. We saw that today already in the presentations. But it's important to highlight that even the type of stress has to be considered, whether it's active contraction or passive stretching. That plays also a role, right? Muscle is imposed to both stress types. When muscle is activated, it's active stress. And for example, abnormal tissue loads, they cause passive stretching. And recent research here indicates that we have to differentiate between those two stress types when relating stress and mechanical properties and shear wave velocities. So these images on the bottom are recent research by the group of Eric Perot at Northwestern University. Okay, thank you very much for letting me share my thoughts here.
Thank you very much, Dr. Klatt. Our next panelist is Dr. Neil Roberts from the University of Edinburgh. Please make sure your video feed is on and unmute yourself and share a slide if you wish to do so.
Can you hear me?
Yes, we can.
Oh, good, thank you. Hello from Edinburgh, and thank you to Dr. Langevin and the organisers for the invitation to say a few words at this great meeting and this exciting session. I'd first like to draw some further attention to the work of Dr. Sabine Bensamoon that Dr. Eamon has already shown, which is shown in the left on this slide, and shows the robust measurements being made of individual muscles in the thigh, 9 individual muscles made, individual measurements made by several different acquisitions. My colleagues in Edinburgh, Eric Barnhill and Paul Kennedy, whose work is shown in the middle and on the right of the slide, they've studied also with 2D MRE a section through the thigh. And Eric's work in the middle, you see statistical mapping of the changes in the muscle of the thigh when the leg is raised from the table within the MRI scanner. So we have this showing in the bottom image here, where the statistically significant changes in the thigh muscles due to that lift in an average of 11 different subjects who are co-registered. And then Paul Kennedy's work, he studied a cohort of 9 subjects, young subjects and older subjects. You see the older example of an older subject on the top row here. And again, with statistical mapping, is able to show where there are changes with age. And Paul showed that actually the muscles seem to get less stiff with age in this study. So this combination of statistical mapping here assumes that the conditions are the same before and after the lift, or relatively similar when you co-register thighs of subjects of different ages. But this must be combined with the rigor of Dr. Bensamoon's work, where you are accounting for the direction of the muscle fibers. And so I'd like to flag this up as an important area for funding, is to continue to develop the elastography technique for robust measurements to combine this excellent wave propagation you see on the left with statistical mapping. So that's the first point I'd like to make. The second point I'd like to make is because of an interest I have in the Alexander technique, which there was a study done, published in the British Medical Journal in 2008 that showed 6 lessons of the Alexander technique plus guided exercise were as effective as 20 lessons of the technique. And I don't know if people might be aware, the therapists who might be involved in this meeting, that Raymond Dart, a famous anatomist, was had lessons from an Alexander technique teacher in South Africa in 1940s, and she left to go back to the UK, and he spent some time thinking what that meant, what he had to do, rather like if you'd only had the 6 lessons. His work, written for medical scientists, is published in this book, Skill and Poise. And he met with, in Philadelphia, with 2 Alexander teachers, Joan and Alex Murray, who developed his thoughts into what are called the DART procedures. They're described in this book, beginning from the beginning. And I think it's important to just bring some more awareness on these procedures, because it's about taking self-responsibility for dealing with pain, for example. And
yes,
so
Dr. Roberts, we're going to have to go on because we're running a little bit short on time, so we want to allow the other speakers to also have a turn.
Yep, I finished.
Yeah. Thank you.
Thank you very much, Dr. Roberts. Our next panelist is Dr. Sergio Sanabria. Dr. Sanabria, if you could turn on your video feed and share your screen and unmute yourself.
Thank you very much. I am trying to share my screen. Let's see. Perfect. Is everything working? So, do you see my screen?
Yes.
So thank you very much for the opportunity to be part of this workshop and for the great presentations. I would like to start my comment with borrowing a slide from Dr. Parker, where we have seen that CR waves nowadays play a very important role in elastography. However, we have seen as well that there are other types of waves occurring in ultrasound, like pressure waves. And my comment goes in the direction of these pressure waves. And the question I'm addressing is, can we use ultrasound to quantify fatty infiltration, for instance, in myofascial pain syndrome applications? This is as well an important component of muscle mass and quality loss, especially in the elderly, and it is possible that it is also a perpetuating factor of MPS in older adults. Currently, we have a gold standard magnetic resonance imaging to measure fatty infiltration, fat fraction in the muscles. However, we are missing objective ultrasound elastography methods for fat tissue quantification. Speed of sound is a very interesting biomarker, which is an emerging technology. It measures the velocity of pressure waves in soft tissues, and tissue composition has a strong impact in the speed of sound. For instance, we see that waves propagate slower in fatty, around 1,440 meters per second, than muscular tissues, where we have around 1,585. There are emerging clinical applications of speed of sound as a biomarker for tissue composition quantification. And we have applications in cancer, liver, and as well upcoming applications in muscles. And here I want to show an example where we use a very, very simple setup to measure the speed of sound in muscle tissues in the calves, using an ultrasound probe from a clinical system and a reflector on the other side of the calf. We can measure how fast the waves travel through the tissue. And what we can see is that the speed of sound quantitatively correlates with the magnetic resonance imaging fat fraction, with a very strong correlation. So we have here an alternative of emerging technology which can provide an ultrasound biomarker for affordable bedside muscle density monitoring. As well, I want to give a last hint, saying that the preliminary clinical evidence is showing that the speed of sound is not significantly affected by muscle tension or by muscle fiber orientation. So we may have here other opportunities to achieve different reproducibility constraints depending which technology we are using. So thank you very much.
Thank you very much, Dr. Sanabria. Our next panelist is Dr. Siddhartha Sikdar. Dr. Sikdar, if you could share your screen if you have slides and unmute yourself. Thank you.
Thank you. I just wanted to make a couple of brief comments. So when we started looking at ultrasound elastography of these myofascial pain, we were expecting to see that elastography will show us that the muscle is actually stiffer, mechanically stiffer, so that the shear wave propagation speed would be slower, as well as the amplitude would be smaller. But to our surprise, what we found was that instead of observing that, what we kept on observing was that when we do color Doppler, we see these regions of color void in the images. So it appears that the shear wave is actually not propagating through a portion of the muscle. And this was actually quite surprising to us. This is not what we were expecting. And we have consistently seen that for the last decade or so. So there's a range of findings that we can observe. One is that a normal muscle that appears to be vibrating uniformly, but with the various levels of the pain and as well as other palpatory findings, the appearance of the muscle appears to be more heterogeneous. And heterogeneous in the sense of lack of these vibration signatures in the muscle. So what we have done is we have quantified something called the muscle heterogeneity index, where we calculate the region of the muscle that's not vibrating or not supporting the propagation of these shear waves. And we find that that is actually correlated with the response to dry needling treatment. So if you look at the muscle heterogeneity index at baseline and after 3 weeks of dry needling treatment, there is a decrease in the heterogeneity index. And at week 8, this continues to get smaller. The heterogeneity index goes smaller. So at baseline, there is a large dispersion between our subject population. So there's a big population variability, but if you track individual subjects, their heterogeneity seems to decrease over time after treatment. And the other observation we made is that if you look at the shear speed as a function of the orientation of the ultrasound transducer with respect to the fibers, as Dr. Parker mentioned, we expect to see that the shear speed along the fibers is significantly higher than across the fibers. So this is a well-known phenomenon. But what we're surprised to see is that as we change the angle, we see this asymmetry in this dispersion of the shear speed with the angle. And it seems like in normal individuals, there is not a lot of asymmetry. So there's a symmetric distribution of the shear speed as a function of angle. But in the individuals with active myofascial trigger points, there appears to be this asymmetry. So on one side, going from, let's say, 0 to 90 degrees, the shear speed increases differently than it goes if we rotate the transducer the other direction. So this, again, gives us some hints that this is a little bit more complex and perhaps related to the connective tissue the infiltration and the sort of the somewhat more complex phenomenon than just a stiff region in the muscle. So I would like to just put that up for discussion, and thank you.
Thank you very much, Dr. Sikar. Our last panelist is Dr. Robert Vining from Palmer College of Chiropractic. If you'd like to share a screen.
I don't have a screen to share. I just have some comments to share.
Thank you.
Thank you to the presenters for describing some of your work. I am both a researcher and a clinician who uses manual therapies. And my current research focus is on non-pathological conditions, mostly related to the spine. I'm currently studying ultrasound measured shear strain in people receiving treatment for chronic low back pain, specifically looking at myofascial tissue movement or mobility changes under different conditions over time and with treatment, building off research that has been conducted and presented today by Dr. Langevin. All manual therapies interact with fascia regardless of the therapeutic intent through pressure, friction, stretching, mobilizing tissues, and so forth. They're used to reduce muscle tone, disrupt or stretch presumed adhesions, reduce inflammation, edema, and several other purposes. But manual therapists and others treating people with at least what we think is myofascial pain work from a theoretical or experience basis. We don't have objective tests to confirm myofascial pain as a diagnosis or to assess treatment response. We don't have an ability to quantitatively assess the myofascial contributions to symptoms. These conditions can co-occur with other pain-producing conditions, and they don't necessarily occur in a vacuum. But I'm hopeful that mechanically based imaging or other modalities that have been discussed today can develop and eventually offer an improved capacity to objectively diagnose and quantitatively assess myofascial pain, to enable research that so far has been beyond our grasp, that can enable practitioners and patients to better understand how to apply manual therapies and when, and just as importantly, when not to use manual therapies.
Thank you very much, Dr. Vining. We'll now open up the session for a panel discussion among panelists and presenters. Please remember to turn on your video feed and to post your questions using the raise hand feature. Dr. Langevin will moderate this portion.
Dr. Langevin, this is Catherine. We do have a few things that have been posted into the Zoom chat. If you would like to have me read those out, that's fine, or we can start with the hands as raised.
Are these questions from panelists?
Yes, these are questions that panelists have been posing during the course of the discussion.
Okay, go ahead.
Great. We'll start with, this might be why Dr. Monk has her hand raised as well. She says, to confirm my understanding of what was just presented, this is in regard to your presentation, Dr. Langevin, the calculations Dr. Langevin presents seems to address the issue of combining data from different areas of the body if the unit of measure is shear. If the way shear is measured remains consistent, changes in shear due to a particular intervention may be combined. Can they be combined from different areas of the body? So that was a question that came in from Dr. Monk.
Well, that would assume that you can measure them in different parts of the body, right? And so far we haven't shown that. I mean, in my lab so far, we've only looked at that in the thoracolumbar fascia and then also along the sciatic nerve. Now, I was really excited to see Dr. Eamon's images showing these really nice shear plane, interfaces demonstrating movement along a shear plane movement along a specific plane that was clearly visible. I think there's a lot of promise to that could be done on a more whole body scale, right? If you wanted to, I mean, we saw this morning PET imaging of the whole body. I think to do MR imaging of the whole body, that would be a little bit more, but it's not impossible, but it would be, ultrasound has to be done one specific region at a time, right? Whereas I think you have more reach if you're using a technique that can look at larger. I don't know if this answers the question.
I think it does. I think it does. I saw that Dr. Sluka posted a question as well. We'll take that one and then I'll turn it back over to you. I think Mr. Mulugeta might be next in line. Dr. Sluka posed the question, how much do you think the alterations in mechanical function measured by elastography are related to a pathology that needs to be quote unquote fixed versus a secondary consequence of the pathology? And then she has a couple of follow-on questions here. Are there any data suggesting that if we improve the movement patterns, we improve the pain and disability? And if we blind the investigator doing the imaging and include pain and non-pain individuals, do we get a clear signal and difference between groups? So there's a lot packed in there. So who would like to take that one? Who would like to tackle that one, Ellen?
Anybody has an appetite for this one? It's a good question.
Don't be bashful.
I could say very quickly, these are all great questions that we could tackle once we get the methods, right?
Is there anybody else who wants to tackle those questions posed by Dr. Sluka?
I'll just say that I think the fact that that we're not all jumping to answer the question is indicative that we don't really know cause, effects, and we don't really know the answers to those questions yet.
Thank you. If I could comment, I think Dr. Vining is exactly right. Of course, I have only studied this from the literature in this particular myofascial pain syndrome. But one thing we do know is that abnormal mechanobiology is at the root of many, many diseases. And that's been proven. Dr. Klatt referred to that. But it's just amazing. If you go and look up a list of the number of diseases that there are now that are thought to be rooted at least part in abnormal extracellular matrix mechanics or mechanics in general, it's absolutely amazing. Even something as strange as simple, I just use one example, polycystic ovary disease is a primary abnormality of the stiffness of the ovarian matrix. That's just who would have thought that? And liver fibrosis is thought to be initially start with an abnormal mechanobiology in the extracellular matrix, at least contributing to it, and many, many other diseases and things that do get close to the musculoskeletal system.
So, Len, I think Mr. Mulugeta had his hand up next, and then we can move to a question that I think Dr. Apkarian posed, and I'll see if Dr. Apkarian wants to ask it. But Mr. Mulugeta, what was the question that you had for the panel and for Dr. Sabri and Langevin?
So all these modalities for assessing elasticity or mobility of tissue is very interesting, and I think very useful for long-term applications in so many different areas. When it comes to actually, now let's say, if the intention is to also use it, let's say for diagnosis of myofascial issues of a particular area, and if you're scanning, let's say the rhomboid, right, and you're seeing tissue stiffness there or tension, how do you know that that tissue right there is actually where the problem lies, and not, let's say, the rotator cuff that's actually overactive and that's actually fanning out the scapula, which then applies tension onto the rhomboid. So I'm looking at it from the whole biomechanics standpoint, like, once again, whole body. This is at risk of possibly making you try to answer the previous question, but this is strictly from a myofascial perspective. Did that question
Does anybody want to answer that? I can say we're going to have a session kind of about this, session 5, where we're going to be looking at multi-scale modeling and putting this kind of in perspective. There may be some discussion of that particular topic. It's obviously a very difficult question that we'll have to get to eventually.
Yeah, if this is not an appropriate time to answer it, I'm willing to wait.
And if any of the panelists want to take a stab at it.
I would just say that I think that's a good question. The idea of regional interdependence has been around for a long time, that one part of the body can be affecting the other part, another part mechanically, and have an effect far away from where one problem can be. When we're looking at imaging in a particular area, I think there are all those possibilities. I don't think we've been able to. I don't think we could say that a problem in the rhomboid would relate to a specific problem in the shoulder, but it certainly seems like it could.
So I noticed that Dr. Apkarian, you dropped a question into our Zoom chat. And did you want to pose that question, or I can pose it on your behalf? Either way.
No, I'll jump in. Is that okay? Should I just?
Yeah.
Let me just jump in and interact with you guys. Anyways, I've enjoyed this conference. It's been very enlightening for me. I know very little on the topic, so it's all fantastic. And I mean, to me, I have this very interesting, I'm an engineering background myself, so I enjoy all these technologies being applied to the complex biology of myofascial pain, which I know very little about, actually. And my question is very much along the same lines of the questions that are being posed by both by Kathleen and the person after her. I didn't catch his name. And it's basically, I mean, it seems like the desire is to go to the clinic and make an application from these tools, while we really don't have the causal relationship established even. And yet there are amazing technologies here that one should start asking the questions at a much lower, mechanistic level. And so my very simple question that I was posing was, I love this MRE technology. It looked really fantastic. For example, if you just vibrate that fingertip, at the same time give them a painful stimulus, how do these shears and forces shift? Simply by the sensory motor loops that we know, that we have known for 100 years that interact with each other. So the system is not an open system, and it's a closed system, and it will interact in a complex way. So just the simple fact, do we even know the answer to that silly question that I'm posing, I guess? That's my question.
Thank you, Dr. Karian. Dr. Langevin, who should take that?
Well, yeah, I agree with you. I think that we have to be curious. When new technologies become available, I think it encourages us to reassess, first of all, what are the new possibilities introduced by this new technology? What you just did, which is think outside the box and say, oh wow, we could apply that to this. I mean, that's part of the fun of research, right? And so I think that the ultimate goal is understanding the whole picture, the cause, the effect, the etiology, the pathogenesis, the treatment. That's the big prize at the end, right? There's a lot of ways to get there. And by choosing to focus on technology development, methods development in this particular workshop, we're hoping this is going to open up all kinds of avenues. Some of them we probably not even thinking about. So yeah, so it's a nice idea.
All right, thanks.
So Alen, we have Dr. Wen Chen dropped something into the chat as well, and I see that her hand is raised. Wen, did you want to pose the question that you posted in the chat, and then Alen, you can take over the calling. The hands there.
My question might not be as relevant to the central theme of this session, but it was in response to one of the panelists' data, which seemed very intriguing to me. It was about adding infiltration. I'm just wondering, do we know, is there any evidence to talk about the role of fat infiltration in myofascial pain? And also, do we know what's the prevalence of MPS in aging? Is it more prevalent in older adults? If it does have a role, it might be more prevalent in older adults, given that the older adults have an issue with fatty infiltration.
So first of all, the prevalence of MPS in older adults. I think, would Dr. Sluka know this? Probably.
It was presented by one of the panelists, and I forgot which. Maybe it was Dr. Sergio Sabria.
I think the issue is all pain conditions are usually a little more frequent, and most pain conditions are usually more frequent as you get older, except for things like migraine. But I don't think there's really clear evidence that they would have substantially more than others. You certainly see it very commonly in young adults and middle-aged individuals. So I'm not sure it's that much more common in the older adult population. From my memory, is that your thoughts?
Yeah, that's what I was thinking as well, but I wasn't sure. But there's been a fair amount of talk, throughout both this session and the one before. Well, it's more than one before, but about the role of fat. And that plays in this, right? Of fat and also fibrous, and there's a relationship, right, between the two types of pathology, fibrosis and fatty, because there's an inflammation link between the two. So I was wondering if anybody has any thoughts about the mechanical properties of fatty tissue. Is this something that could be targeted more specifically?
I just wanted to make a short comment about that. I don't have the knowledge whether it is more prevalent in elderly or not, MPS. I mean, mechanically, what we have been studying with ultrasound waves about the fat infiltration is that the muscles are losing density. They are becoming more fat and less muscle. And this eventually as well leads to loss of strength. So there may be some interactions in the sense that the body posture is affected. Some movements cannot be done the same way. And I would guess, this is just a guess, that this could trigger some of these mechanisms. And I think my comment is more in the direction. I think presently we don't have really good methods for bedside monitoring of muscle loss. And I think it would be very interesting to add these kind of biomarkers to our tool set to be able in the future as well to link these different processes. And certainly elderly people probably have as well some possibilities that this degeneration of the muscles is going on, and therefore there may be some interactions.
Can I please make a comment about this?
Sure.
Hello?
Yeah, yes, so, Dr. Eamon had a comment afterwards, but please start.
Oh, sorry.
No,
okay,
no,
yeah. So I just wanted to say that, of course, fat infiltration that's happening then on the micro scale, right, within the image voxel where for which we determine the mechanical properties. And if you have a tissue without fat, then this gives you a certain stiffness. If you have the fat infiltration, this will be reduced in stiffness just because the shear stiffness of fat is not as high as of the inherent tissue. So just by that, you cannot directly differentiate it. But here comes into play what I tried to indicate on the first slide that I've shown, that when the mechanical properties using elastography are measured over a frequency range, then the dispersion, the frequency dependency of the complex shear moduli, they will depend on the ratio of the fat content and the inherent tissue content. So just by doing multi-frequency elastography and fitting the data to rheological models, where we then model tissues by basic rheological elements, like a spring. The spring could be the muscle, and the dashpot, the damper, could be the fat. We would be able to separate this.
That's great. Well, Dr. Eamon, and I was be interested to hear what Dr. Parker thinks about this.
Absolutely. Thank you. Yes, I would just point, I think that there is a whole ultrasound dimension to this, but I would say that if the goal is to measure fat, measure the amount of fat in a voxel or over a region and various tissues, I mean, there are extremely elegant and fast ways to do that with MRI, as Dr. Gold pointed out. I mean, that's a very easy, very, very well-developed technique to measure exactly, very highly accurately, the amount of fat that's present. However, if the issue is, has the mechanical properties of fat changed? Fat is one of the natural shear control mechanisms in the body, right? So around vessels and other things, that if you eliminate the adipose tissue around them, they will become quickly abnormal. And so so it's known that the mechanical properties of fat, there's emerging evidence that the mechanical properties of adipose tissue do change and are related to matrix biology. And I think that this would be an interesting area to explore whether or not there is abnormalities in the fat in some of these conditions. So I think that's another interesting research area.
Great. Dr. Parker, I was wondering if you had a thought about this question.
Yeah, thanks. Well, I think as the last three speakers have said very well, that there are very sensitive measures of increasing amounts of fat using either ultrasound or shear waves or MR and various versions of these. And so it's an important composition measure that I think we should study. And one other thing, going back to the earlier question about so many parameters, so many different techniques that someone raised, it's a very good question. I think that what we should keep in mind is that there is a kind of an evaluation process. I mean, that must go on and will go on. And the very intelligent people who are here today, you know, could come up with 20 new parameters, right? There is the bottom line is in the short term would be how much do those parameters change in with a certain pathology, and related to that, what is the effective treatment? Okay, so ultimately you want to have a non-invasive measurement for which the person says, yeah, after treatment, you know, my pain went from an 8 to a 2, and then this parameter, which is a repeatable parameter, also goes from an 8 to a 2. That's really what we're all, I think, that's a practical assessment goal that I think we all want to get to, basically. We're not there yet.
So you basically, yeah, so we're all looking after the perfect biomarker, right?
Right.
That relates with symptoms. And yeah, and that's one of the goals of this workshop, is to talk about, we have a shot on goal about this, right?
Right.
Or a few, hopefully.
20.
Yeah. Do we need, Catherine, do we need to be going to the
Actually,
Q&A?
I think we've given ourselves a few extra minutes. If you'd like to take some of the hands in order
We have more hands. Oh, Dr. Chen has a hand up.
Yeah.
Thank you. I just want to make a couple of general comments related to the previous speaker's slides. One is that the muscle is an active organ, and therefore it's very important to make those elastography measurements when the subject is in a consistent and relaxed position. For example, if you have, I think the ideal position probably will be lying down, but if you have someone sitting in a chair, if the shoulder gets stiff or tense, that can change the measurement results a lot. And also, Dr. Parker shows some slides about, you know, passive, when you're stretching the muscle, or when you change the orientation of the measurements, that all change the results. And Dr. Sikar shows the slides too. So we have to be very mindful about this. And another comment is that I think Dr. Lasman, you also mentioned about the limitation of 2D imaging for shear wave elastography for ultrasound. And I think that's a challenge for ultrasound, especially for if we're trying to look at the trigger points, because you know, sometimes we can see them in BEMO ultrasound and therefore use BEMO for real-time guidance. However, sometimes it's difficult to see them in BEMO ultrasound. And therefore, I can see that two solutions may be possible. One is to go for 3D. And I think supersonic imaging has a commercial solution where they have a mechanical sweeping probe to allow 3D shear wave elastography. And another possibility would be to use you know, mechanical vibration and use 3D detection to allow 3D elastography. That's otherwise, because the radiation force-based ultrasound methods, they are limited by the heating and the FDA limits, output limits, and therefore the frame rate is generally very limited for 2D imaging and not real time.
Thank you.
Therefore, a possibility.
Thank you. Do we have, Catherine, do we have time for a couple more, or do we have to? We have Dr. Vining and Dr. Myers.
I think we can take a couple more and then we'll move to the open audience Q&A.
Yeah, let's try to keep our comments brief so we can get more people in. So Dr. Vining?
I had a question for Dr. Amen. In your presentation, you showed vibratory stimulus to the digits and to visualize myofascial planes in the forearm. So in my understanding of MR imaging, this is sort of a technical question. Movement typically degrades an image, and is that characteristic what allows you to visualize those planes because of the movement induced by the vibratory stimulus, essentially showing the dark lines? And then sort of a follow-up to that, do you see any potential application of using that type of technique beyond an extremity, maybe around the spine in some way?
Thanks for the question. The technique that allows us to measure the motion, we really are measuring motion, observing motion with MRI as opposed to anatomy. And it's called a phase contrast technique. So instead of looking at the magnitude of the signal that's coming back to us, we actually look at something called the phase of the signal. And that's affected by the presence of motion. It's a phenomenon that's long been known, but wasn't heavily used in MRI. It's used to measure blood flow, for instance. But in the case of MRE, because of the way, there's a trick that we use that allows us to image cyclic motion. And in fact, we can see vibrations that are as small as the wavelength of light, or even the fraction of wavelength of light. And that really has not been fully explored, the potential for that. And that's why I'm a bit excited about having been put onto this idea about the importance of seeing myofascial interface and characterizing them. I think there's a lot of potential there. Your second question, just remind me again, what it was?
Potential application around the spine.
Yeah, I think this technique, if you looking, so again, you're putting in shear waves, very small amplitude vibrations that are only microns in amplitude, but because of the sensitivity to motion, you can see sites where there is shear. So yes, so either you could put just simple mechanical waves in and observe this, but you could also apply cyclic motion to tendons or fascial planes and see how this would all be something to be explored and to be moved forward. I just make one quick comment because I think the thing here is that all of these, we have these ultrasound techniques, we have these MR techniques, they're all very, very sensitive. And I think the exciting opportunity here is really on the research side, and especially in longitudinal studies where we have these highly precise techniques looking at how a change would occur with some kind of intervention in these things. So things like fascia, looking at muscle stiffness, but with some kind of intervention in between. We haven't really pursued that very much in this area, I think.
Thank you. Dr. Myers?
Yeah, sorry, real quick. How, and I'm just, this is open to anybody who, just in general, the panel, how do we, I'm trying to still box in like, who is the typical myofascial pain syndrome patient? Like, is there something like once you reach a certain age, you're not at risk? Is it a cumulative, occurrence of injury throughout your entire life? And then it like, how do we know who these people are? Because it sounds like young adults get it. What do they look like? Or like, is there any common themes to like when this happens? And then just as a surgeon, there's definitely something about fat. There's people that have this very dense fat when you operate on them. They could have the same BMI and truncal obesity. And then there's other people that have this very kind of amoeba type fat. And I don't know if that correlates with any sort of demographic or clinical history that makes any sense with the myofascial pain syndrome. But there's definitely differences in the density of fat around people's bodies, if that makes any sense.
Well, I like the term amoeba fat. That sounds like it.
Well, it just falls away from the body. I mean, literally, there's no substance to it. I mean, it's very loose. It's very, and you can mobilize. I mean, it doesn't get in the way. And then there's other people that have this just very dense and mobile fat that is just, it fights you the entire surgery, trying to put a hip or a knee in somebody, mostly the hips, but it just.
And is this more fibrotic, do you think? Or
yeah, that's what I mean, like the matrix, the structure, something about it is different. It's very thick. Like when you grab it, it's dense. So I don't know what that means, but it'd be interesting to look into it.
Fascinating. Anybody has a thought about that? Sounds like it could be quantified. I mean, it sounds like a very interesting observation. I don't know the literature on this, but this is a kind of observation that could, be, if you could show that your observation, your visual observation of this behavior of the fat could be quantified with some kind of technique. Sounds like it shouldn't be too hard if you can feel it and see it.
Oh, yeah, you can. Maybe Dr. Parker and I will team up. We're both up here at Rochester.
I think ultrasound would be a great way to look at it, but
Yeah.
but again, I think there's emerging evidence about this, especially in metabolic disease. And we actually have protocols that are underway right now to look at adipose tissue and in various individuals to characterize the mechanical
Oh
properties.
yeah, when you operate on somebody that's a couple years out of gastric bypass, everything's wrong about their tissues, the skin, the bone, and they have that amoeba, very loose fat. Yeah.
Well,
just very quickly
Dr.
comment
Barb, you have
yes, in fat in bone at least undergoes a big change after fracture and or with aging. And the main change is a loss in stem cells and hematopoietic stem cells. And those are the ones that are releasing cytokines that would do all sorts of things of repair cytokines as well as inflammatory cytokines. It could be quite an interesting pursuit for you guys. I think you should do this.
Yeah, that was another thought too, like how do we differentiate like all this from the normal aging process? I mean, it gets back to the first point, is it like, do you reach a certain point where if you've never had myofascial pain syndrome, you're probably never gonna get it? You know, is it 50? Is it 40? I don't know.
So Dr. Sikdar, do you have a thought?
I was just going to say that to that point, I mean, when we look at these patients, a lot of them have very abnormal looking muscle. You know, the muscle appears just really bright, and it seems consistent with what you are describing. And not all of them necessarily have myofascial pain. So even some subjects who have no pain, their muscles just look very, very different. So we have not systematically quantified this, but I was just going to point out that ultrasound is sensitive to picking up a lot of these kind of changes in different types of tissue composition.
I think, Ellen, right before we go to the questions and answers from the audience, shall we hear from Dr. Blumker, Sylvia, who's had her hand up here?
Yes, of course. Dr.
Sylvia?
Blumker.
Yes.
Hi, can you hear me?
Yes, indeed.
Hello, sorry. Yeah, no, I just wanted to say I've enjoyed this whole day. I've learned a lot from the standpoint of somebody who thinks a lot about, especially muscle tissue mechanics and physiology. I found this fascinating, but I'll caveat that with I don't know, pretty much everything I know about myofascial pain I learned today. But one thing I was interested in, how much do you all think is beneficial to really think about comparing and contrasting the changes in structure and mechanics and physiology in myofascial pain syndrome versus other muscle disease pathologies? Because many of the things we've talked about today you see in lots of other conditions that may or may not have pain associated with them. So I think that's part of the kind of quandary, but I wonder if we could flip that around and think about how to harness and leverage these comparisons to start understanding kind of which aspects of what we measure are byproducts of our compensations for having pain versus sources of pain versus somewhere in between. So just wondering what you think about that sort of comparing and contrasting.
That's a nice way to put it. I think, let's see, first of all, does anybody want to speak to that? It's a very good question.
I'd like to say a couple things. So it's a great question because we really don't know, just because we see something in the tissues, that it's the driver of the actual pain. And I think I kind of was getting at that earlier with my previous question, which came first and which is a consequence, which is a driver. Is this just something that happens and it's normal aging process and we don't know what's going on, and it has nothing to do with it? And so I think you have to design experiments around that, that look at healthy individuals and follow them, much like Bill Maxner has done in TMD, and followed people who develop it and look at what was different about those people who develop it versus they weren't. I think you have to design intervention trials to see if you modify those things, does that also modify the pain? And then I think we have to think about myofascial pain from a different perspective. We're talking about it as if it's one thing and there's only one thing. And it's just diagnosed by symptomology and I can palpate something. And there may be multiple ways that we get to that point. It may be multiple different pathologies and they may not be the same one for each individual. And likely some genetics may play a role in who responds to what and who develops what. So just keeping a broad perspective, I think, is important when we start thinking about this.
Yeah, thank you for that. Well, that's actually what I was trying to get at. If you recall in that introduction slide where I had the myofascial tissues and I had all the question marks around it and all the different pathophysiological hypotheses. And I think, you know, it's likely, I think I agree with you that it's probably not homogeneous. There's not one way that you get to this. There may be many different possible routes to this end product of dysfunction and pain. So it's good to keep that in mind. Yeah, thank you.
Thank you, Dr. Langevin. I think we're going to move now. We have a few questions from the audience that have come in from the folks watching on videocast and also our Zoom attendees. So I'm going to start with this one. Is there potential application of elastography to intra-abdominal or intrathoracic adhesion and adhesion membranes? So who would like to tackle that one? Ellen, who do you think?
Either Dr. Eamon, do you have any thoughts about how you could apply some of this to detect with methods you described to detect adhesions in abdominal? Probably.
Yes. So adhesions are a really big problem for anybody that's had surgery in the abdomen. They develop these adhesions, which then become points for volvulus or twisting or bowel obstruction. It's an awful situation, and finding them is actually quite tricky. Imaging is difficult, and in fact, a few years ago we did do some studies. We need to go back to them. There is potential where you could put in fill the abdomen with vibrations, and then look for shear interfaces, and wherever you see a loss of that shear interface, you might suspect there's an adhesion there. So this is a potential application. It hasn't been developed. Some work needs to be done in that area. I'm sure similar technology, things could be looked at with ultrasound as well, though, I think, as well.
Yeah, what about using the ultrasound intra-abdominally? Dr. Parker, do you have it? Has that been done to look for adhesions like around the liver, for example, or in around bowel?
There have been elastography applications to the bowel. Dr. Rubin at Michigan has done a lot with colorectal cancer and other abnormalities. But I think when you're talking about 3D large volumes and the assessment of large volumes, particularly where there might be gas present, then MR would have the advantage, definitely.
Yeah.
So the next question that we have is, what about the emotional somatosensory connection with the various pathologies, such as the PCOS mentioned prior?
Well, I don't think this is the right panel for this question.
It may not be. It may not be. But these are the questions that have been coming in.
I would say this would have been a great discussion for this morning's clinical session, or for our sort of wrap-up session at the end. I would say let's
push that there. So here's a question that's come in. How do you exclude signal from blood movement versus myofascial interface movement with phase contrast MRI? This is another question that's come in.
Okay, I guess Dr. Eamon?
Sure, very briefly. So the thing about blood flow is that over the time frame of a measurement, it's unidirectional. So in other words, it's not changing in direction. And what we do for MRE is we make the motion sensitivity sensitive to exactly the frequency of motion that's being applied. So it's like tuning an FM radio to the right station. If you're at the right frequency, you'll detect it. Everything else you reject. So that's my answer to that question. Good question, but that's the technology behind it.
Okay. And then here's one that we're going to take that I think is a little more general. It's the person is asking, are there any myofascial pain syndrome protocols at NIH? They allude to some issues that they've had with this condition over the years and still experiencing pain. And then they conclude with the question, how is this condition being treated today? So this is a more general question.
Okay, so protocols at NIH there, I guess they're talking about at the clinical center?
Potentially, yes, I'm assuming.
Yeah,
so.
not to my knowledge. In terms of the treatment of myofascial pain syndrome, I guess we could defer to perhaps Dr. Sluka.
Dr. Sluka, would you like to unmute and any thoughts?
Yeah, so right now, I don't think it actually has changed dramatically over the years. But the main treatments that work the best with the greatest amount of evidence are injections into the trigger points with things like lidocaine are better than things like dry needling, but both are effective. And then they have to be followed up with exercise. So they'll work temporarily, but if you don't stretch and you don't strengthen the tissues around it, then people don't maintain that long-lasting effect. Right now, there's no pharmaceutical treatments that are being used regularly that show clinical evidence. I can't even find studies that have been done on most of them. While you might take an NSAID, it doesn't necessarily have a indication for that. So the most of the treatment is wrapped around doing trigger point injections and following that up with really following it up with some soft tissue work, with massage and exercise.
I have a follow-up question. Yeah, well, that makes perfect sense, but I have a follow-up question to that. We've been talking a fair amount about inflammatory processes throughout the day today. Mm-hmm. Just curious about whether NSAIDs would be effective there if indeed inflammation is an important part of this pathophysiology. What are your thoughts on that?
So that's a question of whether or not it's inflammation, or are there things released by immune cells that sit in the tissue that happen to be inflammatory cytokines and substances like that, like IL-6 and TNF-alpha, and the immune cells that sit in the tissue, which they sit in the tissue regularly. There's macrophages that sit there and police the microenvironment. And based on what phenotype they are and what their process is at the time, they release certain things that either promote our recovery or promote pain. Mm-hmm. And it's not clear that that's a true inflammatory process as much as that could be just a change in the milieu of the microenvironment. If it is inflammatory, I don't think it's big. And I think most people would probably agree we're not looking at a big inflammation, but maybe a localized increase in inflammatory substances. But they might work. It just hasn't been well tested. Mm-hmm. And we don't really know that. We do know that exercise can also change your immune cells at the site. So just exercising muscle can change your immune cells from releasing inflammatory cytokines to anti-inflammatory cytokines. So that alone could change that trigger so that over time, now when you move that joint, it's less painful and maybe even a little on the analgesic side.
Yeah, inflammation is certainly complicated. Dr. Barr, you have...
And dampening inflammation in totally is bad. Like Kathleen was saying, there are some attributes of some of the repair macrophages, but if it's autophagy, then you actually need to clear that out. So some inflammation is needed and phagocytosis is needed for repair processes to begin. And then, of course, there's the problem with NSAIDs given too long. There are some studies that suggest there are negative attributes on muscle repair. And then in my animal model, there was a problem with the anti-inflammatory dose of ibuprofen dampen the animals' sort of like sense of what they should and shouldn't be doing. So they went through a couple of weeks of doing great. And then it was terrible. It masked the pain, and they had more damage at the end from which they did not recover.
Wow, that's really interesting. Dr. Tick?
So as a clinician, I would agree with some of what's just been said. Anti-inflammatories, the drugs, are not very useful. For one thing, they have a rebound phenomenon. That's been well studied in headache, but I've seen it in myofascial and musculoskeletal pain as well. So you get rebound, which means you become dependent on the medication, which does have negative side effects, as Dr. Barb just mentioned. Additionally, there is very good research on using an anti-inflammatory diet that will address the type of inflammation that Dr. Sluka was mentioning. And so anti-inflammatory diet is something that works very effectively if people will stick to it, and usually they need some coaching. Exercise, of course, is extremely important. One of the anti-inflammatories that I actually like to give people is curcumin, turmeric, which has known anti-inflammatory properties. It's been demonstrated to have effects on the COX-2 pathway at 6 different levels, as well as other polyphenols, which are anti-inflammatory as well, without any of the adverse effects. So you don't get delayed healing of tissues using those. And then looking after the other major determinants of health, such as sleep, stress, those things can be extremely helpful. I tend to favor dry needling over injections, and there are some studies showing that dry needling can be superior to injections, partly because you can probably treat more areas. And with a dry needle, if you're using an acupuncture needle, which most of us do, you can treat certain areas where you wouldn't want to go with a hypodermic needle, with a cutting edge needle. So you can do a more thorough treatment.
Thank you, Dr. Tick. I think, Ellen, at this point, we've reached 5 p.m. So it's time actually to adjourn our day. Before we adjourn, any final thought you'd like to share, you or Dr. Sabri, to bring session 3 to a close and this day to a close as well? Ellen?
Well, I think we had a really good day. I really enjoyed all the sessions. I think this is so far what we were hoping this workshop was going to do, which is to stimulate some excellent discussion based on some very substantive presentations. I really look forward to seeing what happens tomorrow. Marav, do you have any comment?
Just wanted to thank all our speakers and panelists for today. It was just absolutely excellent.
Well, I want to thank everyone as well, and I particularly want to thank those attendees who've hung on with us until 5 p.m. and those who might be watching on videocast. Thank you for your questions. Obviously, we had a lot of them, and we'll do our best to answer them, even if it's post-meeting. So come back tomorrow. We're day 2. We have some more wonderful sessions for you, and we'll be starting at 8:45 a.m. Eastern. We'll be on NIH videocast and right here in Zoom again. So please join us tomorrow. And thank you so much to everybody for being with us today and for our wonderful panelists that we've had today. Thank you, Ellen, and everyone, and all of the planning committee members. Bye-bye.